Hello, everyone. Good morning. Thank you for joining us at the World Health Summit Regional Meeting. I'm Ragini Bordloy from Common Health, and it's an honor to moderate today's panel, Reimagining Access, Advancing Safe Abortion Through Technology in the Global South. I was really apprehensive about people not turning up because it's way too early in the morning, but at least some of you have, hoping some other people also join, but glad you're here. Excited to have this conversation. I'm really glad to have this opportunity. Rarely do we have an opportunity to see sexual and reproductive health and rights centered in health discussions. They're relegated to the margins of policy and practice, yet SRHR remains the bedrock of dignity, equity, and progress. Centering SRHR in health frameworks is hence a moral and practical imperative to forge inclusive health systems. Now let's cut to the chase, okay? There isn't a time more urgent than now to talk about and advocate for safe abortion access. It is a life-affirming, life-saving choice. Abortion is healthcare. Abortion is a human right. But it is weakened by several persistent barriers and challenges in several parts of the world. And these battles disproportionately affect marginalized communities, women, queer trans individuals, adolescents, religious and caste minorities, and especially those in low resource settings. Abortion especially remains critical in the global south. It is a matter of justice, equity. The barriers to access, especially in this part of the world, is multifaceted, ranging from legal restrictions to pervasive abortion stigma. And these challenges require bold, transformative approaches. And this is where the digital comes in. I was attending a lot of panel discussions yesterday around digitalization, and I think one key point that emerged is that introducing digitalization in broken systems will not have enough yields, right? So we need to also address this brokenness that is inherent in SRHR landscape. Also, like while we talk about this, privacy, confidentiality, and security remain critical considerations, especially where abortion is stigmatized or criminalized. Surveillance and censorship also add new layers of vulnerability. That's why we are so excited for today's panel discussion. Our distinguished panelists bring crucial insights from Malaysia, the Philippines, Nepal, India, and beyond. Their expertise in movement building, advocacy in restrictive settings, and stigma reduction and digital innovation will guide us towards collective strategies and policy recommendations. And thank you for being here. Thank you for being here. Please allow me to introduce everyone. First, our chair, Dr. Kalpana Apte. She's a medical doctor with her Master's of Public Health and Human Sexuality. She is the CEO of Family Planning Association of India, one of the largest civil society organizations working on SRHR. She is also a well-known expert in the field of SRHR and family planning. Thank you, Dr. Apte. And our panelists, our first panelist is Anjali Shenoy. She is a program manager at the Asian Pacific Resources and Research Center for Women, Arrow, and she heads the domain on monitoring and evidence generation. She is an intersectional feminist with over 15 years of experience in research and policy advocacy in the areas of reproductive justice, public health, human rights in India. Welcome, Anjali. Next up, we have Debanjana Chaudhary. Debanjana has over 22 years of experience in advocacy and policy, strategy, management, development, communications, humanitarian and crisis management and communications, branding, and strategy development, working in feminist cross-movements of SRHR, climate justice, and gender equality, among other key themes. She has also led an Indian coalition on safe abortions and gender equality, like the Pratigya campaign for safe abortion, led programs and developed roadmaps for convergence of energy, livelihood, climate, and SRHR. Welcome, Debanjana. Next up, we have Praveena Bajracharya. Praveena is the Regional Director for Asia at the Center for Reproductive Rights. In this role, she leads the center's work in the Asia region. Praveena is a human rights lawyer with an extensive experience in human rights monitoring, analysis, advocacy, capacity building, and strategic partnership. Her area of expertise includes rule of law, gender-based violence, access to justice, transitional justice, and reproductive rights. Welcome, Praveena. Our fourth panelist is Dr. Sucheta Dalvi. She is the coordinator of Asia Safe Abortion Partnership, which is a regional network of safe abortion rights and has members and partners in over 25 countries across Asia. Unfortunately, she hasn't been able to join us due to an unforeseen circumstance, but she has sent a recorded message and very graciously done that. I do welcome her as well. With that, just thank you for being here, and I would pass it over to Dr. Apte for the opening remarks.
Thank you, Ragini. Good morning, everyone. We are here, this is our second day, and yesterday we saw, and you alluded to it, there have been very minimal conversations around sexual and reproductive health, rights, and justice. Today also, the timings of the sessions, yesterday we had a session, today we have this morning session. So now it's a very clear indication that where does the SRHRJ stand in an overall larger health context and the consciousness of people who manage portfolios and plan programs and manage knowledge. Taking from there, let's talk about today's issue, which is safe abortion. Now, safe abortions in India and in Nepal have been legalized. Even though there is an overarching criminal law, and Praveena will talk about it, so access through legal rights is quite ensured or should be ensured in these two countries apart from others. However, we know that in itself, a legal right does not translate into an actual right on the ground for all people, all pregnant people who would like to make a choice of not continuing that particular pregnancy. Policies and programs and law doesn't always linearly progress. And if you bring access as or result of technology, and you look at all other medical thematic areas, the medical issues have really made big progress. There are now more medication, lesser surgeries. There are so many things which really are becoming more and more medicalized. Self-care is a very real and a very doable option for people. COVID has taught us that people really would like to take care of their own health, and technology has made it possible for people to be able to monitor their health, to be able to deliver their own health care to themselves through self-injecting options and to monitor whether their blood sugar levels are normal or not. And within this mix, now taking a medication that can really take care of your decision, or you can help your decision in taking abortion as a choice, is really something that's a no-brainer. However, apart from safe abortion, there is hardly any other medical condition that is regulated. And therefore, however much the law supports, however much the technology may support, abortion is still going to be inaccessible because of barriers on the ground, which are basically social, cultural, and also opposition to abortion. And that's the extremely unfortunate context in which this conversation is going to happen. The more we progress, the more we grow, the more technology advances, the more digital pathways open up for people to access their health care in a very anonymous, private, and a confidential way, the more restrictions they continue to be there, because again, the very thing that makes it possible for women and pregnant persons to access abortion is also the very fact that you cannot provide it through telemedicine, in India at least. It's not possible because it is protected by the MTP Act, and that act doesn't allow telemedicine option for medication abortion. So, today's conversation, let's reimagine what at various levels we need to do. And it's not a one sided conversation. We will have a dialogue, whatever views and ideas and thoughts and feedback that you may have or questions. I think they are, let's have a conversation on that. And thank you, Ragini, for inviting.
Thank you, Dr. Kalpana, for the compelling remarks. And in a way, I'm now glad that we are few of us, so that there's a safe space for us to have a dialogue, and we can, like, use this space to actually reimagine access. Um, my first question would be to Anjali. Anjali, with your work with Arrow and Sage, you have worked extensively on leveraging digital tools for advocacy, capacity building, and cross-border solidarity in the safe abortion movement. With the kind of barriers that Dr. Apte has foregrounded, can you tell us how digital tools and platforms have been instrumental, and what kind of strategies that SAGE partners have also used to ensure digital advocacy remains intersectional?
Sure. Thank you, Ragini. Thank you, Dr. Apte, for setting the stage for what we are discussing today. I just have a brief, a few slides just to show what I'm talking about. Yeah, the next slide. Okay, so as both Ragini and Dr. Apte pointed out, to say that we are living in a complicated world is an understatement. There are multiple crises going on at the same time, and the result of it all is the biggest impact is felt by women and girls in all their diversities. There is an absolute deprioritization of our health needs and our rights. And in this context, the women's movement and the SRHR movement has felt the need to move towards a more justice-oriented framework in our work to ensure that we are approaching everything that we do from a holistic manner. We are thinking about the different intersectionalities that are at play when we are talking about health and rights and gender, of course. Yes, thank you. And within this reproductive justice approach, I think the most important and the central force and strategy that we have seen to be working is to connect people, to connect organizations, to connect movements, networks, bring them together to talk about what they are doing, the challenges they are facing, and strategies to move forward. Um, Within Arrow, we have been part of several networks. We have been part of founding teams of several networks. There is, of course, the Safe Abortion Advocacy Initiative, Global South Engagement, that I will be talking about today. There is Kaleidoscope, which is a fairly nascent coalition that has just about started, which is a collective of trans-regional feminist organizations working on health system strengthening for SRHRJ, particularly abortion rooted in Asia and Africa. There is the Right Here, Right Now network that champions the rights of young people in all their diversities. And there is the Asia Network to End Female Genital Mutilation and Cutting, and the Asia Network to End GBV. Today, I will focus on the SAGE, which is the Safe Abortion Network. So SAGE started off as a part of a small project, not too small. It was a 5-country project with 7 partners that was being conducted in the Asia region. We have our partners here today as well. In India, our partners were Common Health, and in Philippines, WGNRR, who Debanjana is representing. We had Naripoko and Bapsa in Bangladesh. We had BBC in Nepal, and RAC in Cambodia, and Arrow, of course, which is the regional partner. So it started off as a network to bring these countries together and to bring these partners together to talk about the different strategies that they were using during the project. This was in 2018. Today, we have expanded across the global south, and we are close to 300 members. Of course, in the world of Instagram and TikTok, 300 is nothing, and I know, I understand that. But in the world of activism, where there are several challenges, risks to security, safety, 300 is a big number, and I will talk about those challenges later as well. Today, the network is spread across the Asia Pacific region. Of course, maximum number of members come from there because that's where it started. We have a huge number of members from the African region and the Middle Eastern and North African region. And slowly, we are also getting in members from the Latin American region. We've seen that following the Green Wave, which led to immense successes in the Latin American regions, the Latin American activists are now reaching out to other activists across the global south to share their strategies and also to think of ways to keep the successes steady and sustainable. And so we've also seen quite a few Latin American activists also join the network. Now, coming to Ragini's question about what are some of the key strategies that we have been using. Also, just to mention that since the pandemic, so that is since 2020, SAGE has gone completely online. The only physical meeting that we have had has been one meeting at the time of the ICFP conference in 2022, and whichever members of SAGE were present at that conference came together to have a convention. But apart from this, we are completely online at the moment. All our events and strategies take place on the digital platform. So what are some of our key strategies that we look at? The one that we have seen that has got us the biggest success and that keeps members coming back to the network and attending events over and over again is this cross-regional linking and learning dialogues that we are facilitating. These dialogues are on a range of issues. So it could be on strategies that certain organizations are using and they want to share with the rest of the network. It could be on issues like reproductive justice that members feel the need for more capacity strengthening on. It could be currently a lot of our members are facing the biggest challenges that they are facing is with opposition, anti-rights, anti-gender opposition. So the next upcoming linking and learning that we are having is on monitoring of opposition and dealing with the challenges that these oppositions throw at us as networks and as organizations working on safe abortion. It could also just be cross-regional dialogue to understand the status of safe abortion in the different regions that we are coming from. We've seen, just as Dr. Apte and Ragini mentioned also, even within the Asia region, there is so much diversity in the challenges that we face. Nepal and India has a legally conducive law, but with challenges to do with stigma and poor health infrastructure and systems. But then on the other hand, we have the Philippines and Indonesia where there is, the law is, abortion is criminalized and is illegal in certain contexts. So even within the regions, we have activists and advocates that are facing very diverse challenges. But when you come together, you learn from each other and you learn to adopt and adapt strategies to the context that you are in. So linking and learning is one of our key strategies. It keeps people coming back. We try and do at least 4 or 5 linking and learning sessions in a year. Also, the demand and needs come up from the network members itself. And we are also moving towards decentralizing the network itself, where members can take on organizing these linking and learnings also. So it does not rest with the founding partners like WGNRR, Arrow, Common Health, etc. But actually members can come up and say, we would like to hold a session on such and such a theme, and one of the partners will support the members in organizing these sessions. These sessions happen on Zoom. They are closed sessions because of safety, security, privacy issues. Also, just to backtrack, I wanted to mention SAGE itself is a closed network. So when anybody signs up to SAGE, there is at least a 2-step verification process that one has to go through. So the person or organization has to be recommended by one of the existing members. As well as we also do a little bit of a background check to make sure where these organizations are coming from and what are the issues they are working on. Similarly, when we have these online events, people register on the Zoom platform, and we only accept the registration once once we can cross-check that they are actually SAGE members. And so it creates a safe and closed space for this dialogue to happen in an open and liberal manner. Sometimes these events are opened up to a larger audience, and that is during the campaigns and online events that is the next strategy I'm going to talk about. So we try and conduct online campaigns around certain key dates. So September 28th, which is the day for safe abortion, May 28th, which I'm sure Debanjana will talk about, that is coming up, March 28th, which is the Global Day to End Stigma for Safe Abortion. So we try and have events around these dates. These are online campaigns, and these are opened up to all. The network members are informed in advance that this is an open session, so they can choose whether to attend or not, and whether to keep their identities anonymous or not. The other strategy that we use is to make collaborative statements as a network at global advocacy spaces. One of the space that we have steadily been using is the Human Rights Council. And every time the HRC meets, the UN HRC meets, we try and send in a statement on abortion and the status of abortion and decriminalization to the HRC within the themes that they have. These statements also are typically drafted by one of the partners and then shared amongst all the network members, who are free to give in their inputs and suggestions, and the statement is accordingly then rewritten and redrafted and finalized based on all the inputs. And lastly, the last strategy that we use is resource sharing and creating tools for evidence generation. The one on the screen is one that has been done by Common Health. Similarly, other network members, as and when they come up with resources or reports, these are shared between the network. We also have a SAGE website where these resources can go up if the members consent, because again, there is a big issue of security and safety. And we also come up with tools to enable and build capacities of the members. So we already have a tool on which is called the Advocates Guide to Safe Abortion, and we are currently in the process of developing an evidence generation guide. So how to use evidence, how to generate evidence, how to do research, because what we've seen is all of us do research at the base of all our work. This research, unfortunately, does not count as research in academic circles and in circles like this, because it is research that covers lived experiences of women and girls in all their diversities. It is research that is very often community focused and small, and hence is usually not accepted. So I'm finishing. Yeah. So so we're also creating a tool that will build capacities on how to kind of package this evidence that is being generated at the ground level and to be used for advocacy. So yeah, these are some of the key strategies that we are using. I'll talk more later. Yeah.
Thank you, Anjali. Definitely, it highlights how social media and even digital platforms can aid in the decentralization of the movement. But also, since you have also foregrounded some of the barriers, right? I want to ask Debanjana, like working in a restrictive setting like Philippines, like how has been your experience and drawing on WGNRR's work? What kind of, can you elaborate on the role of social media in this?
Absolutely. Thank you so much, Ragini, for the question. Thank you, Dr. Apte, for chairing this and for setting the context, and Anjali for the brilliant explanation on what the SAGE network does. I'm Debanjana, and I'll start a little bit about what is Women's Global Network for Reproductive Rights. We started around 40 years ago, and it's a feminist setup. So WGNRR actually started as a feminist movement in the Netherlands during the suffragette, and it started when contraception was, and especially tubectomy, was being popularized in the global south. So some activists, feminists, they got together and they understood that, tubectomy is not something that can be coerced and should be coerced, which was at that time happening in the global south. So they got together, and very quickly, though it was a global north movement, their realization that the power lies in the south, the movement completely translated in south, and it started its home base in the Philippines. And why the Philippines? I'll share a little bit about Philippines and the political and the SRHR context over there. Abortion is completely criminalized over there, and any abortion seeker or any abortion provider can be imprisoned up to 6 years over there. But the hypocrisy is that Philippines has one of the highest number of teenage pregnancies in Asia. How does this happen? This happens because there's a complete breakdown over there in terms of access and information. Young people do not have access to comprehensive sexuality education. They don't have any access to contraception. Anyone under the age of 18 needs parental guidance in order to access contraception. But if they are married, they can access contraception. So you can imagine the hypocrisy. So you can get married at 16 over there. So the legal age of marriage, though it's 18, it can be recognized in 16 over there. But you cannot, if you're a single person, you cannot access contraception. The moment you get married, you have access to contraception as well as abortion in terms of post-abortion care. So what happens to a person who tries to get abortion care through the lens of post-abortion care? So now post-abortion care is available in the Philippines. So if an individual approaches for post-abortion care in any medical facility, the individual is entitled to get the post-abortion access. But the provider over there, the midwife over there, also has the power on this person to report about this person. So reporting happens quite often over there. Abortion, the lens of SRHR in Philippines is quite biblical in nature. It has a strong Catholic base, and that is where it stems, where religion and health conflates each other, where religion is so involved in laws and policies that it impedes access to safe abortion, SRHR services, as simple as information services on SRHR, including contraception services, including comprehensive sexuality education. Very recently, we had this bill called the Prevention of Adolescent Pregnancy Bill. So this bill was introduced in 2022 by the activists in Philippines in the Congress. It was passed in the Congress very easily because we were just coming out of the pandemic. So people understood necessity, and there was a huge digital and an offline mobilization. So it was kind of a mini green tide wherein thousands of Filipinos and Filipinas were on the streets, and they were all around the Congress, and they were making demands. Then what happened? Last year, it came to the Senate. And this year, Philippines is going on elections. So in a couple of weeks, they are going to vote. So the same congressmen and congresspeople who had voted to pass the bill earlier, they have now retracted their statements, and there was a huge misinformation campaign. They were the same people who came out and said that, no, contraception care is talking about safe abortion, so we need to alienate it, we need to stop the bill, the PAP bill. So this June is the last time when the PAP bill can still be introduced to the Senate, and we are going to push for it. But in case it does not pass in the Senate, it means that we go back to the drawing board. So it gets nullified, the bill. Now, what do you do in a context like this? So there are many providers, there are many organizations like Women on Web who are providing safe abortion services, some medical abortion care, counseling, information digitally. Is it accessible in Philippines? It is very hard to access that information. Though Women on Web is one of our major partner and ally in this issue, but they are also not able to, break the chain that is there in order to reach the individual. So how do we do it? We, like in India, we also have a Philippine Safe Abortion Network. It's a network of around more than 500 activists who are working in the issue of SRHR, senior feminists who have been working since the inception of ICPD. And what does WGNRR do in that case? So if we get any information about somebody wanting to access safe abortion services, we then vet the person. We have steps of verification, and then we connect them to a safe provider. Now you would ask, why the steps of verification? Because it delays the process, right? And we all know here how each day in an unintended pregnancy matters to an abortion seeker. But it is very important for our safety. We cannot compromise the network, because the network is a very closed group over there, and we are all women human rights defenders. And many of our women human rights defenders are currently living in asylum in other countries or are rotting in prisons. So that's the context that we are operating in. But that does not, demoralize us. We are very strong on social media, digital activation. We are working across 137 countries. That doesn't mean that we have offices there. We have offices only in the Philippines and Tanzania, but we have our strong partners, some of them who are here. And these are the partners, individuals and activists and WHRDs who take the mission forward, who make it accessible for us. WGNRR co-leads the March 28th campaign with Inroads, and the March 28th campaign is all about destigmatizing and decriminalizing abortion. So in contexts like Indonesia and Philippines, we make the ask of decriminalization, and in other contexts, we make the ask of demystifying misconceptions about safe abortion in general. May 28th campaign is all about action on women's health, and we co-create, co-lead that campaign with over 80 organizations. So we had, so far what we have done is, this year we have had 2 global consultations already. One was held on earlier this week for Asia, Pacific, Oceania region, and yesterday we had our global consultation on the western part, including Africa, MENA, SWANA, Europe, Latin America, and Northern America regions. And we had around 35 organizations participate yesterday, and the day before around 20 such organizations. So all these organizations coming together shows immense courage, immense strength, and that is where we draw our feminist passion from. It means that all of them agree to bring in that unified collective voice of our bodily autonomy, putting our choice forefront, making sure that the choice of the individual in all its diversities are accepted, and there is space for that. In our September 20th campaign too, that's also something that WGNRR leads globally, and the content is co-created, co-designed, just exactly like the May 28th. So there is a microsite of May 28th, which you can go to, you can visit, and you will see the host of partner logos that are there. WGNRR definitely takes the lead of sounding the bugle, but it's not just WGNRR property. It is a property of all activists, of all feminists who want to make noise in this space. And in today's circumstances, when we are seeing huge anti-choice voice growing, a huge well-funded anti-choice voice growing, it is all the more reason that we get together and we roar louder than ever to make sure that our demands are heard and keep our presence consistent. One thing as an activist organization like WGNRR, we have realized that consistency is key. You need to resist, you need to rest, and then you need to repeat. So we also believe in a lot of care days, like, we always say that, activists need the maximum self-care. So these are certain principles that we operate on, and digital media has its amazing merits. Sitting in our offices, sitting in different parts of the world, we are able to connect to a host of people who have this common agenda of pushing the movement forward. But it comes with its sets of risks and challenges. It also means that the anti-choice is always looking at us. And more than often, our website is hacked. Yeah, so more than often our Google workspace goes down. So we have a hacking almost every month because we know that we are in the space, and that is why we are being targeted, and that is fine by us. As long as we know that we need to move ahead, and we know that this is a collaborative space, we need to move ahead. So I'll end, Ragini, here, and then I'm going to share more. So WGNRR is not just an organization, it's actually a movement that builds capacities of our partners, that ensures that partners and allies understand how important it is to be standing together, stronger together.
Thank you so much, Demanjana. Especially, it's so reaffirming to know that such catalytic work is being done, and the momentum has already been set despite the backlash and the risks, right? And thank you for the work you all are doing. Um, just like there will be time for discussions, and I can already see convergence in the kind of background, in the kind of challenges that people are facing across different contexts in the global south. So I'm moving on to Praveena. Praveena, I know about what the kind of work that was done during COVID-19 in terms of ensuring access to safe abortion information, and this was also the time, like tumbling in a post-COVID world where the focus on digital systems came up. So can you elaborate on some of the lessons from Nepal's experience, and what are some of the strategies that can be adopted or contextualized across the global south?
Thank you, Ragini. And thank you, Dr. Kalpana, for setting the context and that powerful opening remarks. And it's my privilege to be with you yesterday and today as well, sharing the same space. And also would like to thank our audience who have been here. Your presence means a lot, although we are small in number, but I think it's a powerful number we are here in solidarity and in recognition that this is a topic we all need to talk about. And also would like to acknowledge how Philippines is doing in terms of the social media and use of social media, especially by youth. And they use not only the advocacy messaging, but also use of music like songs and dance, and how that has been powerful. So also want to acknowledge that and get inspired by, because I think this is a time we really need in the global south, especially for Asians, because we've been, as a region, so fragmented, and we don't have a solidarity in a sense of political, unity as a reason. We as a civil society need to bring that and be inspired by each other's work, and come together as a unit, as a movement together. So it's really, we can't agree more that this is a high time we need to come together in solidarity. So with that, I would definitely like to share some experience from Nepal, not only about the COVID-19 context and how Nepal was able to manage or increase access for abortion at that time, but also put Nepal in context in terms of how abortion rights and access has been, kind of the journey of that, just to put that in context, because probably many of you are not aware the kind of trajectory. So starting with 2002, until that, abortion was completely criminalized in Nepal. Much later, the MTP Act came in India in 1971, like 30 years plus later. Until that time, it was completely criminalized, not even to save the life of the woman. So, and there were a lot of women in prison for abortion allegations or abortion charges. So in 2002, and because we need to cut this very short without going into detail, it was legalized for the first time. And I think I know law is not the answer all the time, but the power of law is when you have a legal provision, then the managing access becomes possible. It's an enabling environment that we need to create. So in 2002, once the abortion was legalized, the access became possible. And from there, that time until now, we have, not only in Asia, but I could say that globally also, one of the most progressive a law on abortion, including other SRHR, which is primarily based on right-based approach, but there are limitations also. Of course, we are still within the criminal law framework, like in many other Asian countries, but at least there is some enabling environment to ensure access for abortion, including in the public and private setting. And in public setting, it is also free of cost. Yeah, that is one of the things we could learn from Nepal. And in that context, when COVID happened, it was a new learning from everyone. So access was there. There was also MA pills was available. It was listed as, both the drugs were listed as essential drugs, and services was available in tertiary level, primary level, and in also the higher district and provincial hospitals level. But when COVID happened, all of that learning became a challenge because it was not possible to go into the hospital or the facility to seek abortion access. Even when women went, they were returned, they were denied. And then some of the hospitals were turned into COVID hospitals, and then they say, oh, we are not going to give any maternal health services, let alone abortion. Like, abortion was not even a topic of concern at that time. But then what happened was, as government was trying to respond to the situation, and a lot of the civil society and other actors were trying to engage with the government, first it came was the response to the overall health sector. And telemedicine was first introduced in that guideline. And after some time, then because of the advocacy we all did, and just to name of a few, we have a network called this Reproductive Health Right Working Group, which includes not only the advocacy organization like our center, but also the service providing organizations like IPAS, IPPF's FPA, and MSI, PSI, and all of the organization. And with our collective advocacy, the government and other UN agencies as well, UNFPA and all of that, the government introduced another guideline which was specific on maternal health, neonatal health, reproductive health, and within reproductive health, abortion was also, of course, included because there was a lot of advocacy. And then telemedicine was included. But the tricky part was when the telemedicine was included in the language, this was like for information and education. So you can seek information about abortion service, like whether I could go and get the service or not, what kind of drug is available, how much of the drug, regimen I could use, all of that. But then access was not discussed. But as we go into the discussion with the government, later it became possible that including the information, the providers can also give service like asking them to kind of get the medicine. And MA is possible, like legalized until 10 weeks in Nepal. So with that, even like self-managing of MA was possible through this telemedicine process. So that was the kind of methodology we use and strategy we use to ensure that abortion access was not limited even during the COVID. And after COVID, the effort is to make sure that it continues and it doesn't become just, oh, we were dealing with a crisis, that's why we had to do this. Now we can go back to the normal situation and then stop the telemedicine or discussion about MA or SMA. So what we did was, because legal enabling environment is so important, because after COVID, what happened was everybody started saying, oh, the guideline was for COVID. So now COVID is gone, so should we again kind of, depend on that guideline or not? Would it be, useful, or would it be even relevant for us? So what happened, or what we did was, we said, okay, the guideline should still be applicable, although it was designed for COVID context, but it applies in a general context as well as also other humanitarian settings. On Nepal being a country where a disaster, like climate-induced disasters happen every year, it's a high-risk country, this is even more relevant. But to get that acknowledged, we had to link that with the normal abortion service guideline. So now it's part of the regular abortion service guideline, and MA and the SMA through telemedicine is possible. Still, both the drugs are not completely managed SMA. At least one drug has to be administered at the setting. So the second drug can be taken by the woman at her home setting. So some of the other things that was done at that time was, when this services was made available, the civil society partner, like the service providing partner, also came in and say, because for the government it would not be possible to provide this at their own, we would also, start getting this helpline services, and also ensuring that there are, accessible and available for people seeking it. So IPAS, MSI and PSI, they started opening their helpline services, creating different mobile booths in different districts and all of that. So that is how also the access was ensured. And other thing that was done in terms of the advocacy was, because everything was online, right? So there was lockdown and it was not possible to have any physical convening and all of that. And it didn't stop, because we all learned how to use the digital platform like Zoom and all. So even advocacy was happening at the Zoom meetings, and we involved the government partners, also inviting them in meetings and so forth. And wherever there was an issue, like when there was one of the hospitals was declared maternity health, COVID hospital, and maternity health service was denied, it was through these advocacy online meetings and some letter of appeal issued later. The government had to withdraw that decision, saying, okay, it is a COVID hospital, but we'll have some section providing maternal health services, but also the safe abortion services. So with this COVID experience, what I would like to conclude here in terms of how we can, take this lesson is, we really need to, when we say access, we really need to reimagine its concept as well. Because in the human right concept, yesterday I was talking a little bit about the human right framework for SRHR, and including for abortion, and today also I would like to reiterate a little bit, because if you look at it from the human rights framework, then it becomes very clear, and then we can also address the intersectionality issue, discrimination issue, and all and so forth. So when we say access, there are three different access we need to think about. One is definitely the physical access. So when the physical access is not possible, how do we do it? So these kind of alternative mechanisms becomes possible. Also the information access. So, and this is being one of the challenge, how do we ensure information in today's world where everything is available, and if you are good at using these technologies and tools, then it becomes really one click away that you have a right information. And third is, of course, the economic access or the affordability that you need to be able to get this service. Although in Nepal, in the public setting, abortion is free of cost, not everybody would go. Because one of the reasons being the legalization is not known to everyone. Still, despite legalization in 2002 and then having this right-based law in 2018, still 50% of the population is not aware. So that is again information gap probably can be addressed with this digital tools and all of that. So that is something I want to highlight, and then also end with the notion that especially kind of relating that with India, because India, it was a pioneer in creating access through law, right? Like MTP Act was so pioneering in that sense, but still it doesn't put women at the center, and it is still putting the service provider at the center, and that's why there's so much of limitation. And we did a study back in 2021-22 with NLU Delhi and then NLU Bangalore, where we really mapped the barriers, although being legal, what are the barriers in the current context in accessing. And one of the barriers was still being within the criminal law framework, of course, and how, because it is so much of responsibilities given to the RMPs, how RMPs are also under tremendous pressure to decide whether that service should be given or not, and how that becomes the barrier. So if anybody is interested, please, you are welcome to go through that report. But given that context, and since India being such a pioneering kind of leader in ensuring access for abortion reason, but yet it doesn't allow, like SMA or even the medical abortion in that sense. So how probably we can learn from the neighbors and introduce this kind of alternative approaches. So that is where I would like to stop, again reinforcing my message of we really need to come together as one reason now. Yeah, thank you.
Oh, absolutely. I think you have highlighted something really important, is that just the mere availability of information or even services doesn't determine accessibility, right? And my colleague Vinita and I keep talking about like do chatbots really work? How many chatbots do we really need? Like, yesterday everyone was talking about the graveyard of pilots. Like, there are different pilot studies, but unless and until it is integrated in a long term, embedded in the system itself, it's not sustainable. So, how many chatbots do we really need until, we actually get access to these services? So, thank you. And I think this also illustrates your point about hypocrisy, right? Like, there is so much jarring duality of one side having like a legal framework and then saying, I'll not allow you to, decide for yourself. I'll do the work for you. So we will have this conversation. But before that, although Dr. Suchitra Dalvi isn't here, but she has sent a pre-recorded message addressing like what the Asia Safe Abortion Partnership is doing in terms of enabling access to safe abortion. I would ask my colleague to play it.
Hello, I'm Dr. Suchitra Dalvi, coordinator of the Asia Safe Abortion Partnership, and I'm really grateful to the organizers for inviting to speak at this very important panel on leveraging digital spaces in Asia, the lessons and challenges for the Indian safe abortion rights movement. I am sorry that I'm unable to be there in person due to personal health reasons, but I'm very grateful for the opportunity to be able to share my thoughts. So just a little bit about myself. I'm a gynecologist, and for the last 25 years I have been working in the development sector, and I have been involved in community-based advocacy and capacity building programs across the board, both at national and regional level as well as at global platforms. And the Asia Safe Abortion Partnership is the only safe abortion rights advocacy network across Asia. We have members in over 23 countries, and we have been part of creating global forums and spaces such as the Abortion Reproductive Justice Conference, which was held early last year and brought together people from over 60 countries. So we've been very much involved in the safe abortion rights space, and one of the ways in which we have been able to expand our reach and reach out to the people who really need to hear this information and whose voices need to be heard, it has been through the digital spaces, through the online spaces. So very early on we realized that harnessing the online spaces and making our presence felt over there was a very critical part of the advocacy that we wanted to do for safe abortion rights, because since 2008 increasingly social media and kind of I would say democratization of digital spaces was happening. Now I think the situation is a little bit different, because these so-called democratized social media spaces are actually owned by a lot of corporate giants, and they have their own rules and regulations, they have their own censorship, some of which isn't always very liberal, and it isn't always very supportive of conversations on human rights and definitely on sexual and reproductive health and rights. So I think the environment has changed a little bit. But it's still an important space for us to occupy, because a lot of people, particularly young people, are able to access digital spaces with much more anonymity, with much less fear of danger for their own safety. And even groups of people who are traditionally marginalized or left out of mainstream media conversations can also find ways to access these spaces. One of the examples for this would be a series of videos that ASAP made a few years ago, which was on sign language. So we realized that the deaf and hard of hearing community were really completely unable to access information on their sexual health and rights, particularly on safe abortion rights, because the whole conversation around people living with disability, particularly women living with disability, is that either they are highly sexualized or they are highly asexualized, and there isn't any evidence-based information. So we undertook this program for recording sign language videos in 8 different sign languages from across South and Southeast Asia, and that has been an incredibly successful program. So I think there are great opportunities for leveraging a specific, very niche ways of utilizing the digital landscape. However, many campaigns that we have run, we have sometimes come across barriers where we find censorship happening on social media, or we are, there's what we call shadow banning. So they won't actually censor it, but it doesn't show up on people's feeds or in the algorithm. So I think we need to be, I would say, cautiously optimistic about how we use the digital media, particularly for an issue as sensitive, as controversial particularly for an issue as sensitive, as controversial, as politicized as safe abortion rights. The other side of this conversation I would like to have is for those of us who are using digital media, those of us who are putting information out there, and those people who are utilizing it or who are the users of this information, need to be increasingly very careful in terms of digital safety and security. As we know, a lot of country governments have surveillance on a lot of the digital media, which are particularly the ones which are owned by large corporates, and as a result of which it's possible to track. You have a digital footprint, and it's very easy to track that. So people like us who are working in this field need to be extra careful, because sometimes this information can put someone in danger, and we need to be very careful of that. So I think, given it's always a tricky balance, isn't it, between outreach and wanting to, in a way, kind of become virality with each one of your videos, and to become like influencers when we speak of safe abortion rights. But on the other hand, we must balance it out with caution about what this information could mean if it gets into the hands of someone who is not supportive of rights, and whether it could put the person in danger. We also need to be particularly careful about so digital landscape isn't only about putting out reels or having YouTube videos. I think we need to recognize that the digital landscape also includes the fact that data is often uploaded on the cloud. There are a lot of personal information, health information is available, through places where there could be porous areas of cybersecurity. So I think in that sense, I would also urge caution for those of us who are looking to explore or optimize our utilization of the digital landscape, particularly for this specific issue. Because as I said, the socio-cultural landscape and the politics of the real life does get reflected in politics in the online spaces, and therefore we need to be very, I would say, astute. We need to be very careful, and I think we need to be very well informed and very capable of managing the security, both of the information that we're putting out there as well as the persons who are accessing the information. Having said that, I still think it's an incredible opportunity which I think earlier generations of civil society or rights-based organizations haven't had, to be able to reach out to so many people at the same time. And at ASAP we have sort of consolidated that by creating the ASAP Academy. It's an online space where we offer courses on gender power, patriarchy, on contraception, safe abortion, and many other such critical topics of engagement. So if anyone's interested, you can check us out online. And I think all of us do need to find ways to utilize the digital spaces in the best way possible, because very often that might be the only way that this message could reach out to someone. And as we know, in India particularly, practically everyone does have access to a smartphone, even if they don't actually own the smartphone. So there is a greater possibility that the information will reach them than it used to be earlier, but again tempered with the caution. So I really appreciate the opportunity to be able to share my thoughts here, and I wish you great success at the meeting. Thank you so much.
Thanks to Dr. Dalvi. Especially persons living with disabilities are anyway marginalized and more so sidelined in SRHR conversations, because you think of them as asexuals in a way, right? So the idea that these are people living with propensity for pleasure, the need for companionship, it's just completely erased. So thank you for that. The next 15 minutes we'll be opening it up to the audience for questions and answers. I think, like, just to sum it up, and anyway, Dr. Kalpana would be, summing everything up. But just to say that, and because it's a small convening, I can say that it cannot be a depoliticized conversation. Every panelist who has spoken has shown how there's deep embeddedness of the political, social, economic, cultural, religious. And, we need to focus on that, we need to address that, and, we can do it in whatever ways we can. But we are opening it up to the audience for questions. Please feel free. We intend to make this a safe space. Yes, over to you.
Hi everyone. My name is Shubhangini. I lead the abortion rights work at the YP Foundation. And I got up early in the morning because this was not just relevant for the work that I do, but also what Dr. Kalpana brought up in the morning, how in a summit like this, SRHRJ sessions are either in the afternoon, in the evening slots, or very early in the morning, which makes it difficult for us to attend. So I just really wanted to come here, show solidarity, and learn from all the people that I've been learning from. I heard Anjali and Debanjana talk about the microsites, the networks that you're anchoring, and how there are multiple steps of verification for us to ensure that it becomes a safe space. And that's really the kind of effort that we take as abortion rights activists, and it shows a kind of expertise and resilience to do this kind of work. And I was thinking about how, while we create these safe spaces, these networks, there are also platforms like social media where we talk about those campaigns, we talk about abortion all year round. And in times like today, when there's shadow banning, there's censorship, but also taking down of telemedicine platforms like Shout Your Pill by Meta, how do you sort of deal with the censorship? How do you deal with trolling? How do you deal with, the Banjana mentioned hacking happens every month. So I know it takes a certain kind of resilience, but open platforms where, yes, we can talk about safety, but how do you sort of, what are the strategies that you employ as people who are very much present in the digital space, which we do not entirely have control over? So yeah, thank you.
I'll go first and then Anjali, please jump in. Thank you so much, Shubhangini, for the question, and a very pertinent question, because yes, it is times taking, and it also means that it has a burden on human resources. Somebody has to work extra to do all of that. Somebody also needs to again put the website up and running. But that's something that, you know, as abortion rights activists, as feminists, we cannot compromise. So that's the work that we need to put in very plain language, that that's the work that we have all decided that we will put in, so that it is safer and it is inclusive and diverse for everybody. So yes, it is a lot of work. There are certain strategies that we develop at the back end to ensure that there are checks, there are balances, there are some restrictions, and we also get to know what kind of crowd is coming to the website. But however, website and social media, while they are owned media, you really don't have any control on who's looking at it and who's commenting on it. And that's an open space, and that's an argument and a debating space that we are willing to have in order to pursue safe abortion for everybody, in order to pursue the justice that we are seeking for.
Yeah, just reiterating what Debanjana said about consistency. I think just keeping at it every day, every week, just going on doing it is one way. And like she said, of course, it does come at the cost of resources, and that is another big challenge actually, because how do we fund those resources in a climate where funding is shrinking also for, I mean, let alone for advocacy, even for service delivery. So that is a significant challenge. Also, with Sage, I think we have also taken one step back and gone back to some of our traditional means of communication. So where we are facing shadow bans and things like that, we are usually going back to mailing lists, sending out as much information as we can through emails, through our, websites, social media, is whoever sees it. But even just reaching out to partners, asking them to amplify the message through their mailing list. So in certain spaces, we've had to kind of actually go back to old school, because that's another way in which the message is reaching more people, because new school is not getting our message out because of these other challenges. So it's a mix of both. Wherever possible, we use social media and amplify it, but we also use traditional things like email and just asking people to tell other people. And that's another advantage of a network, because when you have a network, you're amplifying it that much more. So 300 people are reaching out to 3,000 people of their own. So it's a snowballing effect.
Thank you. I think we have time for 2 quick questions, and then we can wrap it up. Anyone? Yeah.
Hi, my name is Shumatru Ghosh. Just a couple of observations. We keep discussing that our phones are listening to us. Our phones are watching us. And we click something, and in the next 1 hour, we receive related product services and information. This must be creating some kind of potentially, some kind of a fear in the user's mind. My question is that, what we see is in most of the South Asian countries or anywhere in this region, the pharmacy still remains the first port of call for any kind of diseases, including SRHR, family planning. And we know that because we have not been able to integrate the pharmacies or educate and sort of sensitize them to the process, there is a lot of misinformation or lack of control at that level. Somebody is going for contraception, getting like medical abortion pills. Somebody going for medical abortion, getting emergency contraception. It's very common, we all know. So I didn't hear anything about how we are trying to integrate the pharmacists along with various other things that we are doing. It's a very important player in that whole space, and how do we sort of bring them in? Thank you. I don't know. It's all of you are experts, I'm sure. I know Nepal has a lot of social marketing has been done for medical abortion. So what have you been doing? I know India always says that it is very difficult to expect the pharmacist to do any consultation, any kind of, providing information. All that I know. Like, what's happening in Nepal if it's emerging as a good model for medical abortion?
Unfortunately, I would not have the exact answer to your question because that is not something in my forte. So just a disclaimer that I don't know the answer, to be honest. But what I could agree is completely, because they are also a key player, a key stakeholder in that sense. So few organizations are including them in studies, especially for youth who are seeking both emergency contraceptives as well as MA pills, how the pharmacists are responding to that, especially in terms of their behavior and whether it has been enabling the adolescent access or not. So I know that much, like they have been part of these studies, but in terms of bringing them as part of, the solution, personally, I don't know. I'm sure there is something, but personally, since I don't know, I wouldn't want to give you a wrong answer, so yeah.
Well, yeah, you're right. Pharmacies. Okay, so yes, you are right. Pharmacies are an integral part of our healthcare system. And this is the first point of contact for many people for almost all ailments. But, and also we must understand the Lancet study did say that a lot of huge number, 70%, are self-care accesses, and that happens through pharmacy. But at the same time, we also must remember that pharmacies are not spaces where confidentiality or privacy can be maintained at all. There, at that point of time, the space is just, they come in all sizes and shapes. And we know that there is also just sometimes just a table, and then across the table, that kind of transaction does take place. It's also who accesses the medicine in the pharmacy. Is it the actual person who needs to take it, or it is someone else on their behalf? So the behaviors on the ground are very, very different in these settings. And we must remember that accessing safe abortion medication is, again, it's actually safe abortion itself is so stigmatized, isn't it? And accessing medication itself is a link to that, or it's extension of that. So it's most often either a male partner or a husband or someone who will go and access that medicine. And therefore, even if for contraception, it's relatively easier But or for all other things, it really became a very successful thing, if you can think for ORS and other those kind of solutions. But for a very highly stigmatized service, where we have not been even able to crack it even in a healthcare setting, pharmacies have a role to play in just dispensation without giving correct information. Yes, if there is a trained or a well aware pharmacist, they will be better provider in a sense of not stigmatizing the provision of that. And we have some experiences of at least keeping information leaflets at the pharmacist's desks, that in case they have a problem, they can come and visit our clinics. But a pharmacist also, if you do that, you will also have to work with them, because then you are actually, they feel that you are a competitor. So the market economics, the stigma, the SRH, around SRH issues, the socio-cultural norms, and also the affordability. All of this, you talked about economic access. All of these things are actually at play, if you want to see them at play. People, person by person, you can see it at the pharmacist's desk or the cashier still, that these transactions happen. So there is no one size fit all solution for inclusion of pharmacists into service delivery for safe abortion medication. I think
Pharmacy are sort of getting into this, a chain of
So,
retailers, and
listen outside,
Sure.
because like we have only 3 minutes left and one quick question and we'll be done. We'll be wrapping up the session. Anyone else? Yeah, sure, please go ahead.
Sumitro always provocates me. 15 years of experience with him. Just a quick response and a thought in line with what Kalpana you said. Lots of us have tried it, especially because you asked in this region, Nepal, India. I think London School of Economics had done a study of most of these interventions. The conclusion they had, and I very strongly believe, is an active engagement with the pharmacy for active counseling or active information provision we have not cracked that. But the fact is, they are the biggest presets, they are the first point presets. So the question probably we as practitioners should ask is there some way we can use them to go directly to the woman? Are there active ways of engaging them? So I think the need for the hour is not to forget that they won't counsel, forget they won't give us information, but other ways, because they are your touch point, and the only touch point probably, other ways in which we could use them, leverage them to go directly to women.
no, exactly that. So, Vinod, exactly that. We left leaflets with them saying, if they come back with a fear or worry or asking you about bleeding, do send them to us and we'll take care of that. You sell your medicine to them. You do not, so we are not coming in your business. But if there is a complication, they want more information, send them to us.
And we can
So
take
this
it
is
further
what
also.
we have. I think we need a panel on that. So we'll move on. And it's a very interesting conversation, but let's move on and over to you, Raghu.
Yeah. Right. I think just as a wildly optimistic person, because I'm a young person, I need to look forward. Otherwise, the future looks very bleak. So I would like just to say that the ball is, it has set the role. The tiger is out of the cage, and people are doing incredible work, catalytic work that is going to, make some critical changes. I hope for the best. With this, if you have any questions, we'll just take it in a cluster and probably answer it outside the room. If not, then I'll hand it over to Dr. Kalpana. There's one? Yeah, sure. Please go ahead.
My name is Jewel. I'm a second year undergraduate student. And my question is, so the conversation about the existence of pharmacists is largely on, from what I've been hearing, on their business interests and them wanting to supply the drugs and get the money. But what about the dangers that could be posed to their customers psychologically and even to their physical bodies? What accountability measures are there? Because from what you said, Kalpana ma'am, that they can give the drugs, but then if there are complications, they can advise the customer to come to you. But what if the customer does not, because there's already existing stigma? How do you hold the pharmacists? Are there mechanisms to hold them to account? That's my question, for the harms that they could cause.
So how do you hold the pharmacist accountable for harm they are causing? Post complication. Well, I think I really have no answer to it, because a large percentages of medication abortion are being provided at that level. They are either prescription or without prescription even as a practice. And I think women, and we know there are studies and there is research that medication abortion is largely safe. And it's largely safe. And if there are procedures that require, or women require more psychological or counseling, they will find their ways. There are ASHA workers in the villages, in urban areas, there are people. And as it has become more and more widespread and more common, there are also informal support networks. This is not a perfect solution, and I'm not telling you that it's an ideal scenario, but what I'm trying to tell you is that really speaking, at that point of space, at the pharmacist transaction table, there isn't much space for an individual conversation, privacy, confidentiality, referrals, or as Vinod said, information giving. It doesn't happen, not for abortion, and I don't think it happens for any other fever drug or for diarrhea or for anything else, really speaking. It's a transaction place, more or less. Even for the pharmacies which are set in hospital, these are transaction places, and they are not geared up to answer questions. We all know that. I mean, all of us, we know that. So, yes. Okay, I think I will also take this opportunity that the mic is in my hand and the button is green to really close a conversation we cannot close. Time is the only thing that really requires us to close and leave this room so that other conversations can happen. Safe abortions have been criminalized in almost all settings, and in some countries we have seen that there is some sensible policy decisions to make it accessible for women. Even that access by law does not translate into 100% access to the fullest extent of the law in that country in almost all spaces. There's so much work that we need to do. Technology brings its own areas of opening up and access. However, it also brings its negative sides. And trolling and hacking and all of that is the dark belly of technology that we see. And for safe abortions, of course, it's much more aggressive. Trolling is only a form of online bullying or harassment that abortion providers face, which they also face in person in clinics. And we know abortion providers have died. They have been gunned down, and they have been vilified, and they have been stigmatized, and they have been shamed. And this is the reality of all countries, of all the places, including in places where legal abortions are possible. And therefore, I think be it all this, we need to solidarity, working together, finding safe spaces, sharing experiences, encouraging, inspiring each other is the only way forward when the world is not going to be supporting through resources, through technology, through support, mental support, but women and pregnant people need it. It's an important choice. It's one of the basic choices that the person makes, that pregnancy cannot continue. No one but that person can only feel the burden of living with an unwanted and unintended pregnancy. And we owe it to that person to see that we continue fighting. And that is where we have to draw the inspiration from the people. And so thank you so much for organizing this, and you have been a great audience, and let's continue the conversation outside the hall. Yeah? Can you please all come up for photo? We'll take a group photo. Vinod, come.
Hello, ma'am. Hello, ma'am. Can I ask only one question?
well, it's your hall.
Yes,
If
ma'am.
it's your hall and you give us time, you
Yes,
can
yes.
have
Yes,
20
yes, ma'am.
questions.
Yes, ma'am.
Yeah.
Ma'am, I am working as assistant professor pharmacology in NIMS Institute of Pharmacy.
Yeah.
I used to teach pharmacology as well as social and preventive pharmacy. You just said that pharmacists can't be a part of this program or creating awareness. As we have idea about pharmacokinetics, pharmacodynamics, all idea about the drugs, levonorgestrel, norgestrel, oral pills, contraceptive devices, MTP. Why can't we be a part of this?
Let's
creating
talk
awareness and
outside
all?
because it's a very long answer. Not that you can't be a part of it, but the challenges about it. We would love to be, he's been saying that. We would love to have and young people change the world. So if you think they can be a part, let's find a solution, my friend.
Yes, ma'am.
But let's
In our NIMS
find a
University
solution
clinical
outside.
pharmacist interns, we have provided a space area where people can reach out there and ask.
Sure, let's talk about it.
Okay, okay, ma'am.
Let's
Thank you so
talk
much.
about it. Let's not forget this conversation. And I think I request everybody to please come up. Please, please,
Kalpana ji,
please.
I also just want to say if anybody here would like to be part of the SAGE network, please get in touch with me. We will put you through the standard verification processes, but at least write to us and fill in the form.
Come, everyone. Yes, please. Young assistant professor, please come. Come. Come, everyone.
I think you be seated and then we all kind of,
All right.
as we did yesterday.
As we did yesterday. Yeah. Okay. Come, Shubhangini. Yes, absolutely. Come. Come, everyone. Hi, come. Come, sir. It's okay. Please. Come, sir. Please come. No, come, sir. Please. Thank you. One of our cameras. There is some. Then maybe Nita will. Ragini, will you run and give him powers? Yours. Thank you. Ek aur. Everyone, please. Because this will take time and this one will come quickly. Thank you, everyone.
Hello everyone. Can I get your attention please? Hello. If you want to discuss anything, discuss outside please. Hello, hello. If you want to discuss something, discuss outside please. Excuse me. If you want to discuss, discuss outside please.
Could I please request everyone to take a seat? Hi, good morning, everyone. Thank you so much for being here today in a truly neglected fashion. This is our panel. This is our room today. It's a pleasure to introduce Dr. Bhupendra Tripathi, who will be leading this session. And we are going to be discussing the importance of why it is of an NTD, that's lymphatic filariasis. So Dr. Tripathi, over to you. Thank you.
Thank you, Tanya. Hi, everyone. Good morning and welcome for this session. I'm really happy that we have such a nice audience here because neglected tropical diseases already have neglect in attendance also. So in that terms, I'm glad that we still have at least half house full. So, well, hoping for more people to come in between. So we will start our session. Let me start by just, appreciating Government of India for bringing this neglected tropical disease out of neglected and making it a priority disease. So we are very happy to see that government has made it a priority. And the prioritization is also visible because this session is being held in this whole, summit. So that's also very good. What we will do today, we will have a group of experts who will be panelists. And we will be having our chair who will be helping us. And I will be the moderator for the session. As all of you know, lymphatic filariasis is a disease spread by mosquitoes. And the parasites, we have Urcheria bancrofti maximum in India. We do have Brugia malai as well. And the mosquito basically bites the infected person, picks up the macrofilaria, then bites the healthy person. The macrofilaria goes into their larva, matures. Then the person has adult worm, male and female, and then the worm basically, both of them marry and they have babies. They are macrofilaria, and the circulation happens. And the program has a two-pronged strategy, as WHO has said, that one will be mass drug administration and second will be morbidity management and disability prevention for those who are affected. But Government of India has done more, and we will be hearing more from the panel members. So let me start by inviting our honorable chair for today. I'm very happy to announce that we are lucky to have Professor Dr. N.K. Ganguly, sir, former DG ICMR. Sir, can I please invite you? As all of you know that sir has been a distinguished scientist not only in India but at a global level. And sir he has been scientist for multiple people. He has led so many PhD candidates. He has more than 800 publications across the world. And currently, sir is supporting all the medical students, medical colleges. And we are thankful that sir could spare time for us. So thank you so much, sir. I will be inviting our panel members. So let me invite Dr. Rinku Sharma. She is Joint Director at National Center for Vector-Borne Disease Control. Dr. Rinku is leading the lymphatic filariasis portfolio at the NVBDCP, and she has been great support for vector-borne diseases. She had led the malaria strategic plan in the past, and now she is leading the LF program. Now let me invite Dr. Manju Rahi. She is Director of ICMR VCRC based at Pondicherry. And all of you know Dr. Manju. She has been a great scientist and a passionate person for vector-borne diseases, zoonotic diseases, One Health. Her work has been really helpful in development of guidelines in the past for scrub typhus, for lymphatic filariasis, for DC salt, for triple drug therapy. Now let me invite colleagues, partners, starting with Dr. Badri Thapa. Dr. Badri Thapa is the team lead for communicable diseases at WHO Country Office. He has been a public health expert, not only for South Asia, Indian subcontinent, but also he has worked extensively in Mekong region as well. Adding more, we will be inviting Dr. Madam Anjali Nayyar, Vice President from Global Health Strategies. She is a passionate public health person. She has been working for so many public health programs, including neglected tropical diseases, and we are thankful to her for raising the voice of this particular program. Moving forward, I would like to invite Madam Rajshri Das. She is the Director for PCI India, and she leads the portfolio of neglected tropical diseases in PCI. Then I'm also happy to invite Dr. Manmohan Singh from Piramal Foundation. And Manmohan ji has been a very senior public health person. He has been the co-founder of Kaivalya Education Foundation in Piramal Foundation, and he's having a big team of workers, Gandhi Fellows, supporting the program. And finally, and the most important person whom I want to invite now is a person who has actually suffered with this disease. We are all scientists talking about disease technically, giving our own gyan. But let's hear from a person who has actually suffered lymphedema in her own life. So I would like to invite Ms. Reena Devi, who has suffered. Reena ji, आपका स्वागत है. Please आप आइए. So Reena ji जो हैं, she comes from Bihar, Gopalganj district. Her village is Karsaghat, and she has been a person who has suffered with particular disease, and she has been a passionate advocate and champion for engaging and working with more people and trying to make this life easy for people who have suffered with lymphedema. So she will speak about her own life, and she will also speak about how she has overcome the challenges and how she is an advocate for everybody in her own area. So well friends, let's have a round of applause for all the panelists, and we will start now. So let me start by inviting our chairperson, Ganguly sir, to give 2 minutes introductory remarks, and then we'll come to the panelist. Sir, over to you.
Thank you, Dr. Tripathi, and thank you, Anjali and others for this honor. Actually, I had made the complete journey for this dreaded disease, filariasis. And when I was a child, I used to live in Gorakhpur, and we had 3 ladies in our house who all had elephantiasis. And it was quite a miserable thing right from the childhood, which I saw. The main problem in filariasis was that we didn't have any drug which could really deal with the adult worms. So we had the diethylcarbamazine, which of course quality-wise we had a problem, and this quality was improved by getting the donation from ISI, and now we are producing it quite nice. But to add on this, albendazole was a real struggle, and it happened during my time. And I will recall one scientist, Dr. Rajendran, who was in the Madurai, who identified that when you really add albendazole, you reduce the antigenemia in the filariasis. So this was a great science which came up over there. After that, there was but the adult worm remained. They lost their fecundity, but they came back with a vengeance, and they again started spewing microfilarial worms. So after that, what happened that another drug, Dr. Walls in the Papua New Guinea, identified that if you give ivermectin, add ivermectin on this, then the adult worms will also go. And some very strong tools came up, like ultrasound, as well as the mass spec, which could really identify the population. So suddenly we had tools in diagnostics which we never had before. And here, historically, I will thank BMGF. At time the Julie came up in a big way to help, and also Anjali and group, they also jumped into big way to put it around the states. And Manjurahi, at that time I was chairing the ICMR group, and she was the point person over there, and pushed this ivermectin trials all across the ICMR centers. And next is the history, but few gains I want to identify. One gain was this, that the drug acceptability was because you had to take a huge number of tablets, but suddenly this has improved tremendously. It has improved up to 80%. I could never imagine in my life that this will happen, but this has happened. The other thing which has happened, which is very important now, that there is only 139 districts which now we have to have remained. Rest of them are totally out of it. And all the union territories which were in that area, now free of they don't need any MDA administration anymore. And the block level and few other which NDVPC has now adopted, and the training programs which have adopted, that is great. The two more points I will like to emphasize, that there was a donation which was coming from Medzican, but Medzican donation is still active. And in the Kigali, the last Kigali meeting, there is a fund for NTDs, and so it will not really die because of the funding. And Kavita is sitting here. She was my student in PJ Chandigarh, and she has now a drug from the DNDI, which will act as a microfilaricidal drug. And luckily, she just informed me that ICMR has funded it, and they will undertake a very large trial. So we might have another drug coming in. I will be talking of another point when I really conclude about the climate change, and this remains a big challenge. We will like to see that how this challenge we will be able to tackle, to give put a last nail in the coffin. And I will also remember Sumi from the Kerala, who actually tried in a very big way to integrate into the health system, so that when the major programs, etc., are in place, the health system is able to take care of the hydrocele, about the lymphangitis, about the filariasis. Thank you very much, Bhupen.
Thank you, sir. Thank you so much for the introduction. And before going further, I want to just ask one question. You know, in India, half of the country is actually endemic for LF. There are around 348 districts which are having endemicity. And many of us sitting in this room actually belong to those districts, or you have spent major part of your time in those districts. So except for people who are doing daily work on LF, those who are, our colleagues who have joined the session, how many of them actually know that they are in a LF endemic geography? Has anybody any awareness? Are you from a LF endemic geography? Question number one. Question number two, if yes, assuming yes, how many of you have ever consumed mass drug administration drugs? Have you ever received, first of all? If received, have you consumed, or did you say, no, I will not consume? And that is one indicator which I keep in all my Indian meetings. If I go to a medical college, I will ask all the professors, all the students, how many of you belong to which area, and have you ever consumed? So what happens, all the elite learned people, we usually feel that we are healthy. We will never have this disease. Why should we worry about it? And I'll give you my own story. I'm from UP. I have been working on polio for last many years. And I never knew about this program in the past. And when I came to LF program, and I was part of the inauguration, sir mentioned about triple drug therapy. I was part of that meeting. I also consumed triple drug therapy. And after like 2 days, I got a lot of itching on my body. Everywhere I was getting itching. And I had no clue why I'm getting the itching. I went to a skin specialist and I asked him, I'm having itching. Can you please tell me what to do? He said, oh, you are traveling here and there in hotels you stay. Maybe you have got scabies. Take more take ivermectin. You will get improved. I said, okay, fine. I started popping ivermectin. The more I ate ivermectin, the more I got itching. The more I ate, the more I got itching. I went out of India for some work and I could not get ivermectin there. And I stopped eating ivermectin and the itching also went away. And I had no idea why did I had. Then I came back, then I met sir, I discussed and read more about the program. Then I realized, well, I was carrying microfilaria myself, although not having lymphedema or hydrocele, but maybe, yes, I was transmitting to others. So this is the most important part of the program, which need to be communicated. Like all of you know about the program, you are in this room because you have interest in this subject. But what about the common people? Do they understand? Do they know about this problem? Even if people have lymphedema, do they know really what is the cause? So for that, what we will do, we will start today's session with Reena madam. Reena ji जो यहाँ बैठी है हमारे साथ, इनको ये दिक्कत थी. हम इनसे जानना चाहेंगे कि इनको क्या दिक्कत थी, क्या इनको पता भी था कि ये दिक्कत क्यों है, और उसके बाद इन्होंने क्या क्या झेला, महसूस किया समाज में, परिवार में, इसके बारे में जानना चाहेंगे। और उसके बाद क्या हुआ जो प्रोग्राम ने कुछ काम किया। और मैं इनवाइट करूंगा अखिला जी, व्हाई डोंट यू प्लीज कम ओवर हियर टू हेल्प इन मॉडरेटिंग दिस डिस्कशन। अखिला जी। रीना जी, go ahead or should I just request her? रीना जी अपने बारे में कुछ बताइएगा और थोड़ा सा बताइएगा क्या समस्या थी। हाँ। बहुत सही। यस प्लीज प्लीज प्लीज।
आप रीना जी का देन यहीं पर छोटे हैं ना तो।
नमस्ते, मेरा नाम रीना देवी।
मैं थोड़ा आपका परिचय कर देती हूँ उसके बाद। So my name is Akhila Shivdas. I'm part of an organization called Center for Advocacy and Research. हम लोग ने just right after the first wave actually, between the second and the third wave, ये पूरा thanks to the Gates Foundation, एक पूरा मतलब एक conscious effort to integrate patients into the whole filaria elimination program began. Very hidden, very ostracized, very stigmatized, very poor, very fragmented, very sort of piecemeal everywhere across villages. That's how the snowballing began. With a few lists of few patients' names, we began. By 24, late 24 or late 23, we had gone from about 20 patients to about 17,000 patients across both UP and Bihar. And Reena Devi was part of that entire crusade. This was actually championed by them. They learnt about the disease. They taught all of us about the disease firsthand, what happens to women who are carrying children, who are raising families. All of that predicament now Reena Devi will present to you. Today, this entire thing, the patients have now joined force with the entire health system at the Health and Wellness Center at the Ayushman Arogya Mandir, and along with the CHOs, ANM, ASHA, and all the other intersectoral stakeholders, they are, converging together and launching village by village, program awareness and, compliance to the whole, what Dr. Tripathi just mentioned about the medicines that you eat to prevent the filaria. So over to Reena Devi. Reena Devi, आप बताइए आप अपना खुद का
नमस्ते, मेरा नाम रीना देवी, गोपालगंज बिहार से हूँ। मेरे हाथ में 10 साल से फिलेरिया है और बहुत ही फूलता था, पचकता था, दर्द भी रहता था। इसमें दर्द होता था तो बहुत कठिनाइयाँ झेलना पड़ती थी हमको, और इतना काम करने में बहुत दिक्कत होती थी हमको। तो एक रोज़ अपने खेतों में काम करने गई, उसमें पानी लगा था, तो काम करके आई तो इसमें ललापन हो गया और जाड़ बुखार हमको हो गया। और घर के लोग हमको प्राइवेट डॉक्टर के पास ले गए और दिखाएं तो डॉक्टर कुछ दवा दिया हमको और घर पे हम आ गए। घर पे आए तो दवा खाए, दर्द तो आराम हो गया, बकीर फूलना कम नहीं हुआ, इतना ना सूजन हो गया था इसमें। तो फिर हमने इसको, घर के लोग हमको बहुत ताना मारते थे, बोलते थे, और इतना कठिनाई झेलना पड़ता था। बच्चे लोगों को खिलाना पिलाना, पोसना पालना, और उसके बाद हमको पति भी बोलते थे हमारे, और अछूत मानते थे, ये पूर्वज का है। दूसरे लोग भी बोलते थे हमको, तो मतलब हमारा मन बहुत दुखी रहता था। तो मेरे बगल की एक दीदी आई, बोली ये सरकारी हॉस्पिटल में सब कुछ का इलाज होता है। तो हमको लेके गई, एक रोज़ लेके गई, प्रभारी सर से मिली, प्रभारी सर से दिखाई मेरे हाथों को, तो प्रभारी सर बोले ये तो फलेरिया है, फलेरिया है, ये तो एक्सरसाइज करेंगे, सफाई करेंगे तो कम हो जाएगा, छूटेगा भी नहीं। तो हम अपने घर पे आई, प्रभारी सर बोले जी आप ही की ही गांव में, आप ही की ही गांव में
बहुत अच्छा कर रहे हैं।
बोलो, घबराना नहीं।
आप ही के ही गांव में सीफर का मीटिंग होता था, तो हम आए एक रोज़, तो घर पे आए तो हम लोग पता किए, घर के लोग भी पता किए, हम भी किए। तो हम दूसरे रोज गए तो बहुत सारा वहाँ पर मरीज थे। तो हम गए, बैठे, तो देखे जे किसी के पाँव में था, हाथ में था, तो हमने देखे तो बोले जे हमारी ही तरह एक हम नहीं हैं, बहुत सारे लोग हैं यहाँ पे। तो हमको आत्मविश्वास हुआ एक हम ही मरीज नहीं है। तो फिर हमको उसके बाद एक मैडम देखी तो बोली जे ये तो फलेरिया है, मच्छर के काटने से होता है, मच्छर के काटने से होता है। उसके बाद हमने क्या किए, सर सफाई के बारे में बताई, एक्सरसाइज के बारे में बताई। तो हम घर पे आए, सर सफाई किए, एक्सरसाइज किए, तो हमारा दर्द फूलना कम होने लगा, पुचकने लगा। तो हम फिर दूसरे को बताए तो उसका भी कम होने लगा। उसके बाद हम लोग भी गांव-गांव में जाकर देखते थे जे किसका मतलब ऐसा फूला हुआ है, तो उसको भी बताते थे हम लोग। तो फिर हम उसके बाद गए, 2-4 दीदियाँ मिलकर प्रभारी सर के पास गए, सर हमारा तो सही हो रहा है और दूसरे को भी बताते हैं हम। तो प्रभारी सर बोले अच्छी की बात है, आप लोग जाइए और जागरूकता करिए, हम आपके साथ हैं। प्रभारी सर बोले, तो हम लोग आए घर पे और गांव में जाकर दूसरों को ढूंढ निकाले। तो उसको मतलब 20-25 मरीज हमको मिल गया वहाँ पर, 10 लेडीज़ और 15 जेंट्स मिले। तो हम लोग समूह बनाए और नाम लिखे उन लोगों को। लिखने के बाद उन लोग को भी अपना सफाई के बारे में, एक्सरसाइज के बारे में बताए, तो उन लोग भी करने लगे एक्सरसाइज, सफाई। तो उन लोग का फूलना कम हो गया। कम होने के बाद दर्द भी आराम हो गया। तो हम लोग अब जिले में गए तो मलेरिया, हम लोग उसके बाद हॉस्पिटल गए तो सर बोले, हम लोग उसके बाद मतलब अपने एक्सरसाइज बताते समय उन लोग
बताओ, कोई घबराने का क्या बात है, बताओ। मैडम के पास मिली, बोलो।
हम लोग मतलब जिला में गए तो मलेरिया ऑफिस में मैडम से मिले। तो मैडम बोली आप लोग कहाँ से आए हैं, तो हम बोला जे हम फलेरिया हैं पेशेंट। तो हमारा हाथ देखे मैडम, तो बोली जे ये तो बहुत कम हो गया है, पहले हमारा इतना मोटा था। तो मैडम बोली जे आप लोग क्या करने आए। हम बोले जे मैडम हम लोग तो अपना झेल ही रहे हैं तकलीफ़ दुख, एक दूसरे को भी हम लोग बताएं, जागरूकता करें। तो मैडम बोली जब हम लोग का भी MDM राउंड चलता है, मीटिंग होता है उसमें, तो आप लोग को बुलाएंगे, उसमें आइएगा आप लोग। तो हम लोग गए, एक रोज़ गए, मैडम बुलाई तो गए। तो जो दवा नहीं खाता था ना, तो उसको अपने हाथ दिखाते थे, इतना मोटा था हमारा हाथ दिखाते थे, तो वो लोग दवा खा लेते थे, समझाते थे, बताते थे बहुत दर्द होता है, कठिनाई से झेलना पड़ता है। तो उसके बाद हम लोग क्या किए जे फिर हम लोग वहाँ से अपनी गांव आए तो आशा दीदी के साथ लेकर घर घर दवा खिलाए और हाथ को दिखाते थे। हम दवा खिलाने के प्रयास करते थे। जो आशा दीदी के साथ में जाते थे जो पूछते थे हम जे आप गर्भवती महिला नहीं ना है, और जो गंभीर बीमारी से ग्रसित है उसको भी नहीं दिलाते थे हम लोग। तो पूछ कर दवा खिलाते थे। कुछ लोग वहाँ खाते थे, कुछ लोग नहीं खाते थे। तो फिर हम लोग घर पे आ गए, फिर अपने मुखिया जी से मिले, वार्ड सदस्य मिले, तो उन लोगों को भी हम मुखिया जी से बताए, मुखिया जी अपने गांव में कुछ लोग दवा नहीं खाती है, मेरे तो फलेरिया हो गई है हाथ में और कुछ लोग नहीं खा रहे हैं। तो मुखिया जी बोले चलिए हम चल कर बताते हैं, समझाते हैं ये क्यों नहीं खा रहे हैं। तो मुखिया जी साथ में जाते थे तो सभी दवा खा लेते थे। तो अब मेरे छोटा सा गांव था तो उसमें 20-25 आदमी रहते थे। वहाँ पिछले साल कोई भी नहीं दवा खाया था। तो मुखिया जी को फिर लिए, फिर वार्ड सदस्य के लिए, विकास मित्र को लेकर गए, आशा दीदी को मैंने साथ में लेकर गए, सभी को मतलब मुखिया जी को लेकर गए, वार्ड को विकास मित्र को लेकर गए। तो वहाँ पर जो दवा नहीं खाता था वो सभी दवा खा लिए। खाने के बाद हम लोग घर पे आए। घर पे आने के बाद उसके बाद हम लोग क्या किए का, ये हमारा तो हाथ इतना मोटा था, इतना मोटा था तो 2 खल के ब्लाउज सीकर पहनती थी, चूड़ी भी नहीं होता था इसमें, चूड़ी पहनती थी तो नहीं होता था, बहुत कठिनाई होती थी हमको। उसके बाद हमने कहा कि ये अपने मतलब गए तो एक्सरसाइज और में थे
Very nice, wonderful.
रीना जी बहुत बहुत धन्यवाद, बहुत बहुत धन्यवाद। हम लोगों का जो भी यहाँ पे डिस्कशन है, मेरे ख्याल से शी हैज समराइज्ड एवरीथिंग वेरी वेल एंड दैट्स द अचीवमेंट। And you know, I think we all must appreciate the confidence what she came up with. Being a patient survivor and coming and telling the story of success, that is what the program has done. And I would like to appreciate Akhila ji and her team for this wonderful work what she has done. The only challenge is that Reena Devi जैसे कितने लोग हमारे पास हैं. Ideally, we should have Reena Devi in every village, every ward, who can stand up and say, guys, this is a disease because of mosquito. Don't be stigmatized. Because 99% people who were suffering, who had symptoms when we started the program, had no clue how it spreads. As doctors, we were very wise to tell, ये fileria है, कुछ नहीं हो सकता, घर जाओ, और ये DEC ले लो, हेट्राजान ले लो, when you get fever, you can just eat it. But we rarely go and tell, कि boss, this is something which is spread by mosquito, don't worry, try to take these medicines so that it does not spread to your family members. This message is still not being told. People are having hydrocele, they go to surgeons, they get operated. But how many surgeons actually tell the hydrocele patient that this may be a filarial hydrocele and there is the importance of the mass drug administration drug which you have to take. So these are the challenges we have and we will be discussing in detail. Let me invite Dr. Badri Thapa from WHO. He has been an NTD focal person for the country as well as he has worked with multiple countries. So what are the key principles and key learnings which you have, Dr. Badri, which can be applicable for the country and how we can move ahead on NTDs? Over to you.
Thank you, Dr. Bhupendra. No, before going to other countries' lesson, so I want to emphasize lesson that other countries can learn from India. No, simply the today's this intervention from Minaji. So I haven't seen the people affected people, no, the LF people affected, the lymphedema patient engaged in such kind of advocacy. They are the game changer. And India is doing a lot, I must say. In 1 year's time, I got to understand whether it is in the VL is very near to elimination, and trachoma has been already eliminated. So India is not a country, it's a big continent. So when you come to lymphatic filariasis, so you don't see a country with 620 million people under chemo prevention. So it's a large operation. And success is already there. But India can do better if, like WHO recommended strategies like triple drug therapy, IDA can be implemented right up front. So we have seen that new areas are being mapped and they are confirmed as LF endemic. But it's good to implement IDA instead of going to DA, which is in the view of accelerating LF elimination in the country. And other areas that needs to be done here is the integrated vector management. Because the priority, the NTDs here are LF, VL, and then dengue. So these are all vector-borne diseases. So I think these all vectors can be addressed jointly when we move together with this integrated vector management. Another suggestion I can give is, now NTDs is also taken under the One Health approach. So, human health and animal health and environment cannot be segregated. So if you want to really address human health, then we need to jointly address the animal health, then where the rabies comes into picture. And when we deal with the environment and these vector-borne diseases, which are really important in India, can be addressed. And another one, when we talk about this integration WASH, because water, sanitation, hygiene plays very important role in NTD prevention, control, even elimination. So that can be considered. Thank you, Dr. Bhupendra.
Thank you so much, Dr. Badri. This is really helpful. And we are very also happy to have Dr. Aya sitting here. She represents the NTD as a regional advisor for Southeast Asia Regional Office. Dr. Aya, thank you so much for joining. Now, WHO guidance is always there, and for LF program, we had two pillars. One was mass drug administration, and second was morbidity management and disability prevention. I will like to, invite Dr. Rinku now, because India is a very big country. And if we assume that any NGO from outside will come and try to eliminate a disease, it's impossible. Unless the government of India, Ministry of Health, and the respective department takes it on, that yes, we will do it, it won't happen. So I'm very happy to inform everyone that NVBDCP has transformed this program, what was there in the past and how it has come up. We will be hearing from Dr. Rinku what are the key things which the program has done, what are the key modifications the program has done, and what is the message the program wants to give to all of us. Dr. Rinku, over to you, please.
Thank you, Dr. Badri, for bringing this question. As all of us are aware that earlier the program was based on two global strategies, the MMDP kits and the MMDP, Morbidity Management and Disability Prevention, and the MDA. So recently, like in the last 3 years, there is a lot of changes and lot of advocacy, not only at the national, the state and district level. And we have come up with the 5 strategies. The earlier one was like the mass drug administration, MMDP, morbidity management, high-level advocacy, which is the game changer. Earlier, mass drug administration, which was, we are doing so many years, but we could not see the impact at the field level. Now, with the high-level advocacy, which was the mass drug administration, which was doing in the piecemeal at the own pace of the state and or at the ease of the state. Now it is a national movement. At the national movement, the MDA is now being done across the country. Currently we are observing the 2 MDAs in a year. Now we are more focusing to have a single MDA from in the coming year. So it is become a national movement, not only at the state, at the national level, state level, district level. It is being monitored at the highest by the highest administration level, from the Honorable HFM, they launch at the national level, state, the MD and HM at the state, Honorable HFM at the national level, and the state NHM, or the ministers at the state, and being district collectors are involved. Once the MDA is done, for monitoring is also being done regularly. So that, even the involvement of the medical colleges. Earlier, the country is being reporting MDA coverage sometimes, though we achieve more than 65% in the last in few MDAs, but recently because of these changes, being monitoring at each and every level, we could see an involvement of the medical colleges. We could see the highest, the more than 90% coverage at the field level, which being also the findings corroborated by the WHO and the medical colleges. So in the last few years, there is a major changes which we have seen in the program, not only in the advocacy, but also the financial ownership that the government of India has taken. So earlier, you must be knowing for the MDA, as sir has also told, that we take the medicine on donations from the international partners, but the government of India has taken the ownership for these medicines. Now we are procuring all these, except for albendazole, but albendazole is being procured for other programs, but REC and the ivermectin, we are procuring ourselves and as more and more mapping is being done, more and more states and more and more districts are coming up as a LF endemic, but at the same time, we are strengthening the surveillance. So many of the blocks and the districts are they have they are like coming out of the LF, and they are reporting MF survey, MF rate less than 1%. Not only for the drugs, but for like for the involvement of medical colleges for like coverage evaluation survey. The provision of the funds has been given for the medical colleges, and also the medical colleges for the early diagnosis and treatment. More emphasis are being given, because once the patient has a lymphedema, there is a difficulty in reducing or reverting it back. Now they are being involved in the initial level, so that the early diagnosis, more focus, as Dr. Tripathi has already said earlier, that we are not aware at the elite people or the medical colleges where the patients are being reported, they are not themselves aware that they are suffering from filariasis. And in the recent past also, the advocacy is being done, said these mass drug administration consumption in being done in the medical colleges as well. And moreover, like for the community mobilization, which is one of the priority, as we can see, one of our patient has come up, how the community mobilization has change over the period. The funding is very important for that. And the high priority blocks has been identified based on some indicators, MF rate and coverage rate. Those high priority blocks has been given more intensive funding, so that we can have a more social mobilization at the local level and more consumption of the drug. And even further, like the surveillance though recent, till now we are getting funding from the partners for surveillance, for TAS, pre-TAS and all those, but the government of India is also focusing on that, so that we have a indigenous kits which we can use for not only for early diagnosis, but also strengthening the surveillance. So these are some of the government of India initiatives which help us in bringing the program to a level, so that we can focus towards the elimination much before the global targets. And also these are the government, but the intersectoral, which is very, very important, the government of India has come up. We have many, many ministries and the programs which have a reach at the community level, like the Ministry of Agriculture, Youth and Affair, Education, all they have been involved into this, rural development. So they have all been involved for the community mobilization, and also the partners that have a good role, like WHO, which is helpful for us, giving the support for not only technical, but also for drugs donations, and also the PCI, CFAR, we can see, and the GHS for advocacy. All these, I think it is a comprehensive effort which we can see the effects in the community. So thank you so much.
This is really, really helpful. You know, those of you who have worked in polio program in the past, we used to be very, proud, quote unquote, that we had eradicated from India. But when we started working in LF program, then we realized LF elimination program is the largest public health program in the country. Why? Because in polio, our target age group was less than 5-year-old children. That's it. And what was the mechanism? 2 drops. Simple. In LF-MDA program, the whole population is your beneficiary, except for less than 2-year and pregnant mothers. Second, you don't have one pill. If it is a triple drug therapy, you have 7 to 8 pills to be consumed. And that too with adult and youth and everybody who is healthy. So it's such a big program, a challenging program. Kudos to the Government of India and NVDCP that they have taken on. We will eliminate this disease. So once again, thank you, madam. Thank you so much for reading this from the front. Now the question here is, what happens next? And what happens in areas where they have cleared the program, like the whole transmission, but when people come from the endemic areas, what happens? What are the various type of things which can be done to figure out, okay, if the transmission is going on or not? Or what happens if people say, oh, there is a drug resistance coming up? Who is the body who will check and let us know what should be done? So let me invite Dr. Manju Rahi, who is the director of ICMR VCRC, Vector Control Research Center, and she had been a great support for the program. And we would like to hear from her, once we reach towards elimination, what are the various mechanisms? How do we track vectors? How can vectors be utilized to understand if transmission is there or not? Dr. Manju Rahi, over to you, please.
Yes. At the outset, thank you so much, Dr. Tripathi and the BMGF for inviting me here for this panel discussion and actually bringing at the forefront the discussion on LF, which is so much needed. And NTDs no longer truly need to be neglected. So I'm very happy gradually the room has filled up, Dr. Tripathi. So good to see that people are interested in the disease, and so much has been talked about it already. Taking the cue what Dr. Badri and Dr. Rinku and Dr. Tripathi has output in the open, vector control, vector monitoring becomes a very important aspect of the disease control, and elimination story of the LF will not be complete till we do and manage the vector part of it. Dr. Tripathi is hinting at when we complete the elimination story, or we reach that level where we can say it's eliminated, what do we do? How do we monitor? Here comes the aspect of xenomonitoring. So when we say xenomonitoring, broadly it is defined as detection of the human pathogen, the DNA or the RNA of that parasite, here the Wucheria bancrofti, in the vector itself. So this is, it's a kind of a proxy tool or a complementary tool for human surveillance. Pricking people is difficult, reaching out to them is cost intensive, human surveys are not simple. Usse acha hai, just go catch mosquitoes and just see if the mosquitoes are infected. So one possible case scenario, and will be done and is usually done by the research organizations like VCRC, we do xenomonitoring of the mosquitoes to see, okay, human beings are free of the parasite, whether mosquitoes are free also or not. Because they are the bridge between and they contribute to the chain. Between the parasite and the human infection, in between there is a vector. So that is one case scenario when LF has been eliminated. Otherwise also we can track whether the elimination program is doing its job or not, whether truly we are moving towards transmission or not. We can assess the infection rate in the vectors and see how much infection rate is happening in the vectors, whether it's too intense and at par with the human infection or not. So we can do some comparisons, come up with some figures which are comparable, and there also xenomonitoring will come very handy to assess the transmission intensity of the LF. And we can also use this xenomonitoring in the scenario of assessing whether one area has cleared off. Do you expect a resurgence? Can we assess resurgence of a disease? It can be even implemented in other diseases like malaria or Kala Azar. Ab sabse pehle to mosquito infect hoga, then the human being will get infected. So if a area has been totally cleared off of any vector-borne disease, we can assess the mosquitoes and kind of predict or anticipate any resurgence or outbreak. So these are multiple scenarios for xenomonitoring in that area for LF. And for lymphatic filariasis, VCRC has been working from 1980s and much more in the past 20 years. We have developed robust tools and come out with robust estimates of assessing infection in the vectors and correlating it with the human beings. So we are about to launch a study. It has already been funded by Gates Foundation. I'm very happy to announce it here, which will assess the rates of infection and bring out what is the correlation between vector infection and human infection. This will be a very informative tool. We're going to position xenomonitoring as a national program strategy in selected areas, which will be a complementary tool to human survey. Looking forward to reducing the burden of human survey. So that is about the xenomonitoring. Thank you, Dr. Tripathi. If we have more time, can I also talk about vector control? Or right. So just very briefly about the role of the vector control in LF transmission or LF program. And as Dr. Rinku rightly pointed out, till earlier it was only two strategies. Either it is MDA and also MMDP. And the more or less the stress is on MDA, multiple rounds of mass drug administration in the population. It's not a joke, it's a huge task for a country like India. So MMDP also is given sufficient attention, but in 2023, 5 pillars was announced by the Honorable Health Minister Mansukh Mandaviya ji in 2023. One of the additional pillar was vector control. And vector control, to bring attention to it, it's very important that we talk about the right aspect. The vector is Culex quinquefasciatus. It breeds in a dirty water. It's all over India. It's highly abundant. How do we talk about it? For malaria, the strategies are clear-cut. It is indoor residual spray and L-line. What do we do about Culex? Vector control has never been spoken about in general, or a lot of brainstorming sessions have not been done. Vector control tools have not been delineated for LF, but there are strategies. Dr. Badri talked about integrated vector management, integrated vector control. So that is one of the strategies where we can control other vector-borne diseases in general also. We are talking about mosquito nuisance. रीना जी, आपके गांव में कितने लोगों को मच्छर काटता होगा? कितना ज़्यादा मच्छर होता होगा? सारा टाइम वो मच्छर कानों में भिनभिनाते हैं ना, वो सोने देते हैं. तो mosquito nuisance is all over the India. And now with dengue, we are talking about Aedes, which is a day biter. So I think the call of the day is integrated vector management, and we should be a strong proponent for it. And vector control basically can become a complementary tool to the MD and other strategies. The scientific part is it decreases the longevity of the vector and reduces the chances of the transmission. So there is a science behind it, not just killing mosquitoes indiscriminately. We can, for the moment, think about implementing vector control in a very limited area of the hotspot, because implementing vector control throughout the country will not be very easy, seeing the size of the country. So we can discuss with the program where the data shows that the years of MDA have not been that useful in bringing down the microfilaria rate. We can do targeted vector control on those so-called hotspot areas, and we can begin from there to show the impact of vector control. So the usual strategies are larviciding. There are multiple products available for larvicides, BTI or some beads, and there are other guppy fishes. All these strategies are available for larviciding. Environmental modification, again where we talk about IVM. We can do modern tools also can be used, like geospatial mapping, digital tools, drones for spreading of the larvicides on the canals where the Culex is breeding. So a lot more can be talked about on vector control. A dedicated discussion needs to be there, which we will do. So basically we can do these two things to immediately support the national program here and to support other agencies. I'll take a pause here. Thank you for bringing in VCRC and bringing up the topic of vector control here. Thank you.
Thank you so much, Dr. Manju. I think, without both the arms working together hand in hand, we will never achieve any elimination or sustain the elimination. So thank you so much, both program and ICMR bodies, to be being here. We are very lucky actually to have passionate leaders with us, because if the government leaders are there, then the whole group comes and works together. So we are thankful to both of you. We'll move ahead. Now I just want to know from all of you, have you heard of a movie Tare Zameen Pe? Anybody? Have you seen that movie? Anybody? Raise your hands. Okay, fine. What was the message in that movie? Was there something which was brought up? What the child, the boy actually suffered with? How many of the people in the country would have known about dyslexia had it not been the movie? So, sometimes we need champions, sometimes we need some occasions or people to advocate for a cause. It's not very easy. See, science books are already there. They are like in encyclopedia, they are like everywhere. How many of the medical doctors and scientists talk to common people? We don't talk to common people. We talk among ourselves. You go to conference, professor is sitting here, a professor is sitting there. We are talking to ourselves. Now we need somebody to come up and expose the message for a larger population. Even ministers we have discussed, they are all our people who have become minister today. IAS officers are there. Those who have never lived in an endemic area, they would have never seen a patient. They have no clue what is lymphedema. But somebody has to go and try to tell them, sir, madam, there are diseases like this. Because you won't find these patients in malls, shopping malls, in markets, or in the playground. They're all hidden. They try to hide their own stuff. But as responsible citizens, we need to raise their voice. So to raise the voice and let higher people know about this to make policy decisions, and how to bring private sector into this, we need organizations to sign up. I'm very happy to say that Madam Anjali Nayyar, she is sitting over here. GHS has done a lot of work on that. Let's hear from her how she had increased the visibility of LF in the country with respective people at national level, state level, and how she has brought in the private sector for this particular thing. Anjali ji, over to you, please.
Thank you so much, Dr. Tripathi. Thank you Can you hear me now? Okay. Thank you so much, Dr. Tripathi, and thank you for inviting me and even your kind words about global health strategies. You know, I recall the first time global health strategies got involved with neglected tropical diseases was our CEO, David Gold, who emerged from the HIV world, decided that he needed to work on the issue. And the first thing he wanted to do was bring CEOs of companies together and get them to commit to A, provide the drugs, and B, invest in R&D. Because if you know, while NTDs affect a large number of people, companies don't really invest, and it's a disproportionate investment. And this was in 2012. And then I have to say that I really started working on NTDs thanks to you and Professor Ganguly. And today, you know, I'm a member of the Consultative Forum on Uniting to End Neglected Tropical Diseases. And in India, NTD has become a national priority, particularly as we look at LF. And this is largely due to the consistent policy and program action by the Ministry of Health, and it's sustained by high-level engagement and, as mentioned before, increased resources, because those are the things that show. And this all really started, I do want to bring in the contribution of Professor Ganguly and Dr. Tripathi in 2019 and 2023, where 2 national symposiums were held and recommendations, very specific recommendations were made out, which went to the government, and the government started moving forward. And those symposiums were the setting stage. Today, we do have high-level political prioritization, and you take it from one health minister to another, whether it was Dr. Harshvardhan, moving on to Mr. Mandavia, and then Mr. Nadda. All of them have called for commitment to make this, to talk about elimination of LF. And they not only are talking about it, but they've addressed MLAs and MPs. And we worked with some of them where they've taken the medication in front of their constituents to show that there's nothing wrong, and this should be taken by people who live in endemic areas and healthy people who live in endemic areas. So that has been one. And you know, 2 examples I want to give about 2 states, UP and Bihar. In Bihar, the health minister, Mangal Pandey, made a commitment to make Bihar hydrocele free. And after his commitment and push, 72% of the hydrocelectomies were taken care of in the last 8-9 months. So I think those are some of the things, which is not to say that the job is done. We definitely need to go for that last mile push, which is always the most challenging. So we need communications, we need champions, we need people. आप जैसे रीना देवी, आपकी तो मैसेज जगह जगह पे देनी चाहिए कि कैसे कम्युनिटी से लोग उभरते हैं और फिर जाके दूसरों की ज़िंदगी भी सही करते हैं. अपनी तो करते ही हैं. So I think we need to do that. About private sector partnerships, I think when we talk about partnerships, some, not all, are necessary institutional partnerships. We see Reena Devi's stories. We see how ASHA workers work with religious leaders to go out. PRIs are a big partnerships that happen. But I want to give a couple of examples to say that, you know, we worked very closely with Reliance Jio, and they did SMS campaigns close to about $700,000 and spread messages all over, which was a big success. We also involved Rotary. And a lot of our public-private partnership work really has borrowed from the polio program. So that has been a great thing. I think the second one I want to mention is about Khadi Gramodyog, where they made the commitment to hire people with LF and particularly those who have been disabled, and give them jobs and employment. So I think those are the kind of examples that need to be showcased so others emulate. To last point, one of the things we've learned is that people are driven by an end goal, particularly as they see the end goal in size. So whether you're talking about partnerships, whether you're talking about advocates, whether you're talking about even the excitement of the government, as they see the end goal, they get excited, but there needs to be this constant push. So I think having conversations like this is really, really important. I also want to thank Manoj Bajpai. He's not here, but one conversation with him helped him to come on board and do these short films, which most states now use as they go for MDA rounds.
Thank you so much, Anjali ji. You know, each one of us should be ambassador, not only for LF, I would say, public health. And wherever we go, wherever we discuss with anything, if we have any low-hanging fruit, which we know of, we should disseminate the message. There is no program in the world where you achieve elimination with such a small effort. Triple drug therapy, if everybody consumes, we are done in 1 round actually, maximum 2 rounds. But this everybody is a big catch here. If in this room we are 100 people sitting, even if 60 people take the drugs, they kill off the microfilaria, 40 people don't take, I don't take. What happens? Mosquito will come and bite me. It will go and bite again those 60 who have taken the medicines. So this messaging of left out, people who have not consumed, should be communicated. And it should not be seen as a government program that you guys are every time coming and pushing us to consume drugs. No. The program should be, on the other hand, people should feel FOMO. Oh, I did not get this time. Where is my medicine? And I'm telling you, if any one of you go and talk to people in the community and tell them that this is the lowest hanging fruit, once a year, couple of tabs, done. They actually say, forget about MDA campaign, tell us where can I get the drugs. And interestingly and luckily, these are one of the cheapest drugs available in the country. Not more than 20 rupees, all 3 drugs. I ever met during COVID, everybody has gulped like anything. You all remember that, isn't it? So the point here is that communication reaching to people? Because today, assuming there is a campaign happening in Delhi and the workers are going house to house, are we going to meet those workers today? All people sitting in this room? None of us. And this actually happens with Asha sisters also. When Ashas go to house, those who are good, who are going for livelihood or studies, they are not at home. How to catch hold of them? So community mobilization and making community understand the importance of the disease, importance of intervention, and feeling accountable that yes, I have to get this done. That is a very important topic. So let me move to Rashri ji. She is the director of NTDs at PCI India, and they have done extensive work on social mobilization. So Rashri ji, what were the key things which you guys have done, and what were the results you have observed till now? Over to you, please.
Thank you so much, Dr. Bhupendra. And we are so pleased to be part of this discussion wherein it is such a huge canvas. As my other colleagues, they have shared that every household in the endemic area has to be visited. Every household has eligible people who should consume drugs, antimalarial drugs. Now, if I may ask a question who are sitting here, if you're not sick or ill, and if somebody asks you to take pills, would you be interested taking it? The answer might be no. So that happened when we started the journey along with the NCVBDC team, wherein the story or the communication had to go to the communities and motivate them, prepare them to take 4, 6, 7, 8 pills, despite they are not ill. So it was kind of a journey, and I would say it is a onion peeling effect. As we moved in, we started getting the reasons. We started getting the understanding of why people are not. And we started learning, we started digging in the reasons, and we found with our data that multiple iteration through multiple sources increases the likelihood for people to get convinced and adhere to DOT, because this program promotes only DOT. And DOT is the person has to consume drugs in front of the drug administrators. And as Dr. Tripathi was mentioning, Asha Didi, she's trying her level best, but then still there are areas, opportunities, contexts where she is not getting interface directly with people or the communities. And hence we brought in the ministries who have last mile connectivity or last mile reach. And we brought in various ministries, education department, having schools and colleges in every village, in every locality. We brought in the SRLMs, the State Rural Livelihood Mission, wherein the SHGs are in all the villages, the women's are there in every hamlet, bringing in the NSS volunteers through the colleges, bringing in the tribal development department who have their own penetration in the villages, bringing in the like ICDS, these all department, and hence the intersectoral ministerial or interministerial convergence became one of the key areas or aspect to reach to the communities and communicate to them in a very, very effective manner. So the blanket was over, but then as I shared, it was onion peeling effect. When we moved in, people who were getting information, they were getting convinced and not. And then we got an interface with the communities who had tough questions, the refusals. And they had very, very different questions. जिनको है बीमारी उनको खिलाइए, हमें क्यों खाना है? We are not, हमें तो फाइलेरिया नहीं है, so हम क्यों खाना है? And then that, so in a village, when we went to a household, if a household is of 6 members, 4 were convinced, 2 were not convinced. So it was that level of, varied questions and varied situations, varied contexts, which required a very, very customized and tailored approach. So this is a area wherein with the support from NCVBDC, the refusals communication started getting in. While we were getting into this, we realized there are migrants in the villages. And there were again, when we say migrants, there were various variety. Few people who goes out, come back in the evening. Few household people, they go out, but comes once in a week, monthly basis, आधा साल में एक बार. So this came as another challenge, and that became another question to be solved. And again, while we were solving this, we realized that there has to be very, very customized approach for drug administration in the program, like Asha's getting the list of the migrants, and then seeing that if they're migrating in the areas where the drug administration is happening, or if they're going to the MD areas, how it can be communicated. The other could be, there would be people who will be coming back during festival or during some kind of farming season, if there could be some customized drug administration processes which can be available, so that as we have to cover 65% of the population, everybody gets an opportunity to consume and be safe from this particularly deadly, dangerous disease, or the disease which affects the life, as Reena shared with all of us. While we were doing this whole intersectoral or interministerial work, we got humongous support from ministries like education, higher education, SRLM, and if I may quote data from the recent concluded February 25 MDA, there were around 250,000 youth in the colleges consumed anti-filarial drugs in their own college premises through NSS officers who were just oriented once. So this is the power of the interministerial convergence who can come together and convince and motivate people for consuming these anti-filarial drugs and be safe from this disease. So I take a pause, sir, here, and I'll be happy to take up questions. Thank you so much.
Thank you so much, Rashti ji. And Rashti ji has a team which basically works very closely with the workers at the last mile. They attend the trainings. They also work in refusal conversion. Now, friends, diseases are multiple, and we all understand many diseases are acute diseases. Like you have bite of a mosquito today, and within a week or 10 days you can have dengue symptoms or malaria symptoms. But for lymphatic filariasis, all of us know that this is a disease which will not manifest in next 10 to 15 years. And most of the time, kids are actually infected. You and me can still, shoo away a mosquito or kill a mosquito. What about kids? And they are like going to school, they are playing outside. You cannot track the kids every time. And the symptoms will come when the kid becomes a young, male, female, and then they are at marriageable age or working age. So the point here is how to make them understand. Now, in TV, if you see Revital tablet, you take, you are like free from all diseases. You take Chyawanprash, you are free from all diseases. How many people actually understand this triple drug therapy is not only for filariasis? Obviously for filariasis, not only for filariasis. It can actually also help for intestinal worms. It can kill the intestinal worms, hookworms, which suck the blood. It can actually kill the scabies ectoparasites. It also kills the, we have mites or other things in the body. It can actually kill those as well. How many people have communicated these messages that it's a one therapy with 4 to 5 advantages? Scabies is a big problem. It's an NTD actually. And people don't come out. If a family of 5 members has one person is having scabies, they will treat like only one person, but that person would have spread to second person, third person. It's a vicious cycle of scabies happening there. So point here is the messaging has to be very, very strong. And along with messaging, there has to be trust between the product, provider, and the person who is getting that. So how to build the community trust? Do we have sufficient trust in the community as of date? What else can be done to develop the trust? Let's invite Dr. Manmohan ji from Piramal Foundation. Can you please share, Manmohan ji, how you help the community and the provider to develop the trust? What are the various mechanisms? How can we do? How can the program improve the trust building between both the parties? Over to you, please.
Thank you. Just on the lighter side, that if you look at, I'm sitting on the corner, but half I'm looking this side and then this side. So otherwise, generally we look at one side, right? Whether it is science or the government or the community. So we are attempting to be, up at a place where we are able to see everything and then design the solution. I come from Jharkhand. I was NSS leader for my college, and I spent almost few years in NCC. So I have done volunteer work myself, and I was almost filaria patient. But thankfully, a Dr. Balmukundji saved. So I think one of the panelists mentioned about integrated vector control, that how do we look at integrated approach to be able to build a system so that doesn't matter what problem we need to solve, we have that system built. One learning we spoke about how do we involve community or community leader. So when we say we involve, who has the power to involve? Who decides that Mukhya need to be involved? So let's say I'm a government or I'm an NGO or I'm somebody, then I choose where to go, which Mukhya to involve, and how to involve. and then come back and give the report to government and मैंने तो ये कर दिया, देखो 50 से 70 हो गया, and then I will get a clap and then come back. And this particular problem, it gets solved. Or I will involve volunteer, I trained, oriented, got that work done, and then, we celebrate. I think our learning is that if we do not change from looking at community as a recipient of services to the co-creation of the solution, the problem will continue like this. And no matter what problem we want to solve, if power continues to be outside the community, the knowledge continues to be outside community, we will always have this problem. And therefore our attempt is to work with last mile institution. What is that? Panchayat. Who is the head? Mukhya. Ward member. Who are other people? Whether it is school or Anganwadi or Kisan. And there are multiple government institutions at the last mile. How do we create a platform which is a hyper-local collaboration level and create a process? Example, Government of India has done a fantastic thing that the SDG has been divided into local SDG and 17 SDG goal now converted into 9 themes. Can we have a LF Mukt Panchayat? Can you create that ambition and this goal get created by the community, by the panchayat, by the local volunteer and not by you or me? Right? So I think that, changing that, hopefully will create the space for the community to take the ownership. Of course, science has solved this problem. We have the protocol, we have the guideline, everything is there, but yet for last 20 years, MDA is going on and we have not solved this problem, right? So one problem is that, and I'll give you some example. I was in Jharkhand 2 days back, and one of the member told me, एक गांव में उन्होंने क्या किया, जब शादियां होती है तो पीला चावल और एक कसेली बिटल नेट लेकर के जाते हैं निमंत्रण देने कि आप आइए, निमंत्रण है. They use this for MDA. घर घर में सहिया जाकर के, सहिया is a frontline worker in Jharkhand, they went every house saying कि आप लोग को दवाई खाने आना है, दवाई खाने. And that increased 90% consumption in the village. There were a lot of refusal. There is a village in Arwal. There, in the beginning, the identified lymphedema patients and the LF patients were around 13. But when Mukhya got involved and created a plan, line listing was done by the Mukhya and the volunteer, about 32 additional lymphedema patients were identified. And at the power of that, how do we build trust? And building trust required giving power. A lot of time, without intention, we'll end up judging that individual that what this person can do because you have not gone to his school and you are not aware. So knowledge as a power, if it continues to be outside the community, maybe the trust building may not happen. So that's the core learning. There are plenty of examples that how in Bihar, Jharkhand particularly, we work in 62 districts. There is just one district where we have stopped MDA. So if we need to achieve the 27 target, I think we need to do this plus Jan Andolan. Example, certification. Jharkhand has 54,000 lymphedema patients. We did around 4,000 certification is done. But what about 50,000? That need to be done so that they get 1,000 rupees a month, which helps those patients also to live a life. So I think there are multiple such things, but the core is how do we sift power? How do we sift our knowledge? How do we sift from recipient to the co-creation so that they have the ownership and therefore the change required? Thank you.
Thank you so much, Manmohanji. And I think, I should also shift the power of speaking from this stage to this part. So there is no panel complete without, having audience asking question or sharing comments or experience. So we would like to basically, invite any one of you. If you want to ask a question, most welcome. If you want to share your own experience, most welcome. Or any ideas you want to share. Because see, this is a disease which has to be eliminated from this country. There is no reason why our future generation should suffer from lymphatic filariasis with all these drugs available. So let's start with, sir. Please have a name, designation, and question.
Yes, Thank you, and Professor Ganguly knows me very well. I worked in several years. When I was posted in Rourkela Field Unit of National Institute of Malaria Research, Dr. Tripathi, you don't believe it, malaria is Odisha at that time, and 90s, everywhere. And when I checking, I found Filaria parasites along with malaria. I published in that article. So then we started doing, Filaria routine surveillance along with the state government. 10% MF rate came out. Nobody knew of those cases. And then we started doing, that time only DEC was there, not albendazole, 1990s. And many patients came to us, and then as per WHO recommendations, we gave 6 milligram per dose of DEC to the patients, like she's here, and for 6 months, 12 days. It worked fantastically. And then in course of time, in 2004, I was also involved for this MDA program. I was only vocal about that integration of vector control. Nobody listened to those things, and now 2023, now it has been a part of that. Without vector control, no vector-borne disease is impossible. And that's it. And second part, I published, I requested you to share your thing,
Yes,
a very simple technique of, night surveillance of blood collections. I'll share my article, it's under publications. A simple thing, you take a drop of blood and in a fend of tube with, just, your blood, CPD. And you take it and bring it in the, camp lab and do a kind of a, weight smear checking. Because collection at night hours is very difficult. I have done several, and their efficacy is so good. Even in one slide, I got one parasite, but after staining, none is seen. So very simple. I will share link to madam. You can see it is under publications. And another question is that those patients with lymphedema, what is the microsurgery available today in the country, post-management? It's a very stigma, I know, in very villages. Right now, I am working as an advisor to the government of Karnataka on dengue. I find many migratory workers accumulated in Bangalore city. Madam, you might be knowing Yadgir district. First, Dr. Krishnamurthy came to me for MDR drug in the country. I was engineer to, execution of the projects in Yadgir districts. Dr. Tripathi, don't believe it, 33% MF rate came after so many rounds of MDA.
My goodness.
And it was a shocking for the program. Now what I'm telling to the BBMP, that Bangalore Mahanagar Palike, those patients coming from congregated migratory patients from Yadgir, Gulbarga or North Karnataka districts have a night survey there.
True.
These type of interventions are very important.
True. Agreed, sir. Fully
And these are the things I think, it will definitely have some impact on those aspects,
Thank you, sir. Thank you so much.
Yes.
Very well, valuable points. So I'll just, take the one point from sir, that what happens to the patients who are suffering with lymphedema? Unfortunately, the microsurgery or plastic surgery is not very successful. There is debulking happening. People are doing it. I will not discount that, but it has been not very successful. On the other hand, we had engaged with Ayush department, and there are institutes which work on yoga and Ayurvedic medicine. One such institute is in Kerala, in Kasaragod. I can give the details separately if you want. They have shown remarkable change in the lymphedema swelling. And 2 centers in UP and Bihar, Ayurvedic Medical College, we had opened those centers. So we can give those addresses to you, which you can circulate to other people, and they can take the advantage of that. Thank you, sir. Thank you so much. Any other comment? We have just 3 minutes left. And yes, please.
Thank you. And thank you all panelists for this nice information. Just on integrated vector control measures, I just want to say can we initiate integrated communication on integrated vector control? Because when there is malaria control program is going on, only malaria, malaria, malaria.
Very good point.
When there is dengue program is going on, dengue, dengue, dengue. So when we are distributing LLIN, we are giving just one message, it saves you from malaria. But I think a message if you include dengue, malaria can be saved by using mosquito net, then I think that will be a big initiation for integrated vector channel, means control. Second part is like mapping of LF cases or how to gather support from grassroots level. So as per my experience of working in tribal area of Telangana, Chhattisgarh and Maharashtra, in tribal area they have a very big and good network of local traditional health healers. So those people who are trying to avoid hydrocelectomies, they have their own ways of having some jadi booties. We are seeing this pinnas of ear just to get the problem solved. So if they are enrolled in the program, they have a good control over the community belief and saying on what to do for that particular a thing or not. So I think if we can enroll them in our program, although it may take some time,
Agreed,
so
Dr.
definitely
we
it
have
will be
no
a big
time
things.
left now. So thank you so much for your valuable comments. We will do that. Sir, behind, Rajat, behind you. Sir, very short, very specific. Yes, please.
Hi, yes. So just a brief remark. So I am Abhishek Bhatia from the Health Diplomacy Alliance. Currently, globally, at the World Health Assembly next month, there will be a negotiation on the Global Action Plan on Skin Diseases, wherein an integrated approach towards skin-related NTDs and even non-communicable skin diseases, wound care is happening. So I just wanted to raise that aspect, given that these diseases have etiologically not in dermatology in origin, but the manifestations and the stigma and the management is all around dermatology. So just wanted to bring that aspect of skin diseases and that it's happening at the global level. And just to know your thoughts on at the national level within India or even in the Asia Pacific, are you seeing that type of conversation on integrated skin diseases wherein all of these aspects are featured? Yeah, thank you.
Thank you so much. I can answer this question because it's a new phenomena starting from headquarters. We have to do it in India, no questions. And CRO, yes, Dr. Aya, please. Yes, okay, separate. So, yeah, good point. Yeah.
I will be quick. I have a question. I think, it's an excellent, very comprehensive panel discussion, so thank you very much for having this. And I fully agree with everything said in this panel, and especially this community ownership, extremely important. You think NTD, maybe the community will never own it, but it's not true, because I was thinking of one example where I was in Indonesia, one of the NTD called schistosomiasis, not in here, but then so they had a very good progress on MDA every year. Prevalence went down very low. So the government decided to shift from the MDA to the selective treatment, meaning everybody who think you have a disease, you come forward, test. If positive, you get medicine. Then people stop coming, right? Then community started to ask government and WHO, please shift back to MDA. Because if this way, even I take medicine, my neighbor not taking medicine. So we need the MDA. Yes. So if Indonesia, the small community can do it, Indonesia also is a huge country, right? India can do it. Yes. But then to do that, I think this, India has so much progress in advocacy, huge advocacy. I'm always happy the government always say NTD is no longer neglected diseases, priority disease, right, in India. But how do you cascade and sustain this high-level advocacy to the state level, district level, the community level? And how do you sustain? And then maybe good thing, maybe running from what you mentioned, is to give the motivation or acknowledgement for everybody who's working in district, state district, and to see what they are doing. And if they are doing the excellent job, and we give a feedback and acknowledge. But do you have a system at the state level, from the national level? Of course, you can monitor and acknowledge. But from the state to the district to the community, block level, maybe do you have a system to monitor and acknowledge formally of the MDA coverage in a formal way?
So
I can just one line that yes, this is happening. Health Minister Bihar wrote letter to 8,000 mukhias at the panchayat level for their work. So there are those initiatives going on,
Very
but of
good.
course we need to do a
Yeah,
lot
yeah.
more.
So I just don't have time. They have already told me you will be out of this room in 2 minutes. So yes, I have very good point. I think WHO team is doing monitoring and program is accepting that data. So great point. Well, friends, I'll have to stop here. But those of you who don't know whether you are from a LF endemic area or not, we have some LF fact sheets kept over here. You can just pick up the fact sheets. You will have the map of the country and the districts if you belong to that area or not. Before ending the session, I would like to hand over to our chair, sir, Ganguly sir, for your remarks, sir.
One of the things which I see here, great partnerships, and this was so much evident today, very, very rewarding. The main, another thing which I saw with Anna Fleischer's triangle, that ultimately it is the political will and political commitment. So from Dr. Sharma, from Anjali, we heard that, and I have seen Anjali in action. I have accompanied her to Vajpayee ji in the past, to Mr. Abdul Kalam in the past. She can open the door, so we need such people in this partnership to really move forward. The 3 or 4 just bullet points. One major achievement is this, that involving what Manmohan Singh ji said and what Reena ji said about, and the trust building what we heard today, actually moving a survivor. In cervical cancer it has worked wonders. So moving a filaria survivor and the mukhiyas at the grassroots whom people trust has been a great, great experience. Another big achievement which I heard from Dr. Sharma, because we were really completely shattered because of the procurement. Because you need to get surveillance data, the procurement was happening. So India doing procurement is a great, great news. So that is something which is a game changer over here. The commitment to surveillance and the surveillance tools which have emerged, and which one of them, Dr. Ghosh also said, was again something which will be a real game changer. And what Manju said about the environmental monitoring, which happened in the polio, that you got it sewage when there was nothing in the xenodiagnosis. So that again something which is important. And she talked about drone. Actually with the drone you could get the vegetation, you could get the precipitation, you could get the rainfalls, you could also get the temperature. All of these climate changes are very, very important. We talked about migration, because with the drought, with the flood, with the others, the poor migrate, and it is disease of the poor. And the migration map is also very, very important. So this was also emphasized. Finally, the 2 other major messages are which have come up are that this ultimately creating a system, ecosystem, where people will take the drugs, all of these drugs. And also an ecosystem where we integrated with other diseases, which we talked about, and one of the audience talked about integrated communication. So that is very, very important. And financing was also talked of today. And so all of these things, if we take together, we are really moving forward. And I thank Bhupender, who has been a great, great advocate all the time. So today's this discourse was one of the best which I have ever attended. Thank you very much.
Thank you, sir. Thank you so much. Round of applause for chair, sir, panelists, and most important, all of you. Thank you so much for attending this. Moving forward, each one of you is our advocate. LF-free India, LF-free world. So we have fact sheets. Please do collect and have your lunch. Nice meeting all of you. Thank you so much.
So wonderful to see you here.
I just want to thank everyone.
I have met triple the journey has been long.
I hope people go energized.
So I will start here, just to make sure. भैया कहाँ से on है? On है? Ladies and gentlemen, a very good afternoon to all of you. ठीक है, it's fine. I will just start the session, that opening part, and then I will come here and sit. It's fine? Yeah, that's fine. Could you send me that presentation? I have this one. Oh, why don't you just send it to them directly?
ladies and gentlemen, colleagues, distinguished guests, and respected panelists. A very good afternoon, everyone. I'm Aarti Garg, working with World Health Organization Regional Office based at New Delhi, and as a focal for health emergency, I look into the fragile, conflict, and vulnerable settings. On behalf of World Health Organization, it is an honor for me to welcome each one of you to this panel discussion titled Bridging Climate Change, Migration, and Health, a collective approach for sustainable solutions. This is being held as a part of World Health Summit. We do see the chairs are still filling in. We do understand it's a post-lunch session. So hopefully, if we start on time, we'll have more audience joining us. But nevertheless, we have a respected honorable chair. We have the respected delegates. So we begin on time. And with this, with the permission of chair, I will mark the session open now as a welcome remarks to all of you. Once again, a very warm welcome to the experts on the dais, to our distinguished guests in the room, and all the colleagues working at this area of work, climate change, migration, and health. In today's interconnected world, migration and climate change are an undeniable reality. Climate change is increasingly being recognized as both the driver and outcome of human mobility. The health implications of climate-induced movements are profound and multifaceted. You will hear more from our panelists during the discussions as the session proceeds. So we are privileged to have a distinguished panel of experts and leaders working at the critical intersection of migration, climate change, and health. To outline the objectives of this session and set the tone for our discussion, allow me to please invite my colleague, Ms. Faustina Gomez, Technical Officer for Climate Change at Regional Office Southeast Asia, WHO. Thank you.
Thank you, everyone. Thank you, Aarti, and good afternoon, everyone. To set the stage for today's conversation, I'll walk us through the key objectives of our panel discussion and why this dialogue is both timely and critical. So as climate change accelerates, we're witnessing a growing number of people being displaced within and across borders. These mobile populations are often excluded from national health strategies and left vulnerable to compounding risks, be it lack of access to care, poor living conditions, and disrupted continuity of services. At the same time, our health systems, already under strain for multiple shocks, are being called upon to do more, to prepare, to respond, and to adapt in the face of climate emergencies, often without additional resources. This panel aims to bring actionable insights on creating resilient healthcare systems that meet the needs of mobile populations, strengthening mechanisms to safeguard access to healthcare for mobile populations in line with SDG 3, good health, SDG 10, reduced inequalities, and SDG 13, climate action. Through forward-thinking strategies, integrated policies, and strengthened governance, the session will contribute to advancing health equity and sustainable development in a rapidly changing world. So the core objectives of the session are threefold: integrating the needs of migrant and displaced populations into national climate and health systems and policies, strengthening health systems to be climate resilient and migration inclusive, fostering cross-sectoral collaboration for policy coherence. Through this session, we're hoping that our esteemed panelists are able to highlight promising practices that strengthen the resilience of health systems to climate shocks while also being inclusive to migrants and displaced populations, showcase country experiences and institutional models that are working across sectors, be it health, migration, climate, disaster, risk reduction, to advance equity, and to explore how research, data, and governance can align with the identified priorities. The session will run for 90 minutes, beginning with an opening and introductions, which is currently going on, which is for 15 minutes, the panel discussion for 50 minutes, an open discussion or Q&A with the audience for 20 minutes, and finally, closing reflections from our Honorable Chair for 10 minutes. Now, over to you, Aarti.
We will now begin with the introduction of the panelists on the dais. We are truly honored to have with us Professor Vinod Paul as the chair of the session today. He's a distinguished pediatrician, a public health expert who has played crucial role in shaping India's healthcare policies and landscape. Currently, since 2017, Dr. Paul is serving as a member of National Institution for Transforming India, Niti Aayog, the premier policy think tank for Government of India. He leads the health, nutrition and education vertical, contributing significantly to the national health policy and program. Sir, it's truly our privilege to have you amongst us and for you to agree to chair this session. We extend once again a very warm welcome to you and our sincere gratitude for your presence. Over to you, Faustina.
Next we have
We're just introducing the panel and we then begin with the session, sir. Sir, as you're comfortable.
Sir, we'll do the introductions first, if that's okay with you. Sure. All right.
Continue with the introduction of the panel on the chair, on the dais, and over to Faustina for the next panelist introduction.
So next we have Dr. Jabindra Prasad Pandey, Undersecretary at Nepal's Ministry of Health and Population, who heads the Population Management and Information section. With over 20 years of experience, he leads national efforts in population policy, data systems, and civil registration, focusing on health rights and evidence-based planning. A warm welcome, Mr. Pandey.
It is our pleasure to welcome Dr. Sirasit Satirachorn Kol, Deputy Director, Health Administration Division, Office of Permanent Secretary, Ministry of Public Health in Thailand. Dr. Sirasit brings a wealth of experience in public health planning and has been instrumental in advancing inclusive health policies for migrant populations in Thailand. Notably, Thailand is a champion country for the Global Compact for Safe, Orderly and Regular Migration and continues to demonstrate leadership in integrating health into migration governance. We are honored to have Dr. Sirasit and with us today. Thailand's experiences and insights will be a great learning.
Next, we have Dr. Santino Severoni, who's the Director of Health and Migration Department at the Healthier Populations Division at the WHO headquarters in Geneva. He leads the WHO global work on health and migration. Dr. Severoni is unable to join us in person today, but he will be represented by Dr. Aarti Garg, who is the Migration and Health Lead for WHO CRO. And Aarti, on behalf of Dr. Severoni, will be presenting key insights on system strengthening and governance.
It is now a proud privilege to introduce Dr. Poonam Dhawan, Director of Migration Health Division within Department of Mobility, Pathways and Inclusion at International Organization for Migration. Dr. Dhawan is responsible for migration health policies at IOM and has over 2 decades of rich international health experience. She provides strategic leadership and oversees all migration health programs, working closely with member states, UN agencies, and a broad range of partners. We are delighted to have you, Dr. Poonam, today.
Next, we extend a very warm welcome to Dr. Adil Sharif, a medical doctor and passionate advocate for migrant health. He serves as the Vice President for Migrant Health at the Mission for Migrant Workers Maldives, MMWM, a non-profit organization he co-founded in 2020 to address critical gaps in healthcare access and legal protection for migrant communities. He leads efforts to improve healthcare access, policy reforms, and strengthen collaboration between civil society and policymakers in Maldives. A warm welcome, Dr. Adil.
Our next panelist is Dr. Tasneem Arifa Siddiqui. She's a professor in Department of Political Science, Dhaka University, Bangladesh, and she's also the founding chair of Refugee and Migrant Movements Research Unit. That's one of the Bangladesh's premier migration think tank. Although she's unable to join with us in person today, her insights will be shared by Ms. Faustina Gomez, who will represent her on the panel. Once again, a very warm welcome to all the esteemed panelists. And let's give them a big round of applause for their gracious presence and taking time to be with us today. It's now time to begin with the panel discussion. the things for which we've gathered here. And for this, may I now request for Stina to kindly begin the panel discussions.
Thank you, Aarti. Before we go ahead with the panel discussion, I'd like to remind our panelists that we have 50 minutes for the session, and we'll be asking each one of you one question, and you'll have about 6 to 7 minutes to respond. Our request to all panelists is to keep interventions concise and solution-oriented. Like Aarti said, our first question is to the chair of this panel discussion, Dr. Paul. So Dr. Paul, drawing on your deep experience in national policy making and health governance, according to you, how can cross-sectoral collaboration be strengthened to create coherent policies that address the health needs of displaced and migrant populations?
Well, thank you very much, esteemed panelists. Thank you, Aarti. Thank you, WHO. And thank you, the distinguished participants of this important and interesting session. You're bringing a new dimension to policy debate in a way. The health of migrants is important. The issues related to health and welfare and well-being of migrants become accentuated in the context of climate change, and truly it's very appropriate for us to start thinking about policy and program pathways to address this emerging issue. The note that you have circulated, and perhaps others may have seen, clearly climate change will accentuate migration of populations because the ecologies will change. Some areas will get submerged, not available for economic livelihood, and so on. Disease patterns would change, crop patterns would change, and so on. So therefore, while climate change itself is a huge issue in the context of every sector, and indeed for the survival and the welfare of humanity and more, when you see its consequences, one part of human misery is what it does to the migration of population. I like to also emphasize here that there's one other facet that you may like to keep in mind in this context. One, when we will move toward net zero efforts in every nation, then some areas where we have, let's say, coal or petroleum being the source of livelihood and economic will shut down. I like us to keep it in mind, and for a nation of our size, that aspect is also going to be very important, the displacement of people. But we also have a greater responsibility to respond to that because it's coming, it's visible, it'll happen on time. Just want to say, NITI is engaged in looking at how the transition to net zero would affect various sectors, and one of these very important point that we landed up with was this issue of closing of, let's say, coal mines in very large location of India. So please keep that in mind. Migratory population is typically for jobs, and for India, we see east to west migration in a very big way. We must also keep in mind that not all migrants have their families coming with them. Very often, the women, children, the elderly stay back, and they are also our responsibility. We must keep in mind that the recipients of migrants are benefiting with economic activities and their GDP and their, so they have a responsibility. Let me now divide this issue into acute issue, acute problem that we witness in COVID-19, and the chronic and subacute consequences that we may have as we move forward. So climate change, for example, would perhaps be creating scenarios which are slowly building up, but then there'll be surprises because acute events would also happen. So one framework that you may like to consider would be the chronic part, the acute events that would happen on top, and then catastrophic events which create upheaval. Now let's come to one such catastrophic event that we experienced in our nation, in the world. There was a huge population, migrant population, located away from their homes. And when COVID-19 pandemic measures were instituted on a scale, and specifically in relation to the lockdowns that occurred in the early phase, which we needed to prepare ourselves with countermeasures and to stop the spread of the virus and the chains of transmission. This was necessary, like it was necessary in rest of the humanity as well. At that time, how did we respond? And there are some lessons on the point that has been made about cross-sectoral collaboration. One of the mechanisms that was created for pandemic response was to bring in a whole of government approach. We created what is at that time known as empowered groups. So the union government had 10, 11 empowered groups created to mount a response to the pandemic. It included, let's say, an empowered group on oxygen, an empowered group on emergency preparedness, empowered group on vaccination, empowered group on economic affairs, partnerships, and so on. So the empowered group on economic and welfare measures was responsible for looking after this particular aspect of the situation. Empowered groups typically consisted of not only one major department, let's say home in this case, or finance, let's say, but it had other departments, and some of them only to add force to it and to push the, shall we say, as a force multiplier to say, for example, for oxygen, for example. It's railways, it's industry, it is health, but it was also maybe school education because we needed their help of sort to be able to do certain things. So this brought in synergy and power, shall we say, power of action together, and we benefited from this in every possible way. Through this, and steered by this, and in particular helped by the National Disaster Management Agency, NDMA, that exists in India, which played a very important role in this particular phase, we were able to mount multiple responses. Some examples are here. Special trains were run to move migrants from their current location to their home locations. Over a period of 34 days, more than 4,400 such trains ran, and they benefited something like 5.8 million people. More importantly, it was made sure that the migrant population going through this displacement had access to food. So a very large number of people, very large number of migrant families were given food through the public distribution system. If I look at the number, how many people benefited out of this, this runs into as much as 270 million people who received food because of being migrants. And of course, there was a larger pool of people being provided food in that period of time as well. Likewise, the communities rose to the occasion, and you may have more examples to share. Some of you who have been working in the field, that the communities themselves decided how to look after the returning migrants as they came back to the villages. Likewise, the opportunities for the work, we have a scheme called MG Narega, which guarantees work as a right by any citizen of India. So that work opportunity was given so that you could earn, and the rate of payment for the work was also enhanced. So this was another welfare measure that was brought into picture. The short point is that we rose to the occasion, but in order to make it happen, the sectors joined hands. It was whole of government, whole of society, state governments played their role, and basic aspects of care in terms of food, in terms of financial assistance was mounted. Having said that, we need to keep in mind that there are other dimensions. Health dimension itself is important. I'm sure we're hearing more about how to provide health to migrant populations in general, and when there is a special stress, how we handle it. Here, I wish to emphasize that India is fortunate because you have Aadhaar card, which gives you identity. You have Jan Dhan accounts where money and cash can be transferred. You have a deep penetration of mobile, which allows you to do all this using the power of technology. So we are fortunate, and this trinity, as it is called, was invoked in the course of pandemic in multiple ways, but also to help our migrant population. In summary, keep in mind that migration and health and climate change will give us acute shocks, chronic simmering, worsening scenarios with acute shocks. We need to have a response for chronic events and chronic scenarios being different, and that is something that I would like to come back toward the end after hearing my distinguished colleagues, give you an example of how in the face of something unprecedented, very acute, India in some ways try to do what we could do best. I want to emphasize, last but not the least, here that the responsibility for immunization, responsibility for child care, other care, is the business of where the migrants are. Our health insurance scheme, which entitles ₹500,000 coverage for secondary and tertiary care hospitalization, has a feature called portability. If I belong to Bihar, but I am currently working in Dadra Nagar Haveli, I have the right to seek care from institutions in the other Nagar Haveli through their administration and their government, and it will be taken care of. So portability of your access to health and your cashless care entitlements is one interesting way of ensuring what we wish to do. But this is just a little bit of a start. As a trigger, I like to learn a great deal from my distinguished colleagues and would like to come back later for a few more minutes. Thank you very much.
Thank you so much, Honorable Chair, for that excellent example and for insightful contributions on examples for multi-sectoral collaboration for health and disaster preparedness. I'm sure this will go a long way in helping other countries also develop similar models. Over to you, Aarti, for the next question.
Thank you, Faslina. So Nepal has extensive experience in managing significant public health emergencies. The country has demonstrated remarkable capacities while responding to devastating earthquakes and also, as Honorable Chair mentioned, COVID-19, the global challenge. We all know that during such emergencies, it is the migrants and the displaced which are disproportionately affected, particularly when it comes to the continuity of healthcare. So, Mr. Pandey, we're very fortunate to have you from Nepal with us today. We request you to please share how these experiences of handling the emergencies as a country have shaped the current or future health policies or practices or strategies for them to become inclusive of migrant and displaced populations. We are hoping if you can share some examples from Nepal that highlight migrant and displaced population inclusions in the overall health systems. Over to you, sir.
Thank you. Thank you, Aarti. Respected Chair, esteemed panelists, moderators, both moderators and audiences, good afternoon. As Aarti said, Nepal has experienced two devastating situations like earthquake 2015 and COVID-19 as well. In both situations, Nepal's health system was severely affected due to resource gap, means there was a shortage of resources. Also, the health workers and other manpowers were not fully trained on such kind of disasters, and
among people also. There was fear, a kind of terror in the case of earthquake, because after main earthquake there were several aftershocks, and people were really afraid at that situation. And many houses, about 500,000 houses were damaged, and around 15 districts of Nepal were severely affected by the earthquake. And other districts also affected, but severely affected 15 districts. In such a situation, there was a kind of crisis in the government sector also in the other NGO sectors, non-governmental sectors. All were afraid of earthquake. And after the earthquake, there was another epidemic, COVID-19, after 5 years of earthquake. In such situation, there was not all health facilities which were damaged in the earthquake were not fully reconstructed. At that situation, there was a problem to settle health services because of health facilities and health workers also not fully prepared for COVID also. In such cases, Nepal government coordinated with different ministries, government's ministries, also with non-governmental sectors, development partners, and many other stakeholders to cope with the disasters. Like in earthquake, there was immediately constructed a health emergency operation center in the Ministry of Health. Likewise, there was a National Emergency Coordination Committee under the leadership of Deputy Prime Minister. That was constructed, formalized immediately after the incidents. Similarly, in case of COVID also, there were shortage of resources, manpower also, terror, a kind of fear among people, and many people wanted to migrate from their workplace to the home place. To manage those people who wanted to migrate and go to their original homes, they have to manage by the government. There was a challenge to settle them in quarantines or isolations. Many difficulties were there. In such situation, there was a strong coordination between government ministries, between non-governmental sector, even in people. Civil society also helped for government for that situation. And there was a commitment, a kind of commitment among government stakeholders, even in government employees, civil servants, Nepal police, even army, other health sector supporters, development partners, etc., committed to cope with the incidents and work together so that our health facilities could be resumed, and even the health facilities were not fully in implementation phase, but with tents also we provided services to the people, and finally we became success. Also, Nepal is a vulnerable country by climate change. Like Nepal has geographical terrain like high mountains, hills, and plain tarai. There is, due to climate change, there is sometimes long drought, and then heavy rainfall, so that landslides and floods are the main disasters that usually come in Nepal. And in such situation also, Nepal has some strategies to cope with them. After COVID and earthquake, Nepal has made health sector strategy, and that strategy focused on resilient health services. Also, Nepal is now preparing national health policy. It's second time national health policy. Before this, there was first national health policy 10 years back, and now we are making second national population policy. In that policy, we have focused to migration health of the migrants people who migrate due to either from climate change or displaced people, or the labor migrants who go for employment to foreign countries, and they come and go. They have to be cared by health sector also. So the new Nepal national population policy is focusing on migrants' health issues also as well. Thank you.
Thank you so much for that insightful intervention. You mentioned about the resource crunch, and that becomes even more exaggerated when it comes to the vulnerable populations. Thank you for sharing how your policies are again being reshaped. There are efforts going on to strengthen the health systems and also preparedness part. You actually reiterated the fact that how this acute crisis, which Honorable Chair mentioned, will lead to movement. So migrants people wanted to move after these COVID challenges to their places of origin. Thank you so much. And we move this forward and over to Faustina for next question.
Thank you. So next, we'd like to talk about models for sustainable inclusive financing to support migrant inclusive climate resilient health systems. So my next question is to Dr. Sirasit. As Thailand faces intensifying climate risks, such as rising sea levels, floods, and heat waves, many migrants in informal settlements or high-risk sectors remain particularly vulnerable. What specific measures are being considered to ensure continuous access to quality health care for migrants during climate-induced disasters, and what models exist for sustainable inclusive financing to support migrant inclusive and climate resilient health systems? Over to you, Dr. Sirasit.
Thank you for the question. It is my honor to share Thailand's experience on these topics. Our country stands on the intersection of two urgent realities. First is a large volume regional migration. The second one is global warming, which impacts many, many countries in the world. With over 5 million migrants, many of whom live or work under informal and high-risk environment, when the environment struck, these are the high-risk population that we need to taken care of. To address this overlapping challenge, 3 core strategy has been utilized by the Thai government to ensure the continuity of care. First, integrating the migrant health into national emergency plan. Migrants are no longer an afterthought after the disaster struck. They are included into the national health emergency framework from when the policy was planned. Let me give you an example. Last year, we have a flood in Mae Sot area in northern Thailand. The mobile health unit is quickly dispatched to where migrants live and work. They provide basic treatment, vaccination, and also maternity cares. Second, we're strengthening the community-based health volunteers system. We have this system called migrant health volunteers. These systems are central to Thailand's inclusive health public health model. These are trained individual migrants who closely coordinated with local health workers. They can assist in health education. They can disseminate early warning. During last year prolonged heat wave in Thailand, the MHV are they are helping with the distribute the treatment kit and coordinated with the local hospital and make sure everyone got their treatment promptly. Their ability to communicate in the local native language is essential and indispensable in those times of crisis. The third pillar that the Thai government used to make sure that there is a continuity of care is to leveraging Thailand technology to make sure the continuity of care is ensured. One of the most transformed sector during the past year is Thailand's digital health initiative. More Prom platform, which is originally created to distribute the COVID-19 vaccination, now evolved into one of the broad public health communication system. With integration with Line application, together they use widely by Thai and migrant alike. They can be used to mass communication with the migrant and the Thais during the crisis struck. In less than a month ago, we have a largest earthquake in our national history, more than 100 years, magnitude 6, that happened in Thailand and also Myanmar. More Prom platform is one of the fastest way to have the government contacting the people, also the migrant who live in Thailand. They send the alert and the instruction of how to deal with the earthquake situation. Looking forward, we are looking towards the location-based alert system. When with the tie into the flooding, heat wave, or disease outbreak, we can send the alert system to the migrant and also Thai when this crisis struck. These are simple multi-languages and practical for migrants whom are limited to the official news and communication channels when disaster struck. On the financing front, inclusivity must be matched with sustainability. Thailand has two main sources of financial scheme for the migrants. The first one is social security scheme for the formal sector migrant, and the second one is migrant health insurance scheme for the informal workers. These are the foundation of Thailand scheme for the migrants. Even this is our foundation, this can be pushed to the limits when the crisis happen. So we are now proposing for the shared responsibility model to empower the employers of these migrants, especially in the sector where they are heavily rely on the migrant workers. They can co-finance to the emergency health response fund. This reduce the public burden when the disaster happen. On the regional level, we are advocating to cross-border cooperation, especially in the Mekong region. We believe that migrant health should not be stopped at the border. In summary, the climate resilient health system must be practical, inclusive, and responsive. The migrant is not the sideline, but deeply woven into the Thai community, Thai economics, and the Thai government is heavily responsive and will take care of these human beings with the system that is inclusive and built on community trust. Thank you.
Thank you, Dr. Siraset, for that very comprehensive overview. You touched upon some very good strategies, one being introduction of migrant health into the National Health Emergency Framework, very important, strengthening community-based health volunteer systems, their insurance schemes, such as the Migrant Health Insurance Scheme, and the regional level cross-border cooperation, all very important points and something for us to think about as we go with the next speaker. Over to you, Aarti.
So I will have to respond to a question posed to Santino as I'm stepping in for the next question will be to WHO. So first, Tina, could you please ask for the question you posed to Santino then?
Sure. So the question that we posed to Dr. Santino was, how can climate resilience and migration inclusion be integrated into national health systems? And more specifically, what role does research and evidence play in informing policy decisions around climate-induced migration and health, particularly through WHO's global and regional support?
Thank you for the question, Faustina. So I quote, "Good afternoon, esteemed colleagues, distinguished guests, and respected chair. We convene today at a pivotal moment as climate change, migration, and health are intersecting in increasingly complex ways, placing pressure on the health systems and demanding coordinated multi-sectoral solutions. Today, over 1 billion people globally are migrants, refugees, or forcibly displaced. Across the Southeast Asia region and beyond, these populations, they face overlapping vulnerabilities, from recurrent displacements and legal uncertainties to the loss of social and cultural networks, which significantly affect their health and overall well-being. In 2022, for the first time, World Health Organization published the World Report on Health of Refugees and Migrants. That was the first ever report which talked about the health aspects of refugees and migrants. And this report reminds us that migration and displacement are the social determinants of health. Refugees and migrants' exposure to overcrowded living conditions, precarious work environments, and limited access to care contribute to poorer health outcomes as compared to the host populations. Now, these challenges increase vulnerability to both communicable and non-communicable diseases. While the drivers of displacement are always multifaceted, climate change acts as a risk multiplier, worsening the pre-existing challenges like water scarcity, food insecurity, and loss of livelihoods. For example, according to the available data, by the end of 2023, over 235,000 people in Myanmar were internally displaced. We also have to take into consideration that it is during that year, Myanmar was also affected by Cyclone Mocha. So there are overlapping vulnerabilities. Climate-related displacements disrupt access to health services, undermines the continuity of care, and increases exposure to both physical and mental health risks, impacting health both directly and indirectly. In Southeast Asia, these challenges are already visible. The Rohingya population, for instance, faces overcrowded, hazard-prone conditions in displacement settings. There's extreme heat, monsoons, and floods. They compound their vulnerabilities. Mental health impacts are widespread, including anxiety, depression, and trauma, particularly in communities like those in small island developing countries, such as Maldives. Now here, the environmental loss also means the loss of culture and identity, an impact that extends for the generations to come. To address these risks, health systems must be strengthened to be both migrant inclusive and climate resilient. WHO is working closely with countries to build health systems that are sensitive to the specific needs of climate-affected, displaced, and migrant populations. Migrant-sensitive and migrant-inclusive health systems not only help to close access gaps, but also improve service delivery for entire populations. Yet, we continue to face significant lack of evidence to inform the policy and practice in this space. With limited data on long-term health system planning and gaps in integration of displacement and migration into national climate and health strategies. To address this, WHO, the Department of Health and Migration at headquarters Geneva, in collaboration with partners, has undertaken forthcoming evidence review on strengthening health systems to more effectively serve populations displaced by or displaced populations affected by climate change. Early findings of this review highlight the importance of coordinated action involving governments, humanitarian actors, academia, and affected communities. They also point to the potential of both emerging innovations and scaled adaptations of existing interventions to support migrant-inclusive, climate-resilient care. There is a need to shift from reactive, short-term fixes to a whole-of-society approach, supporting continuity of care from origin to destination. This entails integrating essential public health functions such as surveillance, risk communications, workforce development, and financing into long-term resilience planning. It also demands breaking down silos across health, environment, disaster risk management, and migration sectors at global, regional, national, and subnational levels. Above all, displaced and migrant populations affected by climate change must be active partners in designing policies, services, and research. Policy must not only be made for them, but with them. Co-creation ensures that interventions are not only effective, but also just and dignified. Evidence must lead to action. WHO Global Research Agenda on Health and Migration identified climate change as the most pressing, under-researched environmental determinant of migrant health globally, with a particular need to focus on evidence generation and understanding the impact of climate change on migration and displacement. Also, the effect individual level and overall population health level has to be more understood. WHO continues to collaborate with countries in developing regional and national research agendas aligned with the global research agenda. The first such regional agenda developed in Western Pacific, it focuses on health, migration, displacement in the context of climate change. We aim to strengthen evidence for policy action through supporting real-world operational research and ensure findings are translated into tangible policy with system-level change. We call for a shared commitment to building migrant-inclusive, climate-resilient health systems that safeguard health equity for all. Let us work together across disciplines and borders to create responsive, sustainable systems that truly leave no one behind. Unquote. Thank you.
Thank you so much, Aarti, for stepping in for Dr. Centino. And thank you for also highlighting the impacts of climate change on health, especially migrant health, and the importance of building resilient systems and systems that are migrant inclusive. Dr. Severoni's reflections serve as a powerful reminder of the need for data-driven governance and evidence-led action in addressing climate and migration-related health challenges. I'd also like to add that WHO is also supporting countries in conducting vulnerability and adaptation assessments. And these help countries in understanding how climate impacts affect different populations, including migrants, and they also help to ensure that health national adaptation plans, they take into consideration the health needs of migrant and displaced populations. I'll now hand over to Aarti for moderating the discussion further.
Thank you, Faustina. So we all know that International Organization for Migration has been actively working in migrant health sector, supporting governments in addressing the health needs of migrants and displaced populations. Dr. Dhawan, what has been your experience in collaborating with governments, regional bodies to integrate migration into national health and climate-related policies? And what are some of your promising, and what have been some of the promising practices that you've seen when it comes to ensuring that health needs of displaced populations are embedded in the health systems overall? Over to you.
Thank you, Aarti. And it is indeed an honor to be part of this timely discussion. And as you said, IOM, as the UN Agency for Migration, does work very closely with governments, including those represented here on the panel, other stakeholders, WHO, and other UN partners. And our strength is, I would say, our operational outreach and presence in the field, in the countries and communities, in more than 130 countries around the world, including in the Southeast Asia region. We recognize that migration, health, and climate change are deeply interconnected and need to be addressed in a coherent, inclusive, and multi-sectoral approach. And this is grounded in the very basic principle that migrants and displaced persons, indeed like all communities, have a right to health, and that climate change is becoming an increasing driver of displacement as well as health vulnerabilities. I was asked to share some thoughts about what we have learned from the work we do, as well as what can be done further in terms of cooperation and collaboration going forward. So through our field presence, we have learned that we need to focus on migration through very many entry points. Ministries of health, of course, as the primary interlocutors for delivering direct health services, strengthening health systems, and integrating migration into national health agendas and policies, as we've also heard from India, Nepal, and Thailand just now. But also others who may not be attending this World Health Summit here, but we hope will be increasingly drawn into conversations on health. Ministries of Immigration, Interior, and Foreign Affairs, who manage migration governance, borders, and are also linked with migration policy and border surveillance. Ministries of Labor, Employment, Social Affairs, including on health and safety of migrant workers, but also looking into health workforce migration, social protection, ethical recruitment, and others. Ministries of Environment or national authorities on disaster risk reduction, extremely crucial to begin working with them when it comes to climate-related displacement in order to ensure that health is included in climate adaptation planning, disaster risk management, and climate resilience. And finally, national or local emergency response and disaster management authorities in order to address those acute episodes, as Dr. Paul reminded us, and we also heard from Thailand and Nepal in terms of recent incidents, but then to look at preparedness and coordination. So in all of this experience, we understand that this whole of government, but also a whole of society approach is very essential in order to integrate migration within national health as well as national climate adaptation plans. For instance, in this region, including in Nepal and Thailand, we are privileged to be working jointly with Ministries of Health, Environment, and Disaster Risk Reduction in order to ensure inclusion of mobile populations. What works well in such collaboration is starting from a shared understanding that migrants are not the other, not a separate group, but rather they are an integral part of our communities, of our health systems. This makes it then easier to bring in other components and to support intersectoral action. Another important point, of course, like all of us, migrants are not some homogeneous group, but mobility can impact many different people in many different ways at different times. So when we speak about the linkages, like the topic of this session, we need to ensure that focus remains on those who may be facing disproportionate vulnerabilities, while at the same time harnessing the agency and the potential of those amongst migrants themselves that can contribute to health systems. In terms of good practices, and I believe we heard about this already in the discussion, extremely crucial to recognize migration health coordination platforms within governments, not just at the central, but also at local, regional level, but also across borders, so cross-border mechanisms, including a wide variety of stakeholders like we see here on the panel today. Secondly, strong data systems. We've already heard from Aarti on behalf of Santino and WHO on the importance of research and evidence, and we are proud to be a strong ally and partner of WHO in this work. But it is also important to have operational data. What do I mean by this? It's important to understand the patterns, routes, profiles, drivers and destination among various mobility pathways. This includes looking into population mobility mapping, looking at displacement tracking, and then having interlinkages with health risk profiles to be able to bring services to the people where they need them. All of this means that the conditions before, during, as well as after the migration pathway significantly influence health outcomes. So migration is indeed a crucial determinant of health, and the interlinkage with climate change means that we are even more accountable to ensure that the health systems can be migrant inclusive, to address equity, which is the big slogan for our summit here in Delhi this weekend. And ultimately, this can only work if we involve migrants themselves in the discussions, to have a participatory approach that can lead to trust, and this trust can then support better health outcomes. Lastly, in terms of building on existing platforms and working with regional mechanisms, some of the mechanisms here in this region, the Southeast Asia Regional Health Emergency Management Network, as well as the Asia Pacific Migration and Environmental Network, these can further support perhaps in looking at regional protocols, whether it is to have standardized data sharing, which we do know can be sometimes challenging between ministries of health and immigration across borders. But these are important to also ensure cross-border referrals, continuity of care for migrants, and also to build capacity building programs for health workers who can work in border areas and across communities. Lastly, we look to bodies such as the SAARC and ASEAN, who could be vehicles in order to sustain and strengthen political will, and also bring together UN partners such as WHO and IOM that stand ready to serve our member states, but also civil society, communities, academia, and health professionals in advancing health coverage for those affected by migration and climate change. Lastly, I'd like to conclude by saying that policies alone and support to various stakeholders cannot take us so far as can actual implementation and continuous learning and improvement of how we perform these various health systems actions. So I'll stop there and look forward to a discussion after. Thank you again, Aarti.
Thank you so much, Poonam. That's a very powerful contribution. Migrants are not others. They are a homogeneous group like here we all are. Thank you for highlighting the coherence, inclusive, and also an approach which touches to the ground and is actionable. Thank you so much for sharing your experiences and bringing to surface the health dimensions of human mobility in climate change. Thanks once again. I now move forward with the panel discussion. It's time to ask questions to Dr. Tasneem Siddiqui, Professor at Department of Political Science in Dhaka. Unfortunately, she is unable to join us today in person, but we also have my colleague, Faustina Gomez, to stand in her place. And she has already shared a detailed response. I would request Faustina to respond to the question. So what we asked her was, how can academic institutions contribute to designing effective, evidence-based interventions? What are the biggest data or evidence gaps in understanding the health outcomes of climate-displaced populations? Over to you, Faustina.
Thank you, Aarti. The importance of data and evidence cannot be emphasized more. We've already heard a lot from our panelists so far. I will now share the response from Professor Dr. Tasneem Siddiqui. Quote, academia has a vital role to play in designing effective evidence-based interventions to address the health needs of climate-displaced populations. In Bangladesh, our research across 6 climate-affected locations, ranging from waterlogged urban slums to riverbank erosion sites, reveal that displaced individuals, whether self-relocated in planned settlements or urban locations, live in conditions that significantly compromise their health. They often lack access to safe drinking water and adequate sanitation, making them highly vulnerable to waterborne diseases, skin infections, and gastrointestinal issues. The distance to healthcare facilities, particularly for the elderly, pregnant women, and persons with disabilities, results in dangerous delays in care, sometimes with fatal consequences. As academics, we go beyond documenting challenges. We provide solutions. Based on research, the government of Bangladesh invited us to lead the drafting of the National Strategy on Internal Displacement Management in 2021 and its accompanying action plan. The strategy is rights-based, and critically, it includes health as a central component across all 3 phases of displacement, that is prevention, protection, and durable solutions. However, there are major data and evidence gaps that must be addressed. The first being lack of longitudinal data. Most health data is collected in the short term, but the impacts of displacement, especially on mental health and chronic illness, they manifest over years. We urgently need long-term health surveillance for displaced populations. The other is inadequate disaggregated data. We often lack data broken down by gender, age, disability, and socioeconomic status, which obscures the unique risks faced by specific groups within displaced communities. Further, there is often a disconnect between climate and health systems. Our health surveillance systems rarely include climate indicators, and climate monitoring systems rarely track health impacts. This siloing makes it difficult to draw causal links between climate events and health outcomes. And finally, the issue of poor data coordination. There is minimal data sharing between governments, developmental partners, humanitarian agencies, and academia, resulting in fragmented knowledge. We need coordinated, ethical, and inclusive data systems that can monitor health outcomes over time and across borders, unquote. In closing, Professor Siddiqui is urging us to recognize academia not just as a producer of knowledge, but as a partner in policy and a driver of systems change. With the right support, academic institutions can help ensure that health systems are not only climate resilient, but also migration inclusive and equity focused. Over to you, Aarti.
Thank you, Faustina. And big thanks to Dr. Siddiqui for providing her voice to this important platform and dialogue. I now hand back to Faustina for further moderation.
So as we know, non-governmental organizations are often at the front line of addressing healthcare gaps for climate-displaced populations, particularly in contexts where formal systems are overstretched or inaccessible. Dr. Sharif, drawing from your work with the Mission for Migrant Workers Maldives, could you speak to the critical role that NGOs play in this space? More specifically, how can partnerships between community-based organizations, governments, and international bodies help strengthen resilience and improve the delivery of both preventive and essential health services? Over to you.
Thank you, Faustina. Thank you for the question. And I would like to really extend a deep appreciation on behalf of my organization, Mission for Migrant Workers Maldives, to the CRO team and to the WHO country team in Mali as well for extending this invitation and ensuring that we have this representation here at this event. I was speaking earlier and saying, I think it was to Faustina when I was mentioning that I already feel that 2025 is a very optimistic year. We founded our organization in 2020 in the midst of COVID, in the midst of the lockdowns, and so we have experienced working through that very dark period, all the way to where we are right now in 2025, where we are lucky to have this position at summit like this, with this panel of like very distinguished, leaders and implementers in the field of migration health. So when to answer your question, I would like to reflect on this through the lens of our work at MMWM, and just to put a little bit of context as well. I think whilst the Maldives is often described as being on the front line of climate change, I think it was the tsunami in 2004 was when we actually experienced mass displacement of people, internal displacement within the country, which affected local populations and migrant populations. Currently, that's not what we see. We don't see a mass displacement issue, but we do see impacts of climate change affecting the health of populations and vulnerable communities like migrant workers, and especially undocumented or irregular migrant workers, which then get that additional vulnerability added onto them. We're seeing these impacts of climate change through increased temperatures year on year, more extreme weather patterns, with rainfall and associated flooding in many islands. And a lot of these environmental changes are really amplifying those vulnerabilities, and amplifying already the systemic barriers that are faced by migrant communities in the country, in our system. Some of those systemic barriers that they already face are things like language differences. As you may be aware, in the Maldives, we are one of the biggest receivers of labor migrants from the South Asian region, especially from we have Bangladesh, India, Nepal, Sri Lanka, Philippines, and other South Asian countries as well. Documentation has been a big systemic barrier. The lack of documentation or not having complete documentation causes significant barriers in a lot of migrant communities accessing health, primary care, costs, again, tied to the documentation, and of course, stigma as well. So I think this is where NGOs like ours play a very vital role, a vital bridging role. I think we like to think of ourselves as very critical connectors in that system. So we work very closely with migrant communities, many of them who are employed in tourism, construction, fisheries, and I think to specifically answer your question, there are 3 areas where we're able to, I think, bridge that gap. One of it is through improving access and providing a sort of like a navigation service to migrant communities. We're able to help migrant communities understand where health services are. We're able to help them understand how to access them and provide those linkages. So we're able to do this through our flagship program, which is our mobile health camps, which so far since 2020, we have implemented about 32 health camps to date over the last 5 years, covering around 15 or 16 islands, and with a reach of close to 7,000 migrant workers. So through these health camps, we're able to provide very primary care, screening, consultations, and the provision of medication as well for very common ailments and illnesses. We've been able to do this through, of course, support from our partners, from fundings from WHO, community support, for other organizations like IOM as well, the local ministries of health, and international donor organizations, which in this very difficult time, we're facing challenges now. The other place that I think the other role that we're able to play is in improving, I think, trust between, for the migrant communities, because, we are able to provide a lot of, I think we have established NGOs like MMWM and maybe the Maldivian Red Crescent. We have been able to establish that trust in the community as a reliable partner for migrant communities, who of course face a lot of fear, from things like deportation and other very, I would say, practices that are taken up by the authorities, especially when it comes to deportation. Some of these things are conducted in very extreme ways that then, cause a lot of migrant communities to go furthermore into isolation by going into, peripheral islands where they're a bit out of reach from the central government. And the third way that I think NGOs are able to play that role is also through advocacy and, being able to collect data. In the Maldives, from the Maldivian context, for example, the Mission for Migrant Workers Maldives has been one of the key NGOs in the country that's been able to collect a lot of data with regards to the health profile of migrant workers. We have a report that's pending publishing, but we've been able to really establish and really put together a bit of a profile of, the health issues faced by migrant workers, and be able to use that for, advocacy as we move forward. But the other part of your question was, how can those partnerships improve, resilience and stuff? So I think some of these, the first way is, it starts with government, I think, formally recognizing our role as critical connectors, as strategic partners, and I think not just as contractors, as public health contractors, where we're giving funds and we're mobilized. I think we should come in as, from a more strategic partnership role, and be able to guide them in developing these strategies, for universal health coverage, climate adaptation plans. Second, I think, international organizations like WHO, IOM, UNDP can, continue to facilitate capacity building and, policy coherence as well as implementation. Third, I think partnerships must be community-centered. These means, investing in local NGOs like ourselves, empowering other migrant-led organizations, and the development of community migrant leaders. We have found that these models, when we use it during our programs, brings a lot of local empowerment to islands, and we're able to benefit a lot from these partnerships at the island level. So at MMWM, we are exploring a lot of these models. We've initiated dialogue with local authorities to establish inclusive emergency response protocols for migrant workers during climate events, with few, island councils being very responsive. We're continuously involved in building a lot of multilingual health education materials as well, and engaging with our partners as well in getting a lot of this information out. So, I mean, what I would want to say is, climate impacted populations, or, migrants, they're not inherently vulnerable. They are made vulnerable by exclusion. And I think NGOs or civil society like ours, we can help to amplify their voices, but only when we work in true partnership, with governments, with international actors, and most importantly, with the communities themselves. Yeah, thank you.
Thank you so much, Dr. Sharif, for those powerful reflections and for bringing the voices of civil society and local leadership to the center of our conversation today. You've clearly shown us how NGOs, like yours, especially those rooted in community trust, are not just service providers, but they're actually partners in resilience building. And your example from the Maldives basically highlights the importance of working hand in hand across the different sectors and levels to ensure that health systems truly leave no one behind, particularly in the face of climate change. We had to go for a Q&A session after this, but I've been informed by the organizers that we don't have much time, and therefore we'd like to pose one final question to our panelists here for their quick comments. So in one tweet, what are your top 3 suggestions for strengthening health systems to be climate resilient and migration inclusive? I'll maybe begin with Dr. Sharif here, and I'd like to go around the table after that. So beginning with you, Dr. Sharif.
Thank you. I was thinking I was going to be the last of the line, so I was really hoping that I wouldn't have to repeat everyone's options, answers. I think when you think of top 3, I think number 1 for me would be really, I think, really institutionalizing migrant health in national health strategies. From where I come from, I know you said briefly, but from where I come from, a lot of these things are there in some of the policies, or sometimes they're missing, but they're there in principle. We have signed with all the international treaties, but I think it really comes down to impact implementation, and that's what I think we need, that really core institutionalizing of these in these strategies, so that we can be able to then push for implementation. I think more investments in mobile migrant-friendly services, similar to what we've heard from our colleague in Thailand as well, and similar to the work that we've heard from Nepal as well, and the work that we're doing in the Maldives. And I think third would be very, I think really first maybe pushing more on inclusive partnerships, that really brings international organizations, policy-making organizations, but more importantly, grassroots organizations at the grassroots, because that's where implementation happens, that's where data comes from, and that's where impact is seen. Thank you.
Thank you, Dr. Sharif. Those were very informative. Thank you so much. We'll now move to Dr. Dhawan.
Sure, thank you. Thank you for that, Faustina. I think for the 3 points you've asked, perhaps I'll frame it along how IOM also approaches climate action for migration. So it would be to address health-related actions and make sure health systems are part of whatever is done at the national as well as cross-border level for those impacted by climate change, whether it is number one for people to move, so supporting those communities that may indeed be faced with unavoidable displacement. Number two would be for those who have to stay. So this, for me, would be more about preparedness, building resilient health systems, and training healthcare workers, including community workers, and supporting CSOs. I take your point, not just as contractors, but as hand-in-glove partners. And number three would be for people on the move. So those communities that are in the midst of climate-induced displacement, making sure they have continuity of care, making sure that data systems talk to each other, making sure that the local and cross-border health systems include them. So I'll stop there.
Thank you, Dr. Dhawan, for those contributions. Over to Dr. Pandey.
Thank you. From Nepal's experience, I would like to suggest a few points, 3 points, as you asked. First, the safe, healthy, and sustainable shelter for all people, especially focused on children and women. One. And second is health financing for migrant people. Means some people who displaced from the disasters or other migrants, they have sometimes health problems, and for financing also there may be shortage of finance, so health finance for those migrant people. And the next final one is accessible health services for those people who migrated, who displaced from disasters. Thank you.
Thank you, Dr. Pandey. And over to Dr. Sirasir.
Yes, thank you for the question. My first point is the policy integration. There is no national level implementation without good policy, and the policy need to be integrated with the actual people who will be affected with that policy. The second one is to strengthening the community, not only just migrant workers, but all the grassroots people, all the workers, all the people who actually working, who actually live in those affected area. They are your arms and legs to reach out to the people you may not never met. So that it is quite important for us. The third one is to utilizing information technology to improve, to use it as in your advantage to combat the crisis. The technology should be reliable, practical, and easy to use to make sure that no one is left in the dark when the crisis happens. Thank you.
Thank you, Dr. Sirasit. We are clearly seeing some linkages and common threads across everything that we have discussed today, and these 3 key suggestions from our panelists further strengthens this. We have now reached the end of our session, and in closing, I'd like to invite Dr. Paul to share his reflections as the chair of the session. Dr. Paul, as part of your closing remarks, it'll be great if you can also address how health diplomacy can be used as a tool to foster solidarity between sending transit and receiving countries in the face of climate-induced displacement. Thank you.
Well, thank you very much. Been very fascinating discussion. I learned a great deal. Let me summarize what are my takeaways as a policy enabler and as a learner of public health. Firstly, migrations are taking place, displacement of people is taking place today in different ways within countries and across countries. I like to emphasize that these two are different, and at times, we were emphasizing one and then at times different. So I think moving forward, when this science or public health domain is being developed, I like us to keep in mind that these are two different things, and they have their own imperatives and they have different pathways of prevention, mitigation, support, and optimum, meeting the expressions of the population in an optimum way. So first thing is, we should be clear as to what we are. There are two strands to it. When it comes to cross-border, about which I am relatively less informed, clearly this aspect of treaties, aspect of law, aspect of international system, partners, the rules of the game, and what triggers cross-border migration with or without climate change has to be kept in mind. Why do people cross borders which they normally don't? There must be some stress. Nobody wants to do it for the sake of it. You're happy in your own culture and your country. There you're not even having rights. So I think we should keep this in mind. Of course, there are generic issues that can be discussed and have been discussed. So climate change will affect both. It will push, as I said, from India's example, our economic activities are more on the west for very different, very historic reasons and other reasons, and our migration happens from Orissa and Bihar and so on toward the west, from the east to the west. It has imperatives. It has imperatives, as I said, families are left behind. They don't necessarily come here. And then climate change will exacerbate because livelihoods might change, other things might change, and therefore exacerbation can happen, and that can happen intra-country as well as extra-country. So migration is an issue, should be at a second point. I think that's the fundamental message that we get here. People who have been displaced are us. I think that's a strong message, that they are part of humanity, even if it is cross-border. And of course, they are part of our own citizenry when it is intra-country migration. Even the latter needs to be stated, because at times you hear from, let's say, a program manager in a district, the immunizations are low because the migrants' uptake is low. That's not done. They are here to support your economy, your welfare, your well-being, your comfort. It's your job to include them as a part of your beneficiary. So I think recognize that the migrants are us. They have rights, they have benefits. It's easy to understand this intra-country migration. It is somewhat difficult, I'll come to that in a minute, but for intra-country, there is full responsibility for us to embrace them, give them the benefits, make sure that the pathways work, whether it is primary care or it is secondary tertiary care, whether it is health assurance coverage, financial coverage, whether it is the benefits that come for food, for example, nutrition, and other benefit that they have, or bus fare being, let's say, obviated for women of a particular state. So they should have all the rights. That's within country, it's easy to understand. And if ever it happens to the contrary, really not acceptable, and then it is easy to change. When it comes to cross-border migrants, then it becomes more complex. I think their international system, as I said, must come into picture. Our rules of the game should be clear, and some countries and some geographies are more vulnerable to this, perhaps others are not, but we cannot take it for granted. I like the UN system to think about that, but also start thinking about internal migration, particularly because climate will do more of the internal than external, perhaps. I may be wrong, but I like us to keep in mind. So more work on that should be done. I want to emphasize that when there are rights for any migrant population, they are right like what my right is of a primary care, for medicines, for entitlements, for food, for support in mental health, for education for their children. Sure, why not? Total. So the total welfare, the welfare state should act like a welfare state for them. That's my second point. Third point is when the acute events happen. I think that's a topic by itself, but it got connected because that displaces populations, and that was a good way of looking at it, because there are live experiences which we have all undergone. Here, the strength of the health system is critical. And now we have learned that on the one hand, the health system should stand that devastation. That means health workers are available even when there is a pandemic going on, and they are ready to come and they are protected and so on. In the wake of Himachal flood, rain and heavy rain that happened 2 years ago, we estimated, the NDMA estimated that 20% health facilities were damaged one way or the other. So A, make them strong, and B, be ready that if that happens, how do you come around? And we heard examples of how it should be done: mobile units, ambulances, air ambulances, telemedicine, rapid response teams, delivery of food, safe water, drugs, medicines, etc., etc. And I also like to hear mention that India has devised, after significant investment, something called as Bhishma Cube, which is a hospital that can be dropped from the sky from a helicopter, which sets up, I think about 100-bedded, about 50-bedded hospital with every medicine, emergency, and training, etc. You may like to know more about this. This is available for other nations and for our own nation to be used. So to be able to respond. Here, I want to add that the strength will come from community structures and systems, because this is for everybody. The migrant population, particularly women, particularly children, particularly elderly, will face the brunt more. But then, we all are together in that disaster. We should not forget them, because they were us. And B, their community processes that was highlighted very aptly by some of us, that community-based disaster plan, including the health component, will come handy. The last point that I like to make is to endorse the fact that we need more research, more understanding, and perhaps refinement of the framework. If you're linking it to climate, that refine the framework, and we need a discussion at the conceptual level. And I strongly endorse that we have to be together in this. We need partnerships, international indeed, but within the system, we need partnerships with civil society, with academia, with rural, urban local bodies, and the Panchayati Raj institutions or equivalent at that level. And above all, I go back to, for us to be able to respond to these stresses, whether they are chronic or subacute or acute, and or acute, very acute, we have to mount an intersectoral, cross-sectoral response. And because when that happens, there are stresses that cannot be handled by a single department or a single set of individuals. So silos should break, and we should have standing SOPs and standing and stable systems or convenings, shall we say, or coordinating groups with SOPs, with drills being available to us. I'll stop here. Thank you very much for the opportunity. Jai Hind.
Thank you, Dr. Paul, for those very strong and clear messages. Climate change just exacerbates the challenges faced by migrant populations. We need to recognize that migrants are us, and we need to ensure that they have access to their basic needs, including health. Thank you also for emphasizing the importance of building the resilience of health systems, and also emphasizing the need for research, more research, financing, and partnerships, and coordination between the different ministries and sectors. Thank you. Over to you, Dr. Aarti, for the vote of thanks.
Thank you so much, Faustina. I think the audience have to be more generous. For a big round of applause for our panelists. They've done a fantastic job. And as we've come to the close of this session, which has been a deeply insightful and thought-provoking session, it's been a privilege to hear such rich and diverse perspectives on how we can collectively build health systems that are not only resilient to climate shocks, but truly inclusive of migrants and displaced populations. Something which has been said again and again, they are us. They are one amongst us, and we have to embed them together in all our policies and actions. On behalf of the organizing team, I would like to extend our heartfelt thanks to all the esteemed panelists for their time, expertise, words of wisdom, and passion they bring to this important work. A special thank you to Honorable Chair for your time, for your leadership and vision in guiding the discussions and also actions forward. Thanks to our wonderful audience for your engagement, your patience, though I still feel you need to be more generous with your round of applause at the end. And then finally, a sincere gratitude to the organizing team behind the scene, without whom the session would not have been possible. I would fail in my duty if I do not thank the organizers of the World Health Summit, the leadership, the strategic, the technical and policy partners for giving us this opportunity to host the session today. Let us carry on the momentum into our respective workspaces as we continue towards sustainable, inclusive and just solutions at the intersections of migration, climate and health. Thank you so much.
It's supposed to be a
Hi. Demand.
Thank you. That's all very kind of you. Yeah, of course, and I met with some of your colleagues last time, but give me a shout later. But give me a shout, and it would be great to see you in Canada. Great, thank you. Yes, of course, thank you. Lovely to connect with you. I'm just a little distracted.
No, I'm sorry to catch you.
Hi, Gus from Oh, lovely to see you in person. We were on a screen on a panel together. Thank you. Thank you for coming with us.
You have a few minutes to start, right?
Yeah, we do.
My name is Achala Samtam.
And is there then a third video as well? Second video? Got it. No. But it Yeah. Rich, why don't you go there and manage that side and we'll do the rest later.
I'm just wanting to say hello to you, Rajat.
Hi.
Jaideep Malhotra.
Thank you so much.
Such a
Thank
pleasure.
you.
Yeah. Such a pleasure.
Congratulations on your appointment as well. It's great to have you in the role at FIGO. We work very closely with Anne Chiara, who's on the board, so it's lovely to meet you as well, and looking forward to working with you too.
Yes, actually I was appointed when Jean was there.
Yes.
So I'm going to finish this year.
I see.
So already 3 years.
It's all
But
very
I've
clear.
loved working.
Colleagues, if I could request you to take your seats, please. We will be starting the session in the next 2 minutes. And if I could invite the panelists to please take their seats on the podium as well. Welcome. We will begin in the next 2 minutes. Please do take your seats. I know the previous session overran a little bit, so it's, I think we're still settling in. Thank you. Given people have various back-to-back sessions and engagement, I would suggest we make a start Welcome, everybody. It's a great pleasure to welcome you to this session looking at maternal and child mortality and the ways to accelerate progress. Before we get into the scene setting and some of the opening remarks, I would like to play a short video of voices from the field which will help us with looking at the situation within the region and the country that we are in. So if I could request the technicians to please play the first video.
My name is Achala Sangtam from Nagaland, India. I'm in A&M at Sungguman Sub-Center, Mokchung, Nagaland, and I'm proud of what I do to keep the mothers and the children healthy. Every health checkup I provide, every vaccine I administer, every piece of health advice I give, it is all to give mothers and their babies the best start in life. When we invest in their health today, we create a hopeful future for generations to come. I wake up every morning and look forward to being greeted by the smiles of children and the families I'm helping keep safe. I see happy and healthy children in school following their dreams. I love my work, and the community I serve loves me for it.
Proses tu lebih sunnah syahule alu ni mana jalan tu dengan cikim sina tu na ani hije da cikim sina. Di cikim sina di main benefit di very bon di lo semua. Abi juga itu semua bon jadi email dale. Di citi main sudah lebih kita di sudah lebih beli ansu. Tapi dalam cikim. Kapang memkara nga ko masiti rai kong thong ngapay hi barok ko ay kasnong ya kilong ying kilong sem amala ki ying pat hamtam ya kilong kme kon samla ba kilong kme ki tingkam pan yo ya ka ko tingkhia bat nga tentu ro ya ki kon kilong kme kilong pa ba kinlek sia ki jaka jisuma Kapadan hapas nang kum kasok suta ba nang baki kun ki ti jong ki bakin yo ga jong ko khia ba hamtam bakas nang jongi ba kawahi pan long kas nang kapakwat bakhia ban light na kinu ki tingpang ke harukom
আর আমার সন্তানের 5 মাস পূর্ণ হয়েছে আর আশা দিদিদের কাছ থেকে আমার বাচ্চা সমস্ত টিকাকরণের সুবিধা পাচ্ছে এবং আশা দিদিরা আমাদের বাড়ি গিয়ে সমস্ত পরামর্শ দেয় এবং আমরা সেই আমাদের নিজেদের বাচ্চাকে সুস্থ সবল রাখি এবং সমস্ত টিকাকরণে তাদেরকে নিয়ে যাই
Hamil, saya diperiksa oleh bidan puskesmas dan dokter spesialis kandungan. Pemeriksaan yang saya jalani adalah pemeriksaan tekanan darah, pengukuran tinggi badan, berat badan, pemeriksaan HB, serta ada juga pemeriksaan triple eliminasi.
ඇත්තටම අපේ රෝහලේ ලේබර් කම්පැනියෙන් වැඩසටහන පවත්වාගෙන යන්නේ 2023 අවුරුද්දේ ඔක්තෝබර් මාසෙ ඉඳලා. ඇත්තටම මේක මේ ලේබර් රූම් එකට එන මවට වගේම අපිටත් ඒ සෑහෙන පහසුවක් වෙනවා. මේ ලේබර් රූම් එකකට පළමු දරුවා හෝ දෙවෙනි දරුවා හෝ ලැබෙන මවක් එන්නේ සෑහෙන බියකින් සෑහෙන ආතතියකින් ඇයට ඇගේ සමීපත මේ කියන්නේ හස්බන්ඩ් හෝ එයාට සමීප මව හෝ කාව හරියා කැමති කෙනෙක් තියා ගැනීමට දීමෙන් ඇයට ඒ ලොකු මානසික සහනයක් වෙනවා. ඇත්තට මේ වෙලාවේ
Durante me hau tuir ia grupo sporta inang dene hau heta experiência barak hanesang entre hana 195 ida kikliu dene hau bele for susu exclusivo durante tina rua e depois Wahira hau fususune hau hetang benefício barat hanesang hanoang lanara moras e depois nimdade dia tebes e benefício dia gritan hau bele poupa tambah hau nudar inang mesak bahan uang lain 5 how fear ia início ida nebe saudável, ba futuro ida nebe ho esperança.
I believe in healthy beginnings, hopeful futures.
I believe in healthy beginnings, hopeful future.
আর আমি বিশ্বাস করি সুস্থ সূচনা আর উজ্জ্বল ভবিষ্যতে।
Thank you very much to our colleagues in the World Health Organization Southeast Asia Regional Office for sharing that video. And for those of you who do not know the context of that video, that was produced in connection with the World Health Day on April 7, which this year is dedicated to maternal and child health. Healthy beginnings, hopeful futures is how it is captioned. Colleagues, it's my great pleasure to welcome you to this dialogue, which is titled as From Commitments to Action, and how do we accelerate momentum for implementing the World Health Assembly resolution. The World Health Assembly resolution, it might seem like a very technocratic way of framing the discussion, is an important one because last year at the World Health Assembly, Somalia led an initiative which was a cross-regional initiative and eventually joined by over 60 countries to bring to attention the plateauing and slowing down of progress on maternal and child mortality. As we know, progress has been made. The recent interagency data that has been released by the World Health Organization and partners show that there's been 40% reduction since 2000 on maternal mortality, 43% reduction on newborn mortality. However, if you do look at it closely, you do find that the progress has actually slowed down, especially since 2016, and reversed in a number of countries around the world as well. What has also happened, if you look at even more closely, is that the bigger bulk of mortality now is coming from a variety of contexts. So where the mortality is happening predominantly in fragile, conflict, disasters, and climate-affected countries. If you look at the disaggregation of data, you do find that there is a high level of inequality in which the data actually manifests itself. You have women living in poverty, those belonging to minoritized groups, etc., who are at a greater risk and dying in greater number, and the same holds true for newborn and child mortality. So looking at the what, where, and how they are dying, it becomes very clear that majority of mortality that we are looking at today is preventable in nature. The key causes, for instance, for maternal mortality are postpartum hemorrhage, eclampsia, and unsafe abortion, which continues to be very under-resourced interventions to provide women with safe birthing outcomes. To discuss this and much more, we do have a very eminent panel of experts and partners who will be sharing their perspective. The way we have configured this discussion, we will soon be hearing a keynote address from Right Honorable Helen Clark, the Chair of Partnership for Maternal, Newborn and Child Health, which will help us frame the discussion. And then we will be moving into some opening remarks from colleagues from Indonesia and also from the WHO Southeast Asia Regional Office, moving into a panel discussion thereafter. Do please keep your questions ready. It is meant to be an interactive dialogue, not just you hearing statements and responses thereafter. With that, it's my great pleasure to invite my boss, Helen, to please share her opening remarks for this conversation. Helen, over to you.
Well, thank you, Rajat. Namaste, namaskar, everyone, panelists and audience who've come to this PMNCH event. And Rajat has introduced or framed our discussion today. At PMNCH, we were really thrilled, as I'm sure everyone here was, at the bold ambition set in the resolution at the WHA last year on accelerating progress on reducing maternal, newborn and child mortality. Very important resolution. But Rajat's already noted that the report that came from WHO, UNICEF, UN Population Fund, World Bank, UN Department of Economic and Social Affairs this month is actually quite hopeful in showing that 40% decline in maternal deaths between 2000 and 2023. But there are ups and downs, and the pandemic was a down moment for sure, with many setbacks. But even despite that reported progress, every day It's still calculated that more than 700 women die from preventable causes related to pregnancy and childbirth. This is a shocking tragedy. We know that sub-Saharan Africa bears the brunt of that heavy death toll, and we also see the maternal mortality ratios stagnating in Eastern and Southeastern Asia since the inception of the WHO, of the SDG era. So yes, progress, but ups and downs and some stagnation, etc. Now, on the neonatal deaths, yes, they have decreased by 44% since the turn of the century, but nearly half of all child deaths under 5 are still occurring in that critical first month of life, with the leading causes continuing to be preterm birth and complications during delivery. So while we note the progress, we also note the challenges. We note the inequities facing women and children around our world. The lack of access to and quality of healthcare services disproportionately affects the already vulnerable, including those women and children living in the rather many areas affected by conflicts these days. The number of conflicts around the world has soared in recent years. Now, the background also to accelerating action is what we are seeing in the health funding landscape, which in terms of global solidarity is now highly unpredictable. And also the background, there is the increasing pushback against sexual and reproductive health and rights, which are so important for reducing mortality and morbidity, and more broadly for achieving gender equality. But we have to hope that with focus and with partnership, we can reach the SDG 2030 targets of reducing to fewer than 70 maternal deaths per 100,000 live births, and to ending preventable deaths of our newborns and children under the age of 5. The question is, what in this challenging landscape now can we do as a community to get there? And this session is about drawing on the wisdom of the panelists and the crowd to put some new momentum into this discussion. So looking forward to it, and thank you for being here. Thank you.
Thank you so much for that, Helen, and for framing the discussion. And as you clearly outlined, while progress has been made, challenges remain, and challenges which have now compounded with the shifts in the geopolitical and geoeconomic landscape, and how does that impact the women, children, and adolescents' health and well-being agenda. Before we proceed into the first segment of a dialogue with colleagues from Indonesia and WHO Searo Regional Office, we have a short video courtesy our partners C3, which will help us spotlight some of these issues further. So if I could request the second video to be played, please.
I demand to be treated with respect.
मैं चाहती हूँ कि मेरे बिस्तर के चारों ओर पर्दे लगे हों।
I will go to a health provider where I trust my family won't be overcharged. I demand hospitals to ensure that medical equipments are of good quality.
मुझे वो सारी स्वास्थ्य सेवाएं चाहिए जिनकी मुझे जरूरत है। मैं संक्रमण से सुरक्षित होना चाहती हूँ।
I am equal to you in every way. So I would like to be treated just as you would want yourself to be treated.
You cannot tell me not to have another child. That's my decision.
मैं चाहती हूँ जच्चा के लिए और बच्चा के लिए एक ही बिस्तर होना चाहिए।
I should not be asked about my or my family's religion during labor.
मुझे सुनिए, मेरी जरूरतों को समझिए।
What if I look like a teenager? I am who I am. I need care.
I did not use contraception and I want to have this child. It's my decision.
मैं चाहती हूँ डिलीवरी के समय मेरे हाथ पाँव नहीं बांधा जाए।
I will not go to the hospital where I'm insulted based on my skin color.
I want the doctor to explain me the treatment in simple language and not in any complicated medical terms.
I should be asked for my consent before I'm examined internally.
मेरा अधिकार है कि मेरे साथ एक समान व्यवहार हो.
इज्जत से व्यवहार मेरा अधिकार.
सही व्यवहार मेरा अधिकार.
Thank you really C3 for enabling us to hear those perspectives, and something which we will come back to later on in the conversations as well. Rights, equity, dignity, that is what women want. Question is, what are we doing about it? With that, it is my great pleasure to introduce our first speaker, Dr. Maria Endang Sumibi, Director General for Primary Healthcare and Community Health for Government of Indonesia. Dr. Maria, I have one question for you to start with. We are facing a financial cliff. We are facing financial hardship, and in certain places we are already seeing stagnation of financial investments when it comes to maternal child health issues. Yet when we look at Indonesia, you are seeing steadfast progress being made, and Indonesia does emerge as a beacon of hope. How did you do it?
Thank you. Glad to be here with all the distinguished panelists. So indeed, we are on track for the infant and for the neonatal mortality, and also for maternal mortality. We are also on track, even though we are not as low as we want. At the moment we are 140, but this is a great reduction from about 310 years or 20 years ago. Now we are in 140 per 100,000 live births. I always think we are a big country, 280 million, and our problem is also fast because we have also an archipelagic country. But when you come to India, and you have, so our problem perhaps is not comparable to how you deal with things in India. So we should be still optimistic. So of course, the first thing that we do is the universal health coverage for all the evidence-based intervention that has to be there for the maternal and neonatal and child health. But how do we put universal health coverage for RM and CAH? In Indonesia, we rely a lot with midwife services in our primary healthcare services. And now this is the one that we are currently evaluating. So this midwife program started in '89. It's a long time ago that we do a crash program so that every village should have at least one midwives, and it is started in '89. And in 7 years, we produced 54,000 midwives. We have 80,000 villages, and then we have 54,000 in 7 years. But then we think the reduction is not that good, reduction of maternal mortality, because it was 1 year education only. So start in '96, we changed that midwives should at least have 3 years education. And then things start to get better. Now with all the provision of health facility, hospital, etc., we are now coming back to see how is our midwife doing quality of services. And we come to see also, the evaluation is actually done together with UNFPA. We come to see that our midwives is now a little bit difficult when they practice in their education to really get to have enough numbers to help the delivery, normal delivery at least, and also to deal with the emergency for maternal and neonatal. So we come back to look at how we educate our midwives. We have 3 education level for midwives. One is the vocational, 3 years, and then academic, this is 4 years, and then the profession, 3 years plus 2 years. So now we are trying to, the 3 years is actually assistant midwives, and then now we are trying to get all of them to be the professional midwives, and we are doing the, I think now we are doing the, improving the accreditation system, also the continuing education, and we now compare our curriculum with the international curriculum and also the certification system. But also we are dealing also with the faculty, how should they actually teach our midwives so that the quality will be good enough to catch the target that we want, which is 70 in 2030, hopefully. Still a long way to go and hard work to do. So in this context, actually also we will be happy to learn also from other countries how to improve the midwifery services in the other country. So that is our main strategy actually, aside from, of course, putting all our services closer to the community, including improving technology. Actually in primary healthcare, now we put also laboratory equipment, chemistry analyzer, ultrasound also we put now in our primary healthcare so that technology can go down to the community. The last thing, with the new WHO resolution in 2024, we would like also to have a comprehensive program review. We scheduled it actually last year, but it will be done, I think, this year. This will be the first time we will do the comprehensive program review for RMNCAH in Indonesia. We hope also the support from WHO for this program review. Hopefully it will happen this year. Thank you.
Thank you very much, Dr. Maria, and a great example of cost-effective evidence-based care integrated into health systems response and leading to some very effective results, as you demonstrated. If I could have a quick follow-up with you, as you see the changes, the shifts in the global landscape that are starting to emerge, are you worried as the ODA, the Overseas Development Assistance space, shifts? How is Indonesia preparing itself to the kind of fiscal space that we are entering?
So the first thing is, of course, prioritization. So prioritizing the essential care that has to be provided for the community, for the people, that is our #1 priority. And so far, actually Indonesia is okay with services. So services are not disrupted in Indonesia with the change of the landscape of the financing. Most of our external funder actually funding direct into community, community participation, community health literacy, and etc. Of course, this will affect actually in terms of the community participation, community literacy, etc. And perhaps some innovation also that comes from the community will also reduce the level of innovation. Perhaps in the end, hopefully not, the speed that changes or progress has to happen also can be slower, but at least we really need to ensure that our services are reached by the population, and we also has to mitigate this risk that perhaps the community, because a lot of funding, for example, the USAID, and then all that is funded also by USAID, for example, really funding our NGOs and etc. who work with the community. So perhaps the government also now have to think about this gap that is created by the change in the funding landscape.
Absolutely, and looking at both innovation but also domestic resource mobilization. I know colleagues like Vikas have looked at some of those issues as well, and we'll come back to that. But thank you for that, Dr. Maria. And with that, I would like to move to the next speaker. As you can see, dear friend Mac isn't here, Director Program for WHO Sierra Division. He's unfortunately not very well and unable to join us. We are, however, very pleased to welcome Rajesh in his replacement. So thank you, Rajesh, for standing in for Mac. And if you could tell us what are the trends looking for maternal newborn child mortality in the region. We've just received the recent estimates at the global level. How do you see the landscape evolving in the region, and what is WHO CRO doing to support countries in this regard? Over to you, Rajat.
Thank you, Rajat. Very good afternoon, panelists and dear colleagues. The Southeast Asia Regional Office is the smallest of all the 6 WHO regions, but strategically one of the most important because it's contributing to 1/4 of the global population and the annual births that we see in the world. From 2010 to 2023, as per the latest estimates, the region has achieved the highest reduction in the SDG 3.1 and 3.2 targets of maternal and child mortality, and in addition, the stillbirth rate, which we usually ignore, but it's a globally accepted target under the Every Newborn Action Plan. If we compare it from the global reduction, we have achieved a 53% reduction in maternal mortality, which is the highest. And for the first time, the region has achieved MMR of less than 100. For the other 3 indicators, NMR, under 5 mortality rate, and stillbirth rate, the reduction has been between 40 to 50%. Now, if you look into the country level, 8 countries in the region out of the 11 that we have already achieved an MMR below 140, which is the national target under the SDGs. 7 countries have achieved SBR, 6 countries have achieved under 5 mortality rate, and 5 countries have achieved newborn mortality. So pretty good situation if you look into it. Further, when you project the mortalities to 2030, you realize that the region as a whole, we are on track to achieve the SDGs, and there are few additional countries to which have already achieved who are also on track. But the challenge then begins is that this mortality reduction is unevenly distributed, and these variations increase when you go to the subnational level. Coming to the second part of the question, what the region has been doing. Now, WHO's work and guidance has always been aligned with the SDGs, the Global Strategy for Women, Children, Adolescent Health, the regional strategic frameworks, and the various regional resolutions which the member states adopt. All these are emphasizing not just survival, but holistic health and well-being of women and children, and ensuring to leave no one behind. These successes stem from robust political commitments, strategic initiatives, and programmatic efforts. The region has taken several high-level political commitments, and strategic partnerships have been formed. Over the period of time, strategic technical assistance have been provided to the countries to identify policy gaps and incorporate evidence-based recommendations into the policies. Above that, how do you translate those policies into implementation? Actionable items is what the organization has been supporting the countries. In addition, we also have a regional technical advisory group, which has been guiding the member countries. At the programmatic level, several initiatives have been taken, and these initiatives have been gradually adopted at the global level as public health goods. You had the maternal and perinatal death surveillance response, the point of care quality initiative, the universal newborn screening implementation guidance. So all these have been taken up in a big way. Now, importantly, Rajat, coming to another aspect is the inequities. Now, we know why mothers and newborns are dying and where they are dying. But what we are also observing is a changing pattern in the burden of mortality over the past 2 decades. For maternal deaths, hemorrhages continue to be number 1, though their contribution has decreased. But what we are seeing is hypertensive disorders coming up in a big way as a cause of death. Similarly, for newborn, for under 5 deaths, newborn still contribute to nearly 60% of under 5 deaths. But within those things, what we are realizing is congenital anomalies seems to be emerging as an important factor. And birth asphyxia remains an important one. As the region, we are committed to reducing these inequities. We have also realized that two important factors which are really impacting from the data that we have seen: the educational status of women and household wealth. They have a negative impact on the mortality, and we see a higher burden of the mothers dying due to these two social determinants. The region, we have been seeing this transition happening, and the region undertook, under the leadership of a regional director, a regional roadmap was launched last year, the Regional Roadmap for Results and Resilience. This has been endorsed by all the member states, and the basic idea is that we should aim to ensure that the region becomes much more equitable and sustainable in the longer run. There are 5 pillars, tactical approaches identified under it. The first pillar is looking into the mental health, well-being, and quality of care for all the people, a theme which has been ignored for long. And more importantly for this session, the second tactical pillar talks for reaffirming investment in women, children, adolescents, and the vulnerable population. This is key to public health outcomes and health equity. At the heart of our efforts remains universal health coverage, which aims to provide a healthcare system where everyone can access quality services without financial burden.
Thank you. Thank you very much for that, Rajesh. And apologies also for not introducing you properly. Dr. Rajesh Khanna, who's stepping in for the DPM WHO CRO, is medical officer for maternal newborn child health with the regional office of WHO. And thanks a lot, Rajesh, for detailing both the different levels of challenges that remain still unaddressed, the inequalities that remain, but also where you see the potential for us to make some progress and how we might be able to do that. Before I move into the panel discussion, I did wanted to ask you, given you do work at the regional level, you have a bird's eye view of the situation in the region. Are you worried as you look at all that you just talked about, the progress, the challenges, and how the fiscal constraints and the shifting in the global geopolitical situation and ODA trends might affect the region?
Thank you, Rajat. I think it's a critical question in this challenging times. Yes, I have shared with you the progress, but I haven't shared with you that in terms of numbers, how many mothers and children we are losing. We are still losing 2,700 women every month. 2,600 newborns or children under 5 years. That's almost more than 100 children dying per hour, more than that. 47 stillbirths still happening every hour in our region. Now, addressing these challenges, not only in terms of number, but it's also related to the coverage, quality, and measurement of the various evidence-based intervention packages that we have. And these are real challenges that we are facing. We also know that the current challenges in the financial landscape, including progressive deprioritization of resources for MNCH that we are seeing, as well as the geopolitical shifts, they are seriously jeopardizing the hard-won gains that we have seen in MNCH. They're not only hampering our efforts to sustain the gains, but also threaten our efforts to achieve the 2030 targets. Despite this, I know the picture is not looking good, but WHO has not lost hope. We are using all opportunities to safeguard the progress. We are strengthening partnerships across different sectors, including state actors, partner agencies, philanthropies, private sector, communities, and UN entities. One of the big changes has been that now we are advocating for increased domestic resources from the countries, making them accountable to strengthen the primary health systems for which they have already made commitment under the regional resolutions. And then launching joint advocacy and campaigns, just like we had for this World Health Day theme, healthy beginnings and hopeful futures. Now, this is really important at this stage of time, where when we are having a depletion of financial resources, that the priority focus to the survival of mothers, children, and adolescents is not lost. We hope, we do recognize that our health begins before birth. It is a multi-generational inheritance bequeathed from our grandparents to our parents. The health of mothers and children, therefore, is vital not just for our communities today, but for all those who come after us.
Thank you. Thank you for that, Rajesh, and really welcome the steps that the regional office is taking, working with the ministries of health in the region to have robust preparedness so that we are able to meet the needs, and going back to the wonderful video that we just saw, and to respect the rights, dignity, and equity for women everywhere. It's my great pleasure now to introduce a very vibrant panel of experts as we move into the next segment of this discussion. And just for our participants and audience of this conversation, please do get your questions ready. We will have interventions from these panelists in the next few minutes, and then we will open it up for you to have an exchange with the panelists, but also share with you, with everybody your own experience and suggestions on how we can address this formidable challenge. As Rajesh very nicely put out, while the progress might look okay in terms of aggregates, 2,700 women still die every month of preventable causes. Great pleasure for me to introduce Professor Dr. Sutapa Niyogi, Director, International Institute of Health and Management Research, Dr. Aparajita Gogoi, Executive Director, Center for Catalyzing Change and National Coordinator for WRA, Professor Dr. Jaideep Malhotra from FIGO, Vikas Yadav, Deputy Director, Gates Foundation, and Dr. Rashmi Aradhya, Director, Impact and Healthcare Solutions, Laredal, India. Professor Niyogi, if I can start with you first, and in terms of how do you think can health systems be strengthened to ensure equitable access to maternal and child health services, especially in the region with high mortality countries? Over to you, Professor.
So thank you, Rajat, and thank you, WHO, for giving me this opportunity to be a part of this very eminent panel. Yeah, the question is quite relevant in the sense that health system can serve as a tool to address equity-related issues. I just heard Dr. Rajesh saying that there has been a reduction of by 53% in MMR in the region, and 40 to 50% has been the reduction in NMR. At IHMR Delhi, we did an analysis to understand the trend of MMR in the last 20-30 years, and what we found are the following. We found that in India, the first phase of decline happened during the CSSM era, which is between 92 and 97. And the reason behind this decline has been attributed to the social factors in terms of a reduction in TFR or improvement in women literacy, education, etc. It was not related to any health system factors. Now, the second phase of decline was in the period of 2010 and 13, which coincides with the RCH program. And here the reduction has been correlated very significantly with the improvement in the public health infrastructure, with particular reference to the institutional deliveries increase and the skilled birth attendance. Also, during this particular phase, the number of NCOA certified hospitals also increased. And this is all to say that, okay, it is because of the improvement in the public health infrastructure or the health system, which had played a very important role in reduction of MMR. Now, going to the third phase, which is post-2015, here it is said that the reduction was primarily because of the quality improvement initiatives in the form of Lakshan Dakshata. And now, if you have to go even further, the role of health systems becomes even more prominent. Now, as a public health professional, if I have to analyze how and why the health systems had undergone so many changes since the time it was started, I mean, going back to the era Bhor Committee and others, I feel that in any country where the public health structure has been structured as a 2 or 3 tier system, it was based on certain basic assumptions. So the first assumption I would say was that in terms of maternal mortality reduction, the risk stratification, it was assumed that risk stratification would play a very important role in the reduction of maternal mortality. Now that is why it was said that, okay, anybody who has been screened to be of high risk would be sent to some advanced facility for delivery where there would be facilities for cesarean section, blood transfusion, etc. And low risk mothers, so-called low risk mothers, can deliver in a primary healthcare setup. But evidence is showing that almost 30% of those who are otherwise categorized as low risk, they end up having some other complication, which means that this kind of stratification will not work for long. The second assumption was that the primary care clinics can provide good quality birth care. If we consider the primary care centers as a center where the risk stratification would be done, I'm not very sure, but yes, primary care clinics do not have the requisite equipment, skills, and other stuff to categorize a woman particularly as high risk or low risk, which again means that this system will also not, be so much of favorable as we go down in the MMR. And a lot of efforts have gone in project mode or pilot setting mode, and that has shown that even though some concrete and targeted interventions like mentoring and other things would work, scalability then remains an issue. So this is another problem. The third assumption was that emergency referral can be an effective response. Yes, it can be an effective response provided referral happens in utero, and provided we can assure that emergency management can start within 30 minutes of start of the complication, which is again a problem. Even in the best of the situations, it is not possible to ensure that every woman would reach the right facility at the right time where those complications can be treated. The fourth assumption was that the pregnant woman cannot get to hospital for delivery. This has also changed because of the improvement in the transport facilities, road facilities, even technology, interventions, other interventions also. So it's not true that these women would not get to the hospital. And the fifth assumption was that women prefer to give birth in nearby primary clinics. We have recently concluded a study which was supported by NHSRC, where we had seen that majority of the women, they prefer to go to the district hospital. So which means that people or women, they would prefer to deliver in places where they feel that they would get better services, be it private, be it district hospital, be it anything. So this assumption will also not hold good for long. So my recommendation in this whole situation, and I would echo what Dr. Paul just said in the previous session, that the health system framework needs to be revamped, and I also feel that the health systems need to be redesigned in order to ensure that there should be some facilities which can come in between the primary and secondary. One example could be the FRU or the sub-district hospital. They should be equipped and they should be converted into high volume delivery load or facilities so that all the major complications can be dealt with in those facilities. So this is what I'll stop here.
Thank you. Thank you very much for that, Professor Neogi. And it's very, very interesting what you are saying and going through the different assumptions and actually demonstrating strengthening health systems have a direct bearing on maternal child health outcomes. You know, we have this saying in public health, as you know, what works for women and children work for health systems, and we are seeing the corollary of that being true as well. Professor Neogi, I do want to, and you've almost started building on that in the work that you just outlined for us. What role do you see of health systems research in terms of identifying the barriers and the challenges and helping achieve the sustainable development goal targets that we are talking about? And we do know this is an area that is often not taken as seriously and invested as seriously as one would think so. So what are your reflections on that and any recommendations that you may have?
Yeah, so I think we are developing, we are progressing, and one of the indicators is that a lot of hue and cry is now around implementation science. And most of the projects in implementation research in India is currently on maternal child health. So things are evolving, changing, as I said, and yes, health systems research can be a very important avenue to understand the barriers. It's not only about identifying problems, also even if you have to propose solutions and say whether these would work or not, for that also you need to have the health systems research approach. If you have to demonstrate a model, whether it works or not, if you want to look at the feasibility, the cost effectiveness, for everything you need the support of the health systems research. Also there are, I mean in India and other countries I also feel that there could be multiple portals which can give the same set of answers to the same set of questions. So there is a requirement that all these portals should speak to each other, and that can also be made possible only if we invest in health systems research. Also now, I mean, gone are the days when we, only used to look at the inputs and processes. Now is the time that we have to look forward and look at the outcomes also. So for that, for real-time monitoring of the data, again, is only the health system research which can come to our aid.
Thank you. Thank you very much for that, Professor. And an important recommendation, and something that we do need to look at it together and build on that together as well, because this is where I think integrating some of these issues within the broader health systems UHC agendas is so important. And something that you said very importantly, as we are seeing the transition that is happening and the model of transition that is being built by WHO, we are looking at a shift coming from access to quality of care issues, often some of which we don't have very well measured. With that, it's my great pleasure to come to you next, Aprajita. Dr. Aprajita Goi, you are a leader in your own right, and you have been very impressive with the What Women Want campaign in India, and also serve as the Global Campaign's co-chair. I'm sure many of colleagues in the audience and on the panel know your work. What I would like to start with asking you is, can you tell us more? What is it that you have heard from women themselves, what they want for themselves and their children?
Thank you. Thank you so much, Rajat, and thank you for including us in this session. And thank you, Professor Nyogi, for setting the stage for me to say something different. As you laid out, I think we can attribute different factors for the kind of lowering of maternal newborn deaths. You talked about non-health factors like economic well-being. You talked about how core health infrastructure made it come down. You talked about how the reduction in 2015 till now is because of specific initiatives like Lakshya and Dakshata. And I want to talk about, Rajat, about what next. I think we are very, very pleased that maternal mortality, newborn mortality is coming down. But I firmly believe that we have to do things differently now. Because I think the last mile is the hardest. Our own MMR in the country, we are really proud as Indians to say that we have had a decline faster than the global decline. I think we are almost to 80 now, 87, 70, 80, 90. We are going to meet the SDGs. And that was the kind of sowed the seeds of the What Women Want campaign, because we did want to do things differently. And we realized that if we treat women like passive recipients of care, if we do not talk to women and ask them about not just their needs and problems, but most importantly, their solutions. Because women live these lives, and they are the ones who can really point us to better solutions. And also challenge structures and hierarchies and social norms which try and silence women's voices. So that was the reason why we started this campaign. It was initially unfunded. It was done by the White Ribbon members, partners who put in their own voluntary efforts. And the method was very, very simple. We just went and asked women with just one question: what is it that you want when it comes to quality reproductive health care? And we were very specific that we don't want to hear about challenges. We know there are challenges. We don't want to hear you telling us problems. We understand you have problems, but can you just point us towards solutions? We started with a kind of a target of about 50,000 in India. Very soon we grew. We got almost 300,000 women talking to us. The campaign went global in 155 countries, and we ended up speaking to about 2 million women in these countries. So Rajat, what did women ask for? Women asked for, as you heard in the film, they said that they wanted to be treated with dignity and respect. They wanted disrespect and abuse to end. They wanted to be spared the indignity of sharing their beds and stretchers with other women. They did not want to be discriminated, and I'm talking about global results here. Women also wanted health facilities closer to their homes. You talked about a district hospital, but they want a district, they don't want to travel for 4 hours to reach the district hospital. Women wanted supplies, women wanted skilled health providers, women wanted clean facility, women did not want to pay bribes to get proper care or see the newborn. But I think what really helped was how, when we looked at the results from 155 countries, we could all categorize it into major 5 asks. So first was, of course, respectful, dignified, non-discriminatory care. The second was competent, better supported health workers, because women themselves felt that there are midwives and nurses and doctors need more support. If they have to save our lives, they need more support. There was, the third ask was about better functioning facilities. In many of the African countries, WASH became a big ask, because women know that if there is not enough WASH facilities, they can't go to those hospitals, etc. And then, of course, the fourth large ask was medicines and supplies and services. After we got we got to speak to 2 million women, then the challenge for us was, what do we do now? We cannot let this just be a campaign where we're asking women. So we started the process of curating asks which could be put forward to a national health minister or a health secretary or even your local member of parliament. So I think what really worked was how the call to action was really kind of pointedly asked for specific groups of people. So a member of parliament used his local area development fund to fund an ambulance, where there were countries in Africa where midwifery jobs were increased, there were more money for family planning, etc. So I think that's what women wanted, and today we are so happy that what women want, the call for action agenda is finding a mention, and people are really looking at how do you now respond to what women have asked for. Thank you.
Thank you, Prajita. Brilliant work, and thank you for sharing that work. And so, I do have a follow-up question before I go to Dr. Jaideep. And Prajita, when you do look at good practices, when you look at what works in the region, and are there significant policies and strategies that come to mind, that stand out, that can stand up as a model? And as Rajesh was very nicely saying, how do we do these things not just at a boutique level but more longitudinally and at scale?
Yeah. So, drawing from the campaign, and also I'll try and respond to your question, I think about 40 policies have been propelled or informed by the What Women Want demands across the world. And some of the common, if you may call best practices, have been the ask for upgraded health facilities. So in many of the African countries, we have had budgets increase in order to ensure that health facilities are upgraded. It could be a very typical ask in a county in Kenya where they asked for the facilities to be more friendly for the differently abled, or it could be larger policy gains because of the campaign. For example, respectful maternity care becoming a national policy in multiple countries, a respectful maternity care charter being adopted. And one of the demands of the campaign was also midwifery. And many countries now are taking up midwifery as a very, very serious strategy in order to reduce maternal and newborn deaths. But I think, Rajat, there is a science to how you collate women's voices and how you place the asks at levels where multiple countries can take it up, where a nation can take it up at a national level, and where local solutions can also be provided. So I think that's mainly, we ended up influencing policies, increasing budgets. I think about 330 million USD new funding was mobilized because of the What Women Want campaign. Facility upgradation, hiring of more health workers, also ensuring in kind of aspects like respectful maternity care to be part of quality of care. So I think some of those best practices went kind of, was uniform and standardized across countries. Thank you.
Thank you, Prajita. And very critical examples, because when we do, and I shared a slide in a different session yesterday, when we do look at the progress trends on global maternal mortality, we see that there was a big spike that happened during the COVID-19 years. And that's an important point to come back to, because we are looking at the same. What happened during COVID-19 was, as the pandemic reached its hilt, there was a deprioritization that happened of women and children's health, and hence the spike was resulted. And what we are seeing now is a trend in making to a very similar nature that might result in that unfortunate reality coming back. Before I come to you, Professor Jaideep, it's just a quick check on the process. So we will take, after conversation with Dr. Jaideep, we will go to the audience. We will like to hear from you, your reactions on what you have heard, and then we'll come to both Vikas and Rashmi for the second segment of the panel conversation as well. So I hope you were taking notes of the 5 areas that Aparajita mentioned and all the trends, because we will do a straw test after that as well. So wake up in case you were having a doze off in the air conditioning too. Health workers, Professor Jaideep, are critical. They are the backbone of what we do. You represent one of the most fundamental organization, FIGO, in this regard. So what do you think are some of the key challenges in terms of addressing the healthcare worker needs for reaching the women, children?
Thank you, Rajat, and thank you, WHO and PMNCH for this opportunity. There is absolutely no doubt in our minds that, healthcare workers are the forefront. For all the efforts, for whatever we have achieved, we've achieved because of them. But also what we have to also understand is that here is an acute shortage of healthcare workers, and these healthcare workers are a bridge between the doctor and the patient, and that's a very, very important bridge which needs to be done. But what is lacking? We are almost lacking in about 10 million health workers in the global region. Now, can you imagine the challenges which now they will face and all of us are facing? Because all these challenges are different in different regions. In my country, it may be very different. In a very high income country, they are absolutely different. Now, imagine there are 2 areas which we need to look. One is because of the shortage of healthcare workers. Second, also wherever they are available, most of the times they are concentrated in the urban areas or the tertiary care, because they themselves don't want to work in the rural areas or in the areas where facilities for themselves do not exist. Now, that is where the challenge happens. And I actually a lot of times think, how is this deployment happening all over the globe, and how will we balance, equitable services for all the women and the children, or everyone, who deserve the same care as you and I deserve. So these are one of the biggest important areas which we need to look on. Now, the ones who are available, now look at them. Because if you're looking at the density in the high-income countries, almost 6.5 times more availability than the low-income and the middle-income countries. Now, who are available in the low-income countries? Look at the, I would say, the responsibilities and the workload on them. So they really succumb. They have a lot of mental health issues, because this is not only the challenge which they are facing, of the workload and covering larger areas and larger numbers. They have challenges at home also, especially when they're serving in the rural areas or in the semi-urban areas where facilities are not there. They also have children and families which they have to look after. So if you're really not looking after all those and also dumping lots of work, how are they going to provide the care or the respectful care, I would say? If they are not really feeling emotionally up to the mark, I don't think we can expect more care. So we need to look at various aspects in a big way. Now, when we talk about retention, let me say that what is it a person really wants when one goes for a job? So the first important thing they want is a good salary. Then they want is, a good working condition, a lot of respect, which is very, very important. Another very important aspect which we most of the times forget is the opportunity to grow. Because, and I have seen very recently, I mean, I come from a third generation OBGYN private practice hospital. So another very important aspect which I have seen is that they want motivation. And that motivation which, we need to give to them because we need to tell them that they are making a huge difference in the health system of our country and or the region, and it is extremely important. Now, these are very important aspects which sometimes, we forget when we are employing them, because I see in the corporates, when they work, they're just removed if they are not really, working well or they're not delivering. But what we have not understood is that sometimes we have not even given them a structured training. So many of them are posted in areas which is not of their interest, or which is not really, they're not happy in that atmosphere. So they're not really going to work in those areas. So I think I'll tell you one small example. When I was the president of our organization, I started a program called Samarth, because I thought that, a lot of these workers who are working with us are not really, they need some skill enhancement and they need focus. So we did one big program, the first one which we did in Indore, we called all the ANMs of the region. We thought 200 will come, 1,500 came, and we did one whole day workshop for them. And it was an integrated approach, right? Like from preconception to, conception, and then reproductive period, then postpartum period, and then parenting, breastfeeding, family planning, and all those things. Can you believe, like, a lot of people after the session came and they touched my feet and they're telling, we had not thought that we can work this way. Now that was an eye-opener for us, because we give all these trainings to them, but we have not told them how to integrate and deliver more than what they, and that's a big motivation for them. Absolutely. So I feel there are lots of areas which need work, and again, the cultural and the gender bias I would definitely like to touch, because a lot of these women who they come up and say, I do the same work, and I don't get salary, like, my supervisor has lesser working hours and, is not as even efficient. I am the one who's delivering most of it. So those are, again, the challenges which we need to look into.
Thank you very much for that, Professor Malhotra. And it is important not just looking at the gaping hole we have on health workers, but also the challenges on deployment retention that you talked about. Colleagues, now this is your chance. What I'll do is I'll try and take a couple of interventions so that we can have a dialogue. We'll go back to the panel with Vikas and Rashmi for their interventions, and hopefully we can have a second round as well. I'll start with ma'am, you in the front, and then we'll come to you, sir, next. Yeah, absolutely.
Thanks, Dr. Rajat. First, I will introduce myself. I am Professor Sudesh Agarwal. I am a gynecologist. And
It's not working, no?
I am Dr. Sudesh Agarwal. I am professor in Obs and Gynae from Sardar Patel Medical College, Bikaner. I am also the president of my Bikaner Society attached to FOGSI. I am working for last 30 years in the government sector, and I have seen these challenges. Earlier, I have also worked with the trainings of the ANMs, ASHA workers. I was trained at the PGI Chandigarh, and there I was really associated with all these workers. First, my question is to Dr. Maria. As you said, you are having the midwiferys. Those are being trained for 3 years and 4 years. Then they are deployed for giving the midwifery services. Here, I would submit is, yes, Dr. Jaydeep, she has very rightly said, she is a good friend also. In our country, what is the problem? That we have got ANMs and the ASHAs and everywhere. But they are like loaded with all the things, like any program card. The blindness program comes, again the ASHA will do, again the ANM will do. She will do the maternity, she will do the all reporting, she will attend all the clinics. Half of the time she is away from her working place. And most important, Anybody would like to work, even for small works. We give little respect, and they are the ones who really are deprived of that basic thing. And what you get, you give back.
Thank you.
If they themselves are stressed that much, so there is of course a need that we look more deeply into this. Thank you so much for bringing all these topics here.
Thank you. Thank you very much. And an important question about how do we not overload the community level health workers. We have, okay, there are several hands. We will take it in 2 batches. I'll go to you, sir, and then take 2 more after that, and then we will have to pause because I want to come back to the panel as well. Please.
Thank you, Rajat. I'm Rajiv Tandon, educationally a pediatrician, but have had the honor of serving on the PMNCH board and executive committee during Julio Frank and Gressa Meckel. I just have 2 suggestions, especially because we have Helen here. Helen, PMNCH at that time had done what was called the Commission on Information and Accountability under Kikwete and Harper. And I think a lot of you would know that. Today is the time when you should look at that framework and actually decide how to overcome what Rajat has been highlighting in a very softly, respectful manner.
I try.
I'll be very frank because this is the need of the hour. Unless PMNCH does that, we will not see SDGs being met, neither in the region nor anywhere else. My second thing was during a call to action, Helen, in which the US, Ethiopia, and India had co-chaired that, and this is Hillary's time. I think Aparajita would remember that. There was an agreement that John Hopkins bottleneck analysis tool would be used, and probably Rajat, you would know that, to actually reassess the health systems in totality. All I would add is COVID has highlighted and climate change has highlighted issues of resilient health systems, surge capacity, need for continuation of routine activities, and so on and so forth. I would humbly request PMNCH to focus on these 2. I think we need to relook at the health systems from the bottleneck analysis tool and look at the COYA framework to see what Margaret used to say. She said more money for health, but that's all out of the door, but more health for money. And I'll stop there. Thank you.
Thank you. Thank you very much, Dr. Tandon, for that. And it is an important reminder because we did see leaps being made through both the COYA framework and the work that happened after that. Please try and keep it brief if you can. Over to you, and then one more from the sir in the front, and then we'll...
Sure. Hi, this is Suchandrima. I'm the lead of data for Khushi Baby. My question is basically to Aparajita. I have been following what Women Wants, and one of the very key things you said is 40 legislations or policies were kind of contributed from the data that was collected. I just wanted to ask you, what is the step from the point you have the results to ultimately it gets transformed into the policy? Because I think the big break is there. And if you can give me some groups or the areas where major reforms has happened from your work, that would be really helpful.
Thank you. Thank you for that. And we've got the hand in front, so we'll take that. To my dear panelists, we'll come to you for 1 minute or less because I do want to move to Vikas and Rashmi swiftly. Please.
Thank you very much. I'm Shuchin. I'm the founder director of Ujala Cygnus group of hospitals. Terrific listening to the panel, and as Maria and Aparajita said, very happy also that the MMR is decreasing. We are trying to meet the SDGs. But as Dr. Rajesh said, the generations of today will determine the health of the generations of tomorrow. And if we ignore the fastest growing countries, Nigeria we know now has numbers of MMR north of 800, some statistics say north of 1,000. So Dr. Jadip, you talked about the trainings that you did about those ANMs and those 1,500 people that came. How can FIGO help in organizing this and implementation of the global best healthcare practices to underserved areas? And you work in underserved areas yourself. at scale, not just one training or two trainings, but at scale, what can FIGO do to make sure that we have those implementation of the best practices in place?
Thank you so much for that. Let me follow a quick order of responses. Helen, can I request you for any reactions? Because there are some of the issues that came out in terms of bringing emphasis on accountability, health systems policy, research, etc., issues that I know you have thought a lot about as well. Your views on some of these interventions and what you have heard so far?
Well, really want to thank all those who've brought their expertise to the discussion. It's been fantastic. And I always have a particularly soft spot for the What Women Want report, because it just takes us back to the basics, doesn't it? What do women want from these services? And so often what they want has been ignored as people just get on and do it and don't really think about dignity and what really matters to women. So I'm very, very, very touched by you repeating these important messages to us today. I think the point that just came up around, for example, Nigeria and what's happening there and what the profession can do to, encourage and support the spread of best practice. This is very, very critical. I think from PMNCH point of view, I mean, we aim to bring all the constituency together around acceleration of action. So it's really getting us on the same page about what is important to press forward on now. Those SDG dates are only 5 years away, and we're not within reach at the moment, actually. So it does call for some really radically new thinking.
Absolutely. And as a recent calculation showed, we need about 5 times rapid acceleration to happen for us to be able to reach the targets we're talking about. Aprajita, brief reactions from you, then to you, Professor Malhotra.
Thank you for asking that question. Like I was mentioning in my intervention, that there was a whole process of curating the asks and presenting it to the stakeholder who could actually act on it. So there were large level policy outcomes in certain countries. There were smaller initiatives. There is a book called What Women Want on the website, and I would really encourage you to go and look at that because it gives you details. There was in Uganda County where women advocated for mama kits. Mama kits were stopped because COVID happened. They raised $1.7 million from the government so that mama kits would be back in supply. In Malawi, they asked for about 2,000 more health workers. So the idea is that people, wherever you are, if you want, you can take an action which will meet some of the What Women Want demands. It's not necessarily only national level actions. The last thing I want to say is there is an open access dashboard of all the findings. You can look at it country-wise, region-wise, continent-wise, so I would encourage you to go and look at that.
Wonderful. Thank you, Aprajita. Professor Malhotra, and then to you, Dr. Maria, for a brief response to the specific question asked you. Vikas, get ready. You are next.
Thank you, Shuchin. I think it was a very important and a fantastic question. I really don't have big answer for this because you have to understand, like FIGO is an organization of the federations and the societies of the world. FIGO can actually identify a problem. I represent PMNCH. I'm on the accountability group of PMNCH. So I feel even better because we understand what is going wrong with the countries in the whole world. And then basically, see, implementation is something which will only come when we have a structured identification of what the problem with the country is, and then start strategizing, areas where, you need to function, because region-wise, our problems are different. And I think our job is to identify that, bring them in the forefront, and then start training. Let's say, I'll give you one example of how we have done in India through FOXY. There are our professional organization, basically working hand in hand with the government. We have lots of programs where we have, joined hands with the government of India. We started with the Janani Suraksha Yojana, then with the PMSMA, and then very recently, not very recent, Manyata program, where it's a quality, improvement program. So we as an international organization, and along with WHO and PMNCH, identify and then roll out programs with the local organizations, which probably will have a larger impact.
Thank you, Dr. Malhotra. I do want to emphasize to try and keep it short because we are going to otherwise run out of time.
Okay. The midwife's idea really is to increase the skilled birth attendant. So when we start with 20% only, and then in the beginning of 2000, actually, it increased into 50% skilled birth attendant, and now we are at 90% skilled birth attendant. We are still need to work on the facility-based attendant. We are still at the 75%. You mentioned about ASA. We learn a lot, actually, with ASA. We did one Zoom with India to learn on how they do community health worker, because we have community health worker, but it is not certified, it is not standardized. And we learned during the WHA in 2022 that ASA actually has an award of the Global Health Award, win the Global Health. And that's why we learn, and we actually sent 2 teams to India to learn about ASA, and I personally also has the privilege to visit one Ayushman Bharat in Gujarat during the G20 and talk with 5 ladies who is the ASA worker, also with the coordinator. Now we actually trying to make this best practice of ASA into our community health worker. We standardize their capacity, we make the on-the-job assessment and etc. following the ASA example. Do we put a lot of burden to our midwife in the village or to our community health worker in the village? Perhaps for the midwives, not really. Of course, we put immunization also for the midwives to deliver. But we also has nurse now in the village together for the chronic diseases in the future. The community health worker at the moment will limit their responsibility to essential services for promotive, preventive, but also for community participation, to ask mothers who are not getting into antenatal care services, or babies who are not being visited as it should be, and we really learn a lot from ASA. Thank you, Professor.
No, and thank you, Dr. Maria, for detailing that. Because coming back to you, Gates Foundation is a big leader in global health, especially when it comes to maternal newborn child health. It's been at the vanguard of not just supporting financially initiative, but also driving policy. You've heard a lot over the last hour or so from the panel, from the audience. What do you make of all of it? And do you see technology offering us some solutions that can help us drive progress and achieve the acceleration that Helen was talking about?
Yeah, thanks. And with all the tough questions out of the way, Rashmi and we can pretty much get away with saying anything. But thank you so much, first of all, this one. And I really wanted to first reiterate the sort of firm belief from our side in the value of strengthened systems. But with that caveat, I do want to say that there is an opportunity in technology and sort of digital solutions to actually help health systems in improving quality, efficiency of care delivery, and also in some instances leapfrogging the system gaps. And with that, I just want to quickly say a few sort of digital technological solutions which we have explored, and these are just examples, but obviously one big area of attention, focus, and where there could be a lot of unlock of value is this sort of continuum of care tracking and sort of enabling care providers to make decisions based on data. So I think that sort of digitization effort is in various stages at various, in various contexts and geographies, etc. And it's a real value. Other area of opportunity is actually in enabling technology for diagnostics devices. Some of the areas where we are partnering with a lot of local institutions and groups are point of care devices, particularly for those like anemia, etc., where you can actually in some instances enable systems for better tracking, screening, etc. And then comes in the area of comes the role of technology and sort of innovation in areas of enabling care through devices where the specialized care is required. For instance, the whole attention to improving availability of respiratory care in sick newborn care units, in devices innovations like CPAP, etc., where low cost, high quality device availability could actually improve access in some of these geographies. I also want to say quickly that while innovations in digital and technology can unlock a lot of value for health systems, I think two really important things to consider. One, particularly for digital, there is a lot of attention, but I think attention to the foundational systems, I think that's really important in all country contexts. The initiatives such as Ayushman Bharat Digital Mission, which actually sets up the foundation well, actually has the potential to enable a lot of sort of digital solutioning. And second, on devices and technology, I think the idea should be to remain tied to the problem, but also how best we can partner with local institutions and local actors who can innovate locally and also create that value in terms of retaining the quality, but at the same time, reducing or driving down cost. And in that context, I think role of Global South actually becomes really important, because a lot of innovations, if you take India as example, a lot of innovation, ability, in all the areas, but at the same time keeping the cost down is a fantastic opportunity which we can explore.
Thank you, Vikas. That's brilliant, really, and thank you for laying it out in terms of not just looking at technology as the driver, but looking at it as part of integrated model. Before I go to Rashmi, I do want to ask you a very quick follow-up, if I can. When you do look at the current policy scenario, especially in context of sexual and reproductive health policies, not just regionally but more broadly as well, opportunities, challenges, how do you see that?
I quickly say, I feel particularly for sexual reproductive health, particularly reproductive health, given the fertility coming down, etc. I think a reframing of our sort of reproductive health priorities potentially could be useful. For instance, family planning programs, the unlock on value in terms of women's health, productivity, and broader maternal newborn health. I think that could be an area which shifting of narrative could use. I think opportunities, I'm an optimist, so maybe I'm being overly optimistic about it, but I really feel that within the region itself, there are substantial tailwinds which we can leverage. I feel what I mentioned, the ability of the region to innovate and drive low cost, high quality solutions and innovations, I think that's a real potential value. Another thing I wanted to quickly say, two more things. Another thing I wanted to quickly say is the value which we can unlock through local philanthropic partners. I think that's also an under-tapped potential which could be explored. I was just telling Dr. Maria that I was in Indonesia a couple of weeks ago, and we were meeting with Tonoto Foundation, which is actually hoping to partner with government of Indonesia on several initiatives. And I think there's that opportunity. Next week Philanthropic Asia Summit is happening, and all the philanthropists are convening and talking about how best we can unlock resources and value, and not just resources but also their voice and support to the initiative. And the third thing I wanted to say is what again she alluded to is the potential for South-to-South collaboration, and a lot of bilateral or multilateral sort of learning is actually happening. And one fantastic example you mentioned, another one more recently, Bapanas again convened a regulatory exchange for food regulators for several countries, and which also unlocked a lot of value to learn between countries. So I feel there are substantial opportunities to tap for maternal newborn health. Over.
Very well said, Vikas. And we actually had a roundtable on public-private philanthropic partnerships and their role for women and children's health, which is a brilliant segue to Rashmi, who was a participant in that roundtable. Rashmi, what do you make of the partnerships, and especially given the phenomenal work Laredal is doing and the innovation which you will tell us a little bit more about in terms of neonatal life. So over to you.
Thank you so much, Rajat, and thank you PMNCH for including us in the panel. And like I said, like we were discussing yesterday in the roundtable as well, that partnerships is definitely what is required to be able to reach where we want to reach, because everybody brings in a different strength to the table. And one of the things that we do in at Ladal is, that we're a global leader in simulation, and simulation actually brings together all of this, wherein when you simulate, you're not just including the healthcare workers, you're including the security, the receptionist, this one, and bringing them all together as a in a team training, to be able to really understand what is it that is the gap that is leading to the health outcome that is actually happening within the systems. So one of the things, I'll give you a small example. We just came back from Kathmandu, Patricia and I, and we were running the simulation, where there were doctors and nurses, and so these are all, partners at the field level, which is actually making things happen. So, and also picking on the point that Dr. Khanna made, that birth asphyxia is still one of the largest killers. So what is really happening, and what simulation really uncovered, was that we were observing, and these are health workers who have been practicing for 20, 30 years now. And when the baby was born, the baby was not breathing, and they had to actually start the mechanical ventilation. It was more than a minute. And then when we sat down for debriefing and we started discussing what happened, when do you think you started? I think I started within 15 seconds. Now, there is one which is an actual time, which is ticking, and there is a time which is ticking in your mind. Yeah. And I think simulation is also something that actually helps you understand that gap. Number one, and number two is the innovations and the technologies that partners bring to the table help the healthcare workers to be able to identify that and be able to do something about it as well. Mm-hmm. Because because if the first ventilation would start only after a minute, the golden minute is gone. I mean, that's what we are all talking about. So it's basically about all of these things coming together to actually help the health worker at the last mile to be able to do what she or he has to do to actually save that mother or the baby. Yeah. So
that's very helpful, Rashmi. And we're running out of time, and there is not much opportunity to go into some of the details, but I do want to give a plug for the recently published New England Journal of Medicine paper on the innovation Rashmi is talking about. Do have a look at it. It's a phenomenal study, and the work that these guys are doing. And what is very endearing in that work is also the learning approach that has been built in. How do we not just look at the innovation as a product, as an end, but we learn from it and constantly try to evolve that. Rashmi, I do want to give you 30 seconds more for any reaction you may have. So how do you see the future? Partnerships, role of private sector? How do we go from here?
Definitely. Partnerships is always going to be at the forefront. Private sector is also going to be at the forefront, because at the end of the day, private sector is something that will have to be included one, because private sector is providing healthcare, private sector is also the one which is spending on research and development and also innovations, which then gets to be taken to scale, by the governments and so on and so forth. Again, what the Safer Births Bundle of Care that you were referring to with the New England Journal of Medicine, it's a classic case of how the government and the private sector came together to actually make the maternal mortality go down by 75% and neonatal mortality go down by 40% in these hospitals. And now the government of Tanzania, after this partnership with the private sector, is actually going by themselves and scaling it up all the way up to the 700 hospitals in the country. And I think private sector always comes in as a catalyst, and the scale is always achieved by the government.
Absolutely. Thank you. Thank you for that, Rashmi. And thank you to all the panelists for joining us today. Colleagues, we are indeed out of time. I'm sure you're going to try and catch them for coffee, chai, and whatever else that you can find outside in this wonderful conference. Colleagues, thank you. Because, I do want to end with something that Aparajita said. We need to do things differently. And we need to do that now, because as things change, as things become more difficult, women and children can really not wait forever. Thank you for joining us and for your commitment for maternal, newborn, and child health. Thank you.
So we can work together. That, like you introduced this, Hello. I think we can kind of start settling down now. We are slowly appearing at a magic point where the panelist number is about equal to the number of audience in the room, which is the cutoff point at which we can start to be on time. I invite all the panelists to take their seats on the dais. I don't see the need to introduce one by one. Let me start, before I introduce the people on the dais to you, let me introduce why we are having this session. And once in a while, when you're one of the organizers of a summit, you got to organize a session because you have a question in your mind that you need an answer to, and you expect there'll be plenty of wise people around coming for the summit, so you can use that to get the answer. Now, the question in my mind for some time has been that what should Ashoka as a university, taking inspiration from what we understand about global needs, get into in the master's area? And one of the things that, given the Koida Center for Digital Health has been created, we have great interest. The world is becoming progressively digital. Digital is transforming health, not necessarily always in the right way, but it will transform health, that's a given. And what we want is it transforms health in the direction that we want global health to go. Now, to do that, it will require people who have an alignment of vision, skill sets, and tools, which could be called an educational program, and perhaps a master's could be useful. But that's a very, very loose description of a very, very defined problem, which requires understanding efforts that have been made in the world before, global perspectives, job markets, what do we expect to train people in, what is the value of such people after they've been trained. So I thought, given we had recently connected strongly with Professor Bhramar Mukherjee, who is recently moved to Yale in the School of Public Health, has diverse experiences starting as a statistician from ISI, moving to the world of genomics, becoming a US National Academy member before she turned 50, and then flying to Everest to, kind of challenge that, life. And knowing how thorough she has always been at anything I've ever asked her to do, I thought that by making her chair, I will get a very quick and comprehensive overview of the entire field in one good sitting. So Bhramar, as the chair of the session, it's a pleasure to have you here, and we look forward to hearing from you later regarding how you see this question of do we need a master's in digital health. And of course, Bhramar brings a global perspective but has been outside India for a while. So Rajendra Pratap Gupta ji, who in his own very short description has been leading policy for the government for a very long time, whether you like it or not, whether you like the new education policy, which the government has clearly pushed and Ashoka has clearly adopted. A lot of it has to do with his vision of what education should be. So who better to answer this? And his interest has been in digital health for more than 6 years now. He's running an academy. And when you run an academy, you have to figure out what to teach. You have to figure out what the students want. And after your students learn what you have taught them, you get to see what is their life trajectory and career trajectory afterwards. So it can't be a better person to tell us about the Indian perspective. So as our co-chair, we look forward to his words. Brian was Brian is the person who we first met at Johns Hopkins, but is currently Yale. So it adds to the Ashoka-Yale collaboration that we are trying to build here. But Brian has a broad experience in health, public health, digital tools, data science, on-the-ground work, actual impact. So if the purpose of a degree or a training is more than just getting a job to the people who have the degree, then knowing people who have used such training to create impact is a very valuable thing. So in case the answer turns out to be no, we do not need a master's in digital health, we need a training in something completely different, I think Brian is the perfect person to help us with. Moving on to Uday, whom I have known for a while now, who started his career building electronic health systems at Satyasai to create impact. And then moving on to advising people and consulting on how e-health can transform impact, creating efficiencies, creating scale all over the world, particularly this region. I thought Uday would have a very good view on what people are asking consultants to do when they talk about e-health and digital health. So that's beyond a standard profile, but it's like what is being asked for. Purnima Prabhakaran, who many of you know well, is the director of the Center of Health Analytics Research and Trends. As a medical doctor, but then also as a public health specialist, having trained abroad for a lot of it. She certainly will end up bearing a lot of the brunt of if we were to create a master's in digital health. So partly for that reason and partly because she has much more exposure than I do in the same area. Purnima, we look forward to your views on the same. And then Tanu, of course, from PATH, has directly been involved in development sector. Having trained that way, having recently gone from training towards actually working on the ground, it will provide a very important young voice closer to the ground of where we think such people might be. The format we will follow is I'll invite first Brahma, then Rajendra Gupta ji to give their opinion, please maybe around 10, take more time if you require. Your overall views on the matter, perhaps frame further questions that came up based on your thinking about the topic, and then we'll move to a more panel format with all of us having a chance, and I'll just keep the mics moving. Thank you, Brahma, and with that, over to you. You can do it from here or stand as you go.
So thank you, Anurag, and thank you everyone for showing up for a panel at 5 p.m. So Anurag has tasked me with the responsibility of opening and creating a setting for the question of, do we need a master's in digital health? So I have been a professional statistician for 30 years. And you know that statisticians do not give certain answers, right? Like uncertainty quantification is at the heart of our profession. So, and when the whole world is moving away from binary answers for everything, I think the topic of the session is rather ill-formed. So I'm going to take the style of Royal Statistical Society. So if you are a Royal Statistical Society discussant, then you are opposing sort of two viewpoints, and you're representing, so initially the first reviewer gets up and says something mildly nice, and then the second reviewer is very harsh and sarcastic and tears the problem apart. So I'm going to try to embody both the nice and the not so nice discussant of the Royal Society. So what can I say which Gemini or Claude or DeepSeek will not be able to tell you, right? So first I asked Gemini, DeepSeek, and Claude about what can you tell me whether a master's in digital health should exist or not, and the first answer was that your question is wrong, it already exists. There are 6 institutions there are 6 institutions even in India which are offering something similar in different nomenclature, health informatics, health technology. So what can a useful master's in digital health look like, and what should the branding be? So I can tell you a personal story which Gemini, DeepSeek, or Claude will not be able to tell you, is that when I was a student in ISI, I loved math, I loved coding, and I went to ISI, and many people in India is very enriched in terms of people who are interested in quantitative sciences and computational sciences. They go to these institutions, and then if they are applied, they are sort of at the bottom of the hierarchy, right? Because most of these institutions are extremely theory-focused, and what gets rewarded is the theory of applied statistics. So when I actually chose, after my first year in the master's program in ISI, applied statistics as my second year specialization, my professors who had high hopes for me said, "We thought you were smart." Already it had become a past tense because I decided to do something applied. Because I had the merit to do some theory, so I chose to do something applied. That was really controversial. So I think that this cycle has changed quite a bit, and I think it's important to bring important problems and make the two worlds of math and medicine and math and health and computational science and health blend in a more effortless way.
So we talk about interdisciplinary education, but I do think that modern education should not have any disciplinary boundaries. It should only have certain problems and certain skill sets needed to solve the problem. So the question is that what problems are these masters of digital health students be expected to solve? And so those problems, I think, are land in a socio-technological realm and deal with the advancement of health technology and bringing solutions there. And so I again will say that digital health is not just one thing. It's electronic health records, it's wearable devices, it's telemedicine, it's the apps that we are using to provide mental health counseling. So it's a whole realm of things, and each domain of data needs deep expertise in the contextual matter and the technological ability. So how can we promote this ethos of interdisciplinary education? So I think that's the first thing we have to address. And I do think that each institution brings its own flavor to any degree. So I'll talk about my own experience of launching a health data science degree at the University of Michigan, where I spent 18 years. And so we traditionally had a very, very successful traditional biostatistics degree. As the field was moving towards more machine learning and AI and data science, I wanted, as a new chair, to start a new degree. There was a lot of resistance. What are you going to let go? Because we have finite resources, lots of priorities. How does, SOMAC decide whether to invest in a master's in digital health? So for that, what did we do? What was the process? So because I am very persistent, so I said, let us start. Okay, the faculty voted there is no need for any additional degree. And we are always naysayers. We do not want to change the status quo. So what I did was to start a really small sub-plan or a concentration within our existing degrees to see if there is traction, if people are interested in learning more coding, more data science, more about algorithms, departing a little bit from the stochastic structure of a classical biostatistics degree. And within 3 years, we saw that there were 25 students opting for that sub-plan. So now we had preliminary data, but then the graduate school says that why do we need another degree in health data science? We have data science in the Department of Statistics. We have masters in data science. We have a certificate. So then we said that there is not much at the intersection of health and data science. We are going to really design a program which is unique, which brings immersive case studies in health big data, and the students are trained to solve particular problems in imaging, in genetics, in electronic health records. So with a specific foci, then this, because Michigan is a public university, the state even brought up, in the state of Michigan, there are other similar programs. How do you define your uniqueness? So starting small, seeing the market value, rationalizing what unique aspects you can bring. So what I think in terms of digital health, I think one issue as AI and conversational tools are becoming more and more popular, there's tremendous potential in using digital technology to reduce the barriers to access care, for example. But if we just keep doing things but do not train people how to evaluate these tools, how to design digital solutions in impoverished communities, then the struggle of the unseen in the healthcare system is going to prevail. So I think that what a curriculum in digital health can bring is real strong applications of the future and train students to solve those problems. And if you think about, even in village markets in India, nobody uses cash anymore. Only NRIs do. And you stand there well, I do not have Paytm, what should I do? I have cash and nobody wants to take cash. So everything has become digitized in terms of financial transaction. So why not in terms of health transaction? So building a digital ecosystem for 1.4 billion people is not just game-changing for India, it's revolutionizing for the world, because what you are going to learn if you can harness the power of that data. So But who are going to analyze this data meaningfully? So I think if you look into the future, if you bring that particular flavor, as India is moving towards ABDM, I do think that training proper professionals is very important. Whether you call it Masters in Digital Health, I really do not care as long as people are learning the proper skill sets. And I think we have to really understand that whether it's going to be a master's program or are you talking about MPH? Are you trying to use digital data for health surveillance and forecasting? Those trainings are very different than if you're trying to talk about a master's degree. So I also want to say that in order to start a degree, you also need material and courses and textbooks. Do we have textbooks in digital health? Is everything going to be ebook? So we have to be very concrete in terms of what are the core competencies that we want these students to learn. And I personally feel that they have to be completely thrown and immersed into data. And this is something I feel is lacking in many times in terms of computer science education, mathematics, and statistical education, that we do not see real, messy, challenging data. Applied problems are different. They're not necessarily easier or lesser intellectual accomplishment. And we have to come forward with that realization. So I do feel that we have seen variants of health information technology, health informatics, various brands of degrees, but we have to practice data science in health with ethics, equity, and humanism. So that's where the integrative training comes into play. And I do think that you can design a unique program which prepares the quantitatively talented and health-focused students to solve the problems of the future. So that's what I'm going to say.
Thank you very much. And for a reviewer too, you are very, very nice. So Gupta ji, please, over to you. Based on what you've already done, how do you see this?
So I'll take a divergent path than Dr. Mukherjee said. I'm going to give you binary answers with multiple dimensions. So one is picking up, do we need a master's course? Because Anurag, I think you outlined the objective of the session very well, the master's in digital health. The short answer is there is need but not much demand. That's the first thing. And I'll qualify that as the one we started the first Academy of Digital Health Sciences. And you asked for the course book. So my course book is not only a course book in India, but in Germany, and where I teach as well digital health. So I have a textbook on the Masters for Digital Health course published by Walters Kluwer. But if I come down a bit, I would actually go back and validate something that I'm going to say with the audience here. Is there someone in the audience who can define me the exact definition of digital health? So this will answer you one question, that you will have to create a market, Anurag, at Ashoka for this domain to start a course. It's not a ready market. You have to, if you're willing to create a market for digital health, do it. And I'll give you back an example of an institute, a leading private institute in India that started the course somewhere around 1920 on digital health, and eventually they stopped. A leading university again in Jaipur started a course, and they also have not got good response. It was a master's course, by the way. And they have probably the highest number of alumni in health in India. And the challenge, I'll tell you, is very interesting. Where do you get the faculty? I paid 10 lakhs for a 30-minute lecture. How many people will pay 10 lakhs for a 30-minute lecture? So the challenge comes is, first, there is no market. There is no people who understand digital health. I have seen ads in newspapers saying digital health and telemedicine. Now that's coming from a university for a course. Now if someone who understands digital health would know that telemedicine is a subset of digital health, not plus. I also see digital health plus AI. So sometimes I bang my head that if anyone who understands a bit about digital health, would want someone go and do a course like that where someone who is promoting it doesn't even understand the connotation of what digital health is. The second thing, and the third thing what I have seen is, we have been running 4 batches of the master's course, and people who have done it, they are like people with 50 years of practice after medicine, and they've gone out excited and created solutions. People with 40 years, Dean of KEM, they are our students of the course. We recently had the convocation for the batch. So field is evolving so much that we started with AI, became generative AI, became multimodal AI. So the field changes in 7 months, not 2 years. How as an academician you would adopt to changing your lecture in the next few months? So if you are open to being so agile, we must do it. So having said that, the other challenge that is coming is a very big challenge. While we run a course, since we do it with IM and we have done it at a quality and scale, it costs a couple of lakhs. On Instagram, some doctors claim to be, sorry about that, claim to be from AIMS and from IITs and sell the course for 99 rupees. Now, tell me how on earth would you go and compete? If someone puts a video and says, I came from IIT, wanted to change the field of medicine, I partnered with this fellow from AIMS, we're launching a course, it's for 78,000, today it's for 38, but now it's 99 for 15 minutes. So the challenge of such people, how do you manage that? So to me, the short answer is we need. The long answer is a host of challenges and experiences. So, and one who's been running the course, I'm pretty optimistic more universities should come, more should launch. So they create a bigger market. I spent crores to give an ad in Times of India to let people know there is a course, and the course becomes unviable eventually, because if you gave a half-page ad in Times and Atomic Times, it's 1 crore rupees. And then you have to ask people for fees in India, they ask you for value. So I think short answer is yes, we need. The long answer is too many things to ask and answer. So that's where we stand with an experience of training. And we also are, by the way, the largest provider of digital health courses now. We are training nurses, we are training pharmacists, and these are official, by the way. These are not standalone for us. And we're training doctors and CEOs. So we understand the pain in the process. We also understand whom are we competing with? 99 rupees and 1,000. I mean, of course, we can't fall to that level. So I think for me, I would be very happy if universities like Ashoka and others would come. So my job of creating a market would be lesser then. So, and there'll be a ready market for people to take the course. So please train more. And the other reason why you should train is healthcare is going to be driven by digital technologies. And we see that as my role within the UN to chair the Committee on Digital Health and the Commonwealth AI Consortium as chairman for capacity building. I think anyone who doesn't do digital health would not do health before the end of this decade. But are people trained? So we have to train them. Who is going to take the bait of investing in training them is a call the universities will have to take. Yeah.
To summarize this first part of the panel discussion, let me do my best that I can. I think both sides is complete agreement that there is great transformation happening. And unless you train such people, there is going to be problem to the system. It's also very clear that if you train people the right way, and you train them from thinking in terms of digital tools, building, evaluation, deployment, there should be a need in the system for such people if the system wishes to get better. The challenge, I guess, comes from the fact, does the system wish to get better? Does the system have the agility at the faculty level, material level, to keep updating rapidly in a world? And I would imagine that such challenges were faced at every nascent field, including, say, biochemistry, at the time it first started. Even genomics, at the time it first started. And leading universities, probably that could absorb the ability to bring the type of interdisciplinary faculty of high caliber, have them work on other things and use that synergy that occurs naturally to create such courses, may be the ones who could absorb the cost. Because you're not hiring them for digital health, you're hiring them for the various other skills that they bring in as part of the department. It could be statistics, it could be genomics, it could be electronic health records analysis, they could be researchers who are doing primary research in that area, and if they also teach in the area in which they do cutting edge world-class research, then some of the cost problems and curriculum problems and agility problems could be defrayed. So that's one way I would see, I think, both the things that I'm hearing. One from the perspective of a chair of a department in an active research university, where all the type of people that you needed to create your course were already there with you. You didn't have to hire probably a single new person, Brahmer, to build this. You just had to convince the university that there was a need. Rajendra, you probably didn't have the luxury of already having all those people required to do this under umbrella already. And then it becomes a financial model in which you have to look at your inputs as well as the outputs, and then the problem of the field that nobody knows what it is. And that would have been a very difficult, and it's great that you have been able to sustain and champion this over materials. So yeah, please.
So it's not that I didn't have. So the luxury that I was able to pull it off, that for all those 25 years plus, I've been working with WHO, to UN, to Commonwealth. So people who created the domain worked with us. So we made sure that people who teach are the people who created the domain. That has set our course to continue. Something that became indispensable, you know, and something that we were very proud and lucky to have access to those people who created the domain, right from those who coined the term connected health, to those who created software as a medical device, to one who wrote the FAR standards. So for me, the luxury came that I didn't have to have the faculty because these were the friends for so many years we worked together. So like Bakul, who created software as a medical device and who actually started digital health at US FDA, is global head of Google now. The moment it emitted US FDA, I got him on the board. I said, Bakul, I'm not giving you a choice. We are friends. You got to join my board of directors. So we had the luxury of having those faculty which cost a bomb to have. They may not even take that. But again, how many universities in the country would be able to get all those top guys to teach? That's the challenge. I think the challenge is of the faculty locally. And we are through our course trying to create that faculty. I mean, that's one of the biggest challenges we faced.
Fantastically put, and we are lucky to have good two friends on both either side. So that works very, very well from that point of view. So Brian, now we're going to go back to a fundamental discussion of whether such a thing is useful from your point of view, and if not, what else would it be?
Sure. Well, first of all, I just want to say thank you for having me join this important discussion today. My background is as an infectious disease epidemiologist. However, I am very passionate about the foundational principles of public health. In my previous position, I taught for several years an introduction to public health course that I thoroughly enjoyed and continue now to teach even in my even as my role has changed as I joined Yale recently. And so with that, I want to frame my thoughts around the broader context of public health workforce development in India. When we talk about the need for a new master's program, we tend to think about what the market is, but I want to take a slightly different angle in what is the public health need for a new degree program. And so I want to also build on some of my recent experience in leading a public health capacity strengthening project for several years in UP. I continue to be engaged in some of the UP work as well. And so in terms of public health workforce capacity, there have been a number of discussions in India around the establishment of a public health and management cadre. Of course, there are several states, Tamil Nadu, Orissa, Maharashtra, that have established public health cadres. The National Health Systems Resource Center in 2022 put forward a number of recommendations for what a public health and management cadre might look like in other states. And I know those conversations have continued at the state level as well. And so in thinking through establishing a public health workforce and establishing these cadres, there's three real considerations that I think need to be considered and considered simultaneously. So the first is production capacity. And there's been an explosion, an increase in institutions that are offering MPH programs in India. And as we have already identified, the market necessarily might not be there for some of the public health degrees. However, the need, which is a different way of looking at it, I think is there. I think that despite this growth in MPH programs, there's still a need for greater public health workforce. I think the establishment of a public health cadre in some of these states can be a pathway toward more of a quote unquote market for public health professionals. And I think that would be a great thing, and hoping that some of that continues to move forward in additional states. I think, as Brahmer mentioned, when we think about production capacity, we also need to think about whether the faculty expertise within institutions that would be offering these degrees exists, whether there's technological infrastructure, the pedagogical approaches, if they've been established, and of course the course materials as well. And if they haven't, then of course that needs to be established. The other component that needs to be considered, I think, simultaneously is in-service capacity. So the digital transformation that we're seeing in India is occurring at a rapid pace. And so the existing public health workforce, I think, also needs to have their skills continuously developed in order to utilize the tools that are, again, rapidly developing. I think this is something that we've been working on in UP. So working with the state government to better understand how to put to use digital tools that are now available, and now available with support from the government of India, but also other sources of support as well, private sector, among others. And then last is the absorptive capacity. So as I mentioned, there's a need for additional public health and digital health capacity, but whether there's absorptive capacity within states, I think, is another question. And I think this is where really the market needs to be expanded. There's a real challenge if we put effort into developing these skills, including digital health skills, that there's not going to be enough positions available within either government, which is, I think, a central component of a public health system, but otherwise as well. And so I think one of the efforts that we undertook in UP in order to help support the state government in building its public health capacity was the development of a core set of competencies for public health professionals. These are the set of skills that are expected of those who are in public health practice positions. There are competency frameworks for MPH programs, but in India, there has not been historically a framework for core competencies in public health for practicing professionals. We worked with the state government in UP to establish a framework, and integrated into those core set of competencies throughout were digital competencies as well. And so to answer the question whether there needs to be a digital health master's, I think the critical thing from a public health workforce perspective is whether the competencies exist within the workforce. If they don't, how do we strengthen the existing workforce? And how do we then expand the workforce and have those who are entering into the workforce with the right digital health competencies amongst many other public health competencies that we would expect of public health professionals as well. And so just to kind of wrap up, I think I had a nice point I wanted to make. Yeah, so I think there's, again, a need for digital health competencies, a need for public health competencies, and I think that integrating into existing master's programs, digital health competencies for public health professionals would be the way forward. Thank you.
Yeah, please.
So I just want to make a comment that Brian assumed that this is a public health degree. I disagree. It doesn't have to be a public health degree, right? Digital health is not digital public health. I feel that, and I'm doing this just to give you a hard time, but
this is the Royal Society
no,
approach?
This is the Yale Society. And so I just think that there is a room for masters in digital health, obviously, because many computer science departments are also teaching people how to analyze medical claims data, electronic health records data. But I do think that there has to be an integration of public health ethos, even if it's a master's degree. For example, the health data science degree in Michigan is a master's degree. It's not an MPH degree. People with that master's degree work for Google, work for Amazon, work for YouTube. So there is a value and market for that. If you just think about public health workforce, the market for that is limited in India, in US, but as long as you translate that into coding and computation and analyzing data, then all the big tech companies, all the pharmaceuticals actually become your job prospect. And that degree is very valuable, where you are taught how to communicate, how to collaborate, and how to code and compute and do sensible analysis of data. It does not have to be public health.
That is a point very well taken, first of all. I, as a public health educator and as a public health both practitioner as well as researcher, I wanted to bring a public health perspective to this and think about what we need to do in order to build the public health workforce, both in terms of digital competencies as well as broader public health competencies. That doesn't preclude the need for additional digital health competencies that go beyond public health practitioners. But as a public health practitioner, I hope to and expect to see a range of multidisciplinary approaches to public health, of which digital competencies would be a critical component. So, point very well taken. I think there's a need for both, I would say. Last thing I'll say is, the sign of a good mentor is that they push you and challenge you. And so something that many of you may not know is that Brahmer is actually my faculty mentor at Yale, and so I appreciate being challenged by my mentor. It's a sign of a good mentor, and I welcome the challenge.
Thank you, I agree with you.
Now, this was a very, very useful discussion, and there is at least one example in public health in the region where jobs were created in Sri Lanka for people with health informatics degrees, such that every vertical had to have a person. But I think the point that Brahmer made about that being a limitedly scalable system, with the government acting as an employer or public health system acting as an employer, ties very well into the point that you made earlier, that ultimately, employment is also something we have to consider in India.
Since it talked, and I don't have an issue with anyone being a mentor or mentee, so I can take the liberty of answering. So while we do courses, we also continue to evaluate the skills people need. And I continue to engage with people who have done MPH. I was the one who wrote in the health policy, we'll have a public health cadre. And I also know the current system and what impedes to have that public health cadre. We can have any number of degrees. If we don't create jobs, eventually people will start walking out of that. So while we created a lot of courses on MPH, if you talk to people, what did you do after MPH? They're still struggling to figure out that. Most of the people who would do that would be dentists, would be other science graduates who get into doing MPH. But I think as academicians, we got to see, are we just printing degrees or are we creating competence that the nation needs? Do not rely on the government long term to be filling you job vacancies. That's not the way to look at any course. Thank you.
Jay Ganesh, perfect time for you to come in.
Yeah, thank you. I think I kind of come from a very enviable background, I think. Basically, in the beginning of my career, I worked in the hospitals. I was a license point for the clinicians because I was the implementer of hospital information systems and then disease management portals and then telemedicine packs and things like that. So I had to work with the IT team as well as the doctors and be the interface in between. So digital health being inherently multidisciplinary, it depends on who is actually looking at it. It could be very general for some, or it could be too specific when it comes to the competency framework. So I have had that, and even last month, the whole month, there was WHO Digital Health and Innovation Department conducted a series of virtual workshops on digital health competency frameworks. I was part of that. And then few other efforts, like for example, one of the countries actually needed the support on developing the competencies for health information systems. And then there, it was not the doctors in the country. It was the nurses who were actually providing the care because the doctors were too few, but it was nursing. So the entire curriculum had to be kind of tailored to the nursing stuff. So again, it depends on who is looking at it, whether it is, as Brian mentioned, whether it's in services. That is also very important because there are a lot of health workforce who is already on the job. And the digital tools are already there. So do they actually step out of the job and do the course and come back? Or as part of the work, they actually pick up something which is relevant for their work and then get back? And then we also work with a lot of countries, the ministries of health, in supporting their capacity building programs, where like people have very less staff actually working for digital health. And then if they have to take a full-fledged course for 2 years or a year or something like that, it's very difficult. And then so what we actually work with them is provide something like a bridge. So as the first panelist mentioned, honestly, I do not care whether it is a master's or diploma or whatever it is. So, but we have to be more flexible. It's very difficult, for example, in a class, especially on digital health, unlike it's an MBBS or engineering, you may not have a homogeneity in terms of the students or the cohort. So that's the challenge here. So if we could be more flexible, that it's kind of, in a way, difficult to define the core set of skills, depending on whether somebody is coming from a dental background or a medical background or a pharmaceutical background or allied health sciences background. But then, like, if we can bring more modules that can be customized to their own setting, I think that works. For example, I was also part of one of the course known as Digital Health Planning National Systems course, which is more looks at the enterprise approach for the national planners for digital health. It was kind of like how the governments, the national digital health program managers need to look at a more broader view rather than getting siloed. So that looked at like give a broad picture, again, depending on the persona, whether you are a policy maker or a provider, like it gives a kind of a vanilla broad view, but then concludes with a very specific capstone project that is tailored to their own work environment. So that kind of gives them the grasp. It's kind of like starts with kind of a 101 and concludes with something more specific to the area of work. So I would say that we have to have the flexibility, and who offers this course is also important. And then unlike, again, medicine or a regular engineering degree, how many cohorts will happen in digital health unless otherwise the market really requires that? And unless otherwise we have a career pathway defined, like I think Professor Anurag also mentioned about the Sri Lankan experience, like we have a long history of working with them. There, they took the step of actually getting the medical graduates, starting with the master's program, and then getting the board certified specialist, and then they are actually paid during the process. and then they are employed. So, there is a career pathway. If we do not have that, it's really difficult. So I would put it that way, like, I'll be happy to take the questions because I'm involved in multiple ways of actually helping the governments to build the capacity. So we actually see one of the countries, like their requirement was data science and clinical informatics, but they just have 2 staff in the whole division to do digital health. Imagine, and then they had to do this course in another country where we established a fellowship program for them. So that person has to leave the country for 2 years. After that, whether they will come back or not, we are not even sure. And then even for them to qualify for the clinical informatics program, their proficiency in English had to be improved. So we had to have a tie-up and then first got them to that level to even get onto this. So there are multiple issues involved, but of course in India there are many other things that can be taken care of. I think we do have a lot of very good faculty in the universities, but then I'm not very sure about the market. And then if we have a clearly defined, if somebody takes this master's program or whatever we call it, after that what? Do they get a better job prospects? Or do they, like, what is their progression? If that is not defined, it's kind of, I would say that it's difficult at this moment. Yeah, I will end it. I will be happy to take questions actually. Thank you.
Thanks, Uday. This particular direction reminds me of a previous discussion I once had, whether a PhD after MBBS is useful or not. It all depends what you do your PhD in and where you do it. People with the right PhD and the right set of skills are in great demand after their MBBS. Those who do exactly the same thing somebody else does an MD in have a bit more of a challenge with the things. So you're right, being flexible and a high quality training and seeing what the career path is indeed very important.
Yeah, just 30 seconds. It could be like, for example, I come from a background of, family in medicine. Of course, like all our, the ones whom I know, including my father, they all went on to do the PG. But nowadays there is a trend. You do MBBS, but probably you don't get into the PG, and you do something in computer science, and you become a consultant for health informatics or like health information systems or a software company. So it kind of again depends. Or an engineer who wants to quickly grasp the health domain and then get into this. So there is in digital health there is a lot of variation, unlike any other discipline, I would say.
I agree. Lots of variation. Purnima, your thoughts.
So, hello everyone, and I think I'll first apologize for a terrible laryngitis which hasn't healed in a few weeks. But thank you to both the co-chairs as well as Anurag actually for walking us through the lay of the land already, by putting up some really important arguments. And I like the mentor-mentee thing that happened as well. So what I can do here is I think I actually represent a humanization of some of the points that you all mentioned here, MBBS and a PhD, Anurag. So I think when I was trying to think about the theme of the session, do we need a master's in digital health? It actually made me take a step back and reflect on my own journey, both personal and professional. And I think I'm hoping it'll, lead us to an answer that we're looking for. So I trained in clinical medicine and then went on to do a master's in epidemiology and then a PhD in social medicine. I've been working in public health for about 2 decades now. And I think I bring a certain perspective to the work that I do, given the fact that, having studied medicine and, about the functioning of the human body, but then studying epidemiology and what it brings to, designing epidemiological studies to answer questions, but then also learning about how social determinants of health affect all of this. And I think it's brought a certain perspective to the work that I do in public health. So I could relate to what Brian was saying over here. But taking the other lens, my professional experience, I think I've also spent a good amount of time teaching students in MPH courses. And in the last 1.5 days, it was interesting to meet a number of young delegates in this conference who were saying, hello, ma'am, and you taught me in batch of 2018 or 2019 or 2020, and then you strike up a conversation with them and you ask them, okay, what are you doing now? And there was a range of answers. So they're working with the government, or they're working with the CHAIs and the JPIGOs and the JSIs and NGOs, and in a range of domains. So I was thinking, when I was reflecting on the answers for this session, what value addition would a training in digital health bring to people working in the public health cadre in India? And Brahma, I have in the back of my mind the objection you raised earlier when your colleague from Yale was speaking. So if we were to think of a master's in digital health, the additional competencies that we have to think about, everything from the digital applications in public health, or decision support systems, designing them, the hardware, the software, the big push to bring electronic health records across public as well as private health systems, the government initiative for Ayushman Bharat Digital Mission. What is that going to need, I mean, in terms of the workforce that's going to be implementing all of this on the ground? And personally, I feel that we can plug that gap with people who have a strong grounding in public health, but maybe a further deep dive into the narrative that is required, the skill sets and the competencies that you need to meet the digital health revolution that we are seeing in the last few years. And what does it take in terms of the term that was used before, the production capacity? Are we ready for that? I mean, do we have within a institution the capacity to give that grounding in public health so that they have an application-based mindset when they get into the real world and have to be employed in any of these domains that are using digital health applications? And I think it makes me feel that maybe, within a course of masters in public health, do we need to develop a concentration in digital health? Because we've done that before. So by just looking at the cohort or running a survey, do the masters in public health students want more training in health economics, or environmental health, or nutritional health? And then for that cohort, there used to be a concentration in the final year for one of these domains. So is that what we are looking at? A strong grounding in all the principles that we teach within a master's in public health, but then a deep dive with a concentration in digital health, because then you'll probably have a cohort of students who self-select themselves into that concentration, not least because of the passion, but also are aware of what the market is or what their own career trajectory is in their own eyes. So I think the answer is somewhere in the middle. Maybe for now, we'll have to think about the production capacity. We have to think about what the career trajectories will be. The way digital health revolution is happening and evolving, not just in months, I think in weeks the things are changing. So do we have the capacity, like someone else mentioned also earlier before, to kind of tune our courses, our course content to kind of feedback to that need that is there in the ecosystem? So I think the answer lies somewhere in the middle. Maybe we need to start small by thinking about piggybacking on a master's in public health with a concentration in digital health and see where that goes, and maybe then scale up to actually a master's in digital health. Because I think that will be kind of a responsive approach to where we are just now. And happy to take it forward afterwards, but I think that those are my initial thoughts.
So Purnima, one of the very interesting points you brought up was looking at the future. In many ways, both Rajendra Pratap and Brahma, what you did many years ago in Michigan, you were preparing the workforce of the future even though the explosion was yet to come. What the ABDM would do to demands on the public health systems as hospitals digitize, as other people do, but it will not just be public health. There was one thought that came to my mind. If you start thinking of Ayushman Bharat as an insurance before anything, eligibilities, insurance, data made available to people for research, to cooperate, to decide a bunch of things, payment systems. A lot of it will not be public health, it will simply be health. And I think it is very important to think of it in both directions. ABDM as a public health force and ABDM as a health economy force. And exactly as you said, perhaps flexibility in our minds. Are we training them for the health economy? Which will certainly grow. The one place where growth is guaranteed is health economy. If a fraction of that health economy is driven by digital processes, people who use those processes to create efficiencies in a growing economy should be well received in the job market. People who improve efficiencies that don't grow the economy but deliver better health would still rely upon a public health cadre and things like this for the job market. Again, I'm not trying to say anyone is more or less important than the other, but recognizing that they are two different areas. A growing health economy in which you are contributing to the growth, and economic, no more investment coming from the government, simply increasing efficiencies is a different idea altogether. So I'm going to take one last thing from Tanu, because she will bring I think, a perspective of a person who's recently transitioned into this space. And this has been a very interesting time, Tanu, right? I mean, when I was also walking around talking to a lot of people, one of the questions I asked everybody, and if anybody, is, anyway, I know there's a trigger in this area, but the changes that are happening in America, pretty much the collapse of US aid, pretty much diminishing funding for a variety of things that NGOs could take for granted just maybe a few months ago, would have, in my opinion, for the people I'm talking to, there's a tremendous change in impact on the ground in terms of the ability to hire people. Although you and I already had this discussion when we met in Singapore recently. But from your perspective as a young person into the workforce, most of us are well secured and beyond. Tell me what you see as a direction of training that is resistant to these kinds of fluctuations that may occur for processes beyond your control. So I've kind of narrowed down your question a little bit, but want to hear about your thoughts.
Thanks, Dr. Anurag. I mean, such engaging discussions were happening. I was tempted to sit in the audience and, listen to the views. Dr. Brahmer, I'll speak from a public health perspective because I'm part of a public health organization. And Dr. Gupta, I am guilty of being a dentist and a public health professional. So, Dr. Anurag, I was just sitting here and thinking that 20, 30 years back was a similar discussion happening, do we need a master's in public health? Because we thought that doctors know about health, doctors know about the clinical aspects, why is a specialization in public health required? But there was definitely a need for it, there was definitely a need for a different skill set for it. And even at this event, we've been repeatedly talking about digital health, AI. I mean, if only we had $1 for every time someone said digital technology or AI, some of our funding problems might get resolved. But that being said, digital health has been established as an enabler for health systems. Its role is no more questioned. And despite talking about it so much, despite investing in digital health so much, spending countless hours on working on digital health initiatives, it's a little surprising that we still do not have any formal education on digital health. And now countries are everywhere inclining towards digital health. They're either in the process of making their digital health strategies or have even progressed and are refining their digital health strategies. So that need for an expert opinion is always there. And even in my experience, professionals who work in the digital health space, they learn on the job in public health. We don't come with that kind of a background. I personally did not have any background in digital health, and it was a steep learning curve for me. I joined with the Ayushman Bharat digital mission when it was in its pilot phase. And I was put into a room where everyone was talking in a different language. We had people from the IT sector, and they threw words like APIs, integrations, products. I got a little scared. Is it time to look for a new job? It was so overwhelming for me. I came from a public health background. Then we had people from the public health background who were talking about actual public health issues, what kind of process improvements do they want. So the public health person was not able to convey what they need to the IT person. The IT person was not able to understand what health means. How do they turn their solution, more contextualized for health? So, and Dr. Gupta also pointed out, we don't have a unanimous definition of digital health. For everyone, it means different things. So I think those capacities in digital health will actually bring us on a platform to be able to think in the right direction. And at the risk of having an unpopular opinion, what we study in masters, we don't really use in our jobs. But it gives us the right set of mind to be able to encounter new problems and, think outside the box or think in the right direction. It gives us that strength to be able to understand challenges and to be able to look for solutions around it. We have the basics and the concepts very clear. So now coming to your question on how the impact of loss in funding would have on the digital health sector. So the beauty of digital health is that it has both technology in it and it has both health in it. And digital has become an integral part of public health systems now. So you can work on the technology sides of things, and judging by the number of exhibits we had on digital solutions, technology providers are not going anywhere. I think there is enough funding. So you can go on technology side of things. You can go towards implementation or operations side of things. You need to have that kind of mindset on how to implement digital solutions. What kind of challenges occur when you actually go on ground and implement it? Are you able to comprehend what are the challenges of the end users? Are you then able to convey it to the technology provider to be able to solve it? Then digital health also has applications in policy. What does a digital health policy for a country look like? These are areas that need some expert capacities. We also have research. We have so many new technologies coming in related to AI, emerging tech, and so many other things. So who will do all these things? It's someone who has the right background, who understands health, and who also understands IT would be able to, work in such a space. So I don't think that it will be a huge problem for someone with a skill set in digital health going forward, even if the fundings are cut, because digital health is so adaptable, it has applications across sectors. So thanks.
I want to go to Brahmer here for a second, because I think one of the things that you just said resonates well with what she started with. That you have to be trained to solve certain types of problems. It is that ability to solve specific problems rooted in technology or data science or something like this that is cross-operable, even if the health side, public health implementation side funding drops. So if I were to imagine two types of health workers, one who is more just a consumer of things on the health side versus one who is capable of deploying, evaluating, clearly in the scenario you're saying, it goes closer to what Brahmer is saying. So Brahmer, back to you for a comment on this, then Rajendra to you. I know you have to leave at 6:15 for a board meeting, and then we will continue the discussions.
Yeah, so thank you so much for this wonderful discussion and for various diverse set of perspectives. So first I want to make a public statement that I'm the Senior Associate Dean for Public Health Data Science and Data Equity. So by no means I'm criticizing public health education. So I'm just giving people a hard time because I sincerely feel as a professor that's my job. So I do want to say that I was a math major, right? Like I studied mathematics and I studied statistics. I really did not like people. I was much more happier in a solitary room with pen and paper. And I was not doing earth-shattering mathematics. My first job was in a theoretical department in statistics at University of Florida, and it looked like I would not get tenure. And I moved to University of Michigan School of Public Health, and something clicked. Data started narrating stories, whispering stories that I was translating into equations and models, and that gave meaning and purpose to the technology. And I do think that without that spark, I would be an ordinary mathematician and an ordinary statistician, but I was very good at working at that intersection of health and mathematics and health and education. And that's exactly why I commit to School of Public Health. I have been a professor for 30 years in universities. Schoolhouses are my cathedral of learning. And so I completely assent to the mission of public health. So let me clarify that. And so I was a math nerd. My dissertation was in stochastic processes. I did not do anything on health till 2006. But then I continued to teach myself when I got exposed to problems that how to solve these problems. So I must have learned something in my education that enabled me to solve these problems in a meaningful way and communicate that finding to the public instead of being a completely incomprehensible and incoherent mathematician. So I do think that this is very important to do this work and really have well-rounded training. How do you teach people? Do you teach that through a degree? I personally feel in my students what I'm seeing is really dissolution of boundaries. They get admitted to statistics, but they take courses in computer science. They take courses in philosophy. We cannot forget that one derivative, statistics, is obviously a derivative of mathematics, but also epistemologically related to philosophy, modeling natural phenomena. Without this broader understanding of how the world works, how humanity works, I do not think it's important, like it's even possible to dream of solving a problem. So I really want to bring that liberal arts education into everything that we do. I'm so proud that every session in this conference had a focus on health equity, a word which is being constantly debated in today's US education. And so I do believe digitization is the only way to achieve health equity in India. It is the only way through which urban and rural divides can be dissolved. If you look at any hope of getting digital data or representative data, 75% of India live in rural areas, 10%, less than 10% of the data come from them. We need to learn more about health, well-being, and human flourishing in areas which are unseen. So for that, digitization is absolutely critical. And people who have the dream, that altruism of translating this data into stories and compelling narratives, we need to train them. And I simply do not care whether it's through a degree or through it in a classroom by a magical course. I do not know, but I want to ignite that spark in the mind of people to see that it's important to solve problem, and it is important for quantitative people and technological people to improve the human condition.
This sets up perfectly for the question I actually already had in mind for you. Of the cohorts of people that, because when Brahma is speaking passionately, you can hear a quantitative person trying to solve health problems and doing well at it. My personal experience has been the vast intake, and you alluded to it when you talked about the typical incoming cohorts. In India, we have not yet seen quantitative people trying to do biology and medical. We have seen more medical people or people in biology things trying to learn the data science part. In your experience in digital health, the type of classes you are seeing, are you seeing quantitative people who want to learn about health, or is that still a minor fraction? And if it's a minor fraction, how do you think we can make it grow?
So first, I will dwell upon how this field of medicine itself has evolved. So if you pick up from the 19th century or 18th, whichever you may say, it started with biology, became chemistry-led, physics-led, where your medical devices came, is now maths-led. But what is future, we don't know. So the courses have to be aligned with the evolution of medicine, that's one. On the courses that we run, 85% of the people who take our courses are doctors. We have CEOs, a small number though, and then we have technologists which are there. So I think for us, it's mostly MD doctors, and they are 85% of my course. Yeah.
Do you see any change in rising interest with the quantitative tech people wanting to do this, or it's been static?
So we have had people who came with, so the best part is those who join our course are already into job.
Yes.
Yeah. And what we have seen as a change, I mean, I always look at, what impact did we create through the course that we do. So we keep talking to people. So I know there was a head of TCS who joined us. He's now been assigned to look at digital health in the United States. There's someone who joined as a director of Pfizer, now leads digital health in Pfizer. Someone who started a digital health company. A doctor who started building technology solutions. So I think I have seen people learning it and going. Technologies are very rare, I think, who have joined. But once they've joined, they've actually made the use of it.
Fantastic. Yeah. Thank you so much. And at any point, that you need to go, I know you have a board meeting, please feel free. So I'm going to now switch back again and continue the same point. If we were to define digital health, let's say differently. One is, one way you can think of it is today's health delivered more efficiently by digital means. That's one way of thinking about it. We're all in public health, that's the most you can do. Because you cannot fundamentally change what health is. The technologies are, you can just try to make it more efficient, better by using digital. But there is another version of digital health, which has been used by some people in the books they write. Imagination of what health will become, that's more aligning to what Rajendra Pratapji is saying. What health will become in a digital age, perhaps within 10, 20 years when babies are sequenced when they are born, what health will look like in the future. To your mind, and I know this is slightly unfair, Brian, because you have said very clearly you're going to bring a public health perspective to it. Do you see this preparation for the future when these technologies become less expensive and routine? Because, for example, if people in public health did not look at genomics 25 years ago because the cost of sequencing a genome was still in the range of $100,000, then we wouldn't necessarily have built all the technologies that are now being used in public health. So is it fair that even if the interest is public health, preparing for the rapid changes in technologies would still align? What I think the ethos part that Brahma is saying, the ethos may need to come from public health, but the technological readiness might come from more futuristic fields. I'm not saying it's not futuristic, but clearly it's different.
So as I've been sitting here, I've kind of been reflecting on what is public health, and I don't want to be the person who suggests an hour into a panel discussion, well, what is public health? But I will do that. Public health is preventing disease, prolonging life, protecting health at a population level. And so I think unless we're talking about an individual, a degree that allows you to do that, which would be an MBBS, a degree that would allow you to do it on a one-to-one basis, address health, an MBBS or an MD. Really, if we're working anywhere larger than that, we're working in public health. And so I think digital tools and digital health is really a way of delivering at scale and potentially at greater scale public health. And so I think this distinction is maybe a little bit of a either a distraction or a road that maybe we shouldn't go down, because ultimately, again, unless we're focusing on a one-to-one relationship in terms of addressing a health issue, we are talking about working at population levels. And so I don't see digital health as a separate field, as a separate discipline from public health. And I know that we're all, I think given that we're here at the World Health Summit, we are all focused on addressing health at a population level. I see digital health as a set of tools, approaches, capabilities to enhance our public health practice, and to do so across multiple domains. And to your point, Professor Anurag, as digital tools and technologies advance at a rapid pace, the exciting thing is that that allows us to address population level health challenges at a rapid pace. And Brahmer, to your point, it also allows us to address health equity issues at both a rapid pace and at a rapid, at an expanded level. So I don't want us to get into this discussion about whether or not digital approaches to health are a part of public health. I think they most certainly are, and they are tools that allow us to expand what we are able to do in public health. And in years to come, even more so.
I guess I could have been clearer with my question. So what I was asking was, because you exclude that very early, individual level health. Individual level health is probably not public health. But many of the cutting edge technologies of precision health are individual focused. We can have precision public health, then you can have simple precision health catering to the individual. The challenge I see, and I think these are high value things being done, right? I mean, they are not really generalizable to the public.
Sure.
But in them lie the roots of what we will do 20 years down at a public scale. So now, to maybe perhaps have sharpened my question a bit further, would you see investment into people training into individual scale expensive healthcare that is not scalable today, but might become scalable tomorrow as a useful goal towards future of public health?
I'll tell you a little bit of a journey that I went on in my thinking around this. There was a term that was discussed a couple of years ago, precision public health. And initially when this term was being used, and it was being used, I think, in the context of digital health, when I first heard it, I said, that's an oxymoron, right? Precision is antithetical in some ways to the population level impact that we are trying to have when we work in public health. However, as I've thought about it, and especially with the innovations and the development in all of the different AI tools that we have at our disposal now, and as they continue to develop, I began to think more that our ability to provide precision level care at a population level was becoming more and more feasible, and fully now buy into the idea that precision care can be delivered at population levels through emerging technologies. And I think that that kind of upends the way we think about public health. It should be changing the way that we think about public health education. And as a part of that, I hope to see training programs incorporate these kinds of approaches. And I want to say, Tanu, to your point about master's programs not necessarily including things that are applicable, I think a challenge in education and public health education in particular is that we're teaching either the approaches and the challenges of today or even of yesterday, and we need to be more contemporary with how, not even contemporary, we need to be in hockey, we would say you need to skate to where the puck is, or where the puck's going, not where the puck is. And so we need to be thinking about, in terms of our teaching, teaching where the puck will be, not where the puck currently is. And that's a big challenge for us in academia, and something hopefully that the academics on the panel today can work to address.
You're clearly from a cold climate with ice hockey. So, that said, shall we open it up to the room for questions or final comments, probably from your side?
I just want to make one comment, and I am an academic, Brian is an academic, and we teach our students to become academics. That's what we teach them. And that's a huge mistake, I think, that we really need to teach them skills that are going to be useful in other industry. They often say that, right? Like we always, that's what we know and that's what we teach towards. So just 3 weeks ago, I was at the Google office in New York. And this is an event called Google Health Checkup. For 1.5 hours, the different teams at Google, DeepMind, Fitbit, YouTube, they were just presenting the products that they're going to launch. One of them was the new Google Pixel Watch. If it senses a loss of pulse for more than 15 seconds, it's automatically going to call 911. And this is life-saving, right? If somebody lives by themselves or this is happening in their sleep. Similarly, alerts for epilepsy. When seizure is about to happen, the watch can alert you so you can pull over your car if you're driving, or you can turn off that gas stove, because most of the accidents and fatal events from epilepsy happens through these secondary events. So this is life-changing, right? So after sitting through the whole presentation, and the whole presentation was so beautiful, there were no slides, and people were doing high fives and a team spirit. And I was like, what am I doing in academia? These boring slides and equations. And I was literally depressed and crying there, almost like in tears. And then my students are also making 3 times the more money. So then 2 of my former PhD students who are working at Google, they came to me, said like, Brahmar, why are you so sad? I said like, I don't know, I don't think like I'm doing good research, and you guys are making 3 times more money than me. And they said, Brahmar, but please understand that you are at an university, and one of the biggest contribution of a university is to create individuals who can contribute to different sectors in meaningful ways. You created us so that we can work for Google and make money. And so I had no response to that, but I felt better, right? Like I contributed to human resources. Some people are happy, some people are rich, some people's lives are changing. And I think that ripple effect of teaching people sparks and skill sets so that they can go and do big things. We should never lose sight of that, regardless of which degree we call it, which discipline we call it.
Fantastic. And with that, I think the perfect time for any questions from the audience. We'll start there first. You, then you, then you.
Hello, Brahmar. Suchandrama this side. I am the data lead for Khushi Baby, a Yale startup. Now, one of my reason of attending this session is because I did wanted to hear what all of you say. And my personal reason is that I'm currently building a team where I lead impact and data in a digital health company, where if you ask me, I would say as things go digital in health, the difference between health and public health kind of collapse. The precision becomes at population level. So I get these people who are all engineers. Like if you talk about ABDM, they will say API integration, this gateway, HPIs, HIIs, HFS. So, and then there will be people, I have a PhD in demography and biostatistics from IIPS. And then I was like, okay, all that is good, but how do you measure it? Like, what do you do it? And then there will be all these Cornell data science people who will write a sandbox of SCAFX model, this model, that model. And I'm like, but who will explain it to the district collector? Like, where do you put the ambulance and where do you save people from having maternal deaths? So, and then nobody knows. And then there are these poor BHU past statisticians who probably has the answer but doesn't have the communication skill, that I need to run a cross tabulation and a t-test to show that it makes sense that yes, this thing is working and this thing is not working. So my question is, when you say, I see the need for something to teach a togetherness of this and each people to understand the other people and admire that they bring something to the table, but who is going to do that? Like when you say a course, when you say something like that, who is going to build that? Like what kind of people are going to mentor it so that, because they also need to know all the aspects of it, so, and respect each aspects of it. So that's like when I'm bringing this digital health concept, I'm like, how do you do that? And then who develops their communication skill not to use those fancy sandbox experience, but to actually translate them to basic IC material, which you take to government and say, boss, यहाँ पे problem है. This is the problem I need, this is the solution. So just wanted to know all of your opinion on that.
Thank you for this question, and thank you for the outstanding work that Khushi Baby is doing. I was fortunate to be part of your 10th anniversary celebration, and a classroom project that originated 10 years ago at Yale, having this much impact 10 years later is just quite remarkable. So congratulations on that, but how do you teach people these? It's extremely hard, right? As I said, a lot of things we actually learn on the job, but we have to have the mindset to be receptive to other culture and growing. So I'll tell you that when I first went from a hardcore math stat department to Michigan biostatistics, I was in a collaborative meeting with a cancer researcher, and I basically just did not respect his science at all. I just said, well, this is my X matrix, and I'm going to do sparse PCA on X prime X. And I had no respect for what the rows and columns of that X matrix was. This is who I was. I'm just like an honest confession. So he called me after the meeting to his office and said that, Brumar, the rows in this data set are people that I see in clinic every day, and then columns are biomarkers that I have spent my entire career on. So please pay respect to the rows and columns as much as I pay respect to the sparse PC or whatever you're going to do with the X prime X. And that changed my perception, and that I have not forgotten. He became my very close mentor, and we ended up in writing 50 papers together. But that daily learning from another scientist, how to promote that culture, I do think my presidency college education really helped me. This liberal arts education of sitting under a tree and talking to a physicist and a philosopher and trying to understand what is going on in their life, their courses, what is the economic theory. Actually, this is all tied, that general curiosity. So I do not see, and I have to say that when I went to ISI, it was a much more specialized education and a specialized excellence, but often that specialized excellence drives you into a rabbit hole and you lose interest in other factors of science. You're just in your world. And that's fantastic, but we do need to, and people who are happy doing that, they should be happy with that. But I do think that we need to cultivate this culture of liberal and also very compassionate dialogue, and that should be a part of our education, that how do we actually listen to problem. And I do think that 3 C's are essential in any kind of job right now: competition, communication, and collaboration. These 3 C cubes are really essential. Regardless, that's why I think computational literacy and digital literacy is part of a medical professional's job, and similarly learning about health, if you are working in health informatics, is the responsibility of a computational scientist as well. So I don't think I have good answers for a curriculum, but I just think that we need to promote and encourage and reward and incentivize genuine curiosity and genuine drive to solve important problems.
Anybody else wants to come in on this very important question? Can I say one point? So if you want to be a researcher and study to be a researcher, some of the best researchers to, the best way I think to, is there an echo? Thank you. If you want to be a researcher, the best people to study under are the ones who are at the cutting edge of research. Public health is unique because it's a professional practice. And to do an MPH is a professional degree. And so other professional degrees, MBBS or MD, you would be learning from people who are both teaching and practicing. Same thing with a law degree. You would generally be learning from people who are both practicing as well as teaching and sometimes doing research. I think in public health, we need to be doing better about encouraging practice as well in those who are educating potential public health practitioners, because it's only going to be when you are at the forefront of practice, when you're at the forefront of research, that you can educate those who want to be doing practice and research. And so within the digital health domain, those who are practicing using digital tools, or those who are doing research with digital tools, I think are going to be the best educators. And I also think that we need competency frameworks that include both practice and research that incorporate digital health components within them, and not just in one piece of a competency framework, but throughout. And so to your point around how do you have a workforce that can communicate around digital interventions, that should be covered in a professional program that has digital health competencies, that has a competency that incorporates digital capabilities into them.
So I was just reflecting on what Brahmer was saying very passionately a short while ago, about being responsive in a futuristic way, what the needs are for a country like India. And I think she was right. I mean, it's such an rapidly evolving ecosystem. And I think we definitely need to have that workforce and a cadre of people who can kind of plug the gaps for a situation like that. The question is actually, pertains to what you were asking. Who's going to do it? Who's going to build a course, whether that's a master's in digital health or a master's in public health with a concentration in digital health, so that we are building that cadre in the right way, in a very responsive way, in a timely manner. I think also being cognizant of the fact that it's an evolving space. Somebody was asking, do we have a textbook in digital health? So I don't know. I mean, there's going to be several lenses to this preparedness to respond to digital health revolution in India. And I think it's going to take a very interdisciplinary approach to do this. It's probably because you're going to be talking about digital health applications. We have to train on data confidentiality. What are the regulatory processes in India just now? There is no standards, actually. I mean, is there a regulatory standard to the digital health evolution that's happening? And, with AI and all of that also happening in the background, where are we going with all of this? So I think it's going to take a very interdisciplinary set of people to develop a course like this and keep it very flexible. I think we've already agreed on that. If we go that route, it has to be something which is flexible and can kind of respond to the evolution that's happening, not at a pace that one person or one university can respond to. I think it's going to be a very responsive and cognizant group that's going to be able to respond.
Yeah, I'm Ashish. I'm a computer science person who now works in digital health. And I just wanted to kind of, as I was reflecting on this session, what Tanu said, that you often learn on the job. And Brahmer, thanks for standing up for the tech people who want to get into digital health and hopefully impact public health also. As I reflect on my own journey, we often get excited about technical problems, but when you actually do meet with doctors, you often understand that your understanding is often quite shallow or is not how the real world works, especially on the field in India. So just a suggestion maybe that as we think about a degree in digital health, maybe a clinical immersion where you actually spend time in a hospital or on the field could be a way. And a similar IT immersion for people coming from a health background to kind of learn terms like API or containers or whatever, what have you, or the latest AI model. So to get these people to be kind of become bilingual and talk each other's language would be my suggestion.
Idea would be universally well received. One question from that, I think you had that question, right, please?
Me. Okay. Okay, thank you very much. And firstly, I come from the other side. I'm a physician and transitioned into digital transformation. And with digital transformation, I don't mean digital health transformation, because apart from supporting the digital transformation for Ministry of Health, I am supporting a project for small and middle enterprises in Central Asia for UN. So I feel that the lens of digital transformation, which I picked up and I self-learned through it, it opened several avenues, as Tanu highlighted. And it aligns with my passion for the field as well. So I mean, it's a win-win for me. So my journey of this transition, it led me to found Cyber Health Academy. So it's a training academy, and we help in the immersion which our distinguished delegate talked about. So this immersion for healthcare professionals, and it is quite, I've trained different cohorts. I've trained a bunch of pharmacists, I've trained a bunch of epidemiologists, I've trained a bunch of MBA students. So for them, I mean, of course, I've received excellent feedback, because for them, in their routine academic life or a routine professional life, for them it was a refreshing course, because these are all hands-on sessions, and with IT it's quite easy. You just need a laptop, and everyone in the class is up and running and doing that. So what I want to ask, because especially with a limited team which I have currently, I want to create maximum impact. So I want to ask from all the experts, which cohort you think will produce maximum impact in public health landscape? So that's what I.
So while I let everybody think on that question, let's take one more question.
Yeah, thank you for the opportunity. Thank you.
Hello, I'm Dr. Ramesh Gandhi. I'm member of Communication Working Group in WHO Civil Society Commission. So it was very interesting to see the discussion happening on the one side health domain and the other side tech domain. I'm reminded of an incident, a conference organized by Reserve Bank of India, when the chairman of ICICI Bank, he was asked similar question, that whether you are a banking sector or you are a tech sector. So the chairman of the bank said that we feel that we are a tech company providing banking services. And coincidentally, my brother is in a company called TSYS. They do the entire tech thing, which when you put your debit card in an ATM and it comes out, there are hundreds of checks which happen within seconds. So that neither bank can do, nor any only tech company can do, because it's all integration. So what Dr. Purnima said, that the solution lies somewhere in between. And see, this sentence is very important because now you see that banks are there, tech companies are there, and now the solution has come in between fintech companies. They create the solution. They understand various currencies, whether it's dollar or euros or rupees, what conversion, everything they understand from bank. Then they go back and they discuss with their tech people and they create a solution and give it to banks, and the entire ecosystem is evolving. So I think the answer is already discussed. The ecosystem is evolving, and the central part is the coordination or convergence. Who can do best convergence and in shortest possible way will lead the revolution.
Thank you.
That is my observation.
Let's
Thank
take
you.
the last question from there.
Okay. I'm a management professor. I teach business management to MBA students. This conversation is a deja vu for me. 25 years ago, when I started my career, I had a conversation about should there be a digital business? Should there be MBA digital business? And the first question that I asked at that point in time as a young academic was, can business survive without digital? And then the consensus happened, and there are a lot of IIMs which went ahead, and one of the IIMs actually went and started a computer-aided management course. And believe me, it lasted for 3 years. From 1999 to 2002, 2003, the IIMs shut that course because there could not be a management course without a digital course. 2005 comes, Supreme Court created an Academy of Law, and they also discussed the same argument. Should we have a digital law? Can there be law without any digital? Can there be law without AI? Can there be law without any technology? Is there an option? My question to all the panelists is that, can there be a future where healthcare is provided without digital, whether it is precision, whether it is level of individual level of analysis, group level of analysis, community medicine, public medicine, population medicine? Can we escape digital? If that's going to be base, why are we even talking digital health? Every healthcare, every program, maybe we should have it in the second year of MBBS.
Excellent point. Anybody want to know the two questions? One is, we already agreed to the point that you made. If there's any cohort that comes to your mind that is particularly good, that needs to be trained, that's one question. And the other one is, do we see any version of, do we think that health will already become digital health? That I think is the second question.
Can I answer very quickly to both? Many different cohorts. Public health is multidisciplinary, and so we need digital competencies across both. No. we need digital. There's no health without digital, so you're absolutely right.
Just to add to that, yeah, few years back I was part of a Medical Informatics Association. So we tried really hard to work with the Medical Council and then see if this could be part of the curriculum. It was not possible at the time. And then the same thing we tried with other, of course, out of the country also, because these curriculums are already overloaded. That's what they feel. To bring in digital health was difficult at the time. Probably now it should be possible. And then to answer your question, like for example, in the medicine, I find the radiologists are the first ones to take because their profession, their daily workflow is like that. So you could look at others who do not generally use that kind of a system, digital workflow, and then take them. That's the way I would say.
That's a nice way to answer. With the bell ringing, I think they're telling us to now vacate the room. Any final words, Brahma, as we move out?
I just want to end on a note of gratitude to Ashoka for putting together this panel, and for Anurag and Aradhika for getting us organized, and really congratulations for the excellent work and the new ideation. This has been an extremely edifying afternoon. Thank you so much.
Thanks to everyone. Thank you to the audience for staying so late. Thanks.